So he has quickly, within 30 seconds, given clear instructions to everyone. He's not saying, hey, someone do this. Can someone do that? No, he's giving clear instructions. So even though all three of them can do any of these things, right now he has given a particular instruction to Dr. Divya, so she's going to do that. He has given instruction to her. So you don't have two people coming in here and one person there, so there's no confusion. So clear instructions by the team leader is very important. So he has given clear instructions to Dr. Divya. Now again, the instructions are very clear that come over, open the mouth, check the airway, and if required, take any action. So she has come there.
I'm doing the chin lift and jaw thrust maneuver. And after doing the maneuver, I still feel there is obstructed airway, and so I decide to intubate the patient. So
right. Okay. So pause. So because she was given clear instructions, he came, did the chin lift and jaw thrust, and realized that this is not good enough. Patient is still not breathing. I need to do some action. If after doing the jaw thrust, chin lift, patient had started breathing, then she would have done something else. She would have maybe put in a Gudel's airway. If patient's consciousness level is better, then maybe even that is not required. Just oxygen could have been given, or maybe nothing could have been done. In this situation, she decides that I am going to intubate the victim. So now again very important, here we are doing one by one, but actually what would happen, three people have been given instructions, all three are doing the things at the same time. So as you can see, Dr. Anwar right now is
pulse is 140, 70 by 6 and I am putting the camera and I start investigation.
So he has done his stuff, that is, he's put in, checked the PP, pulse, put in a cannula, taken blood samples and started IV fluids. So he's told to do these 5 things, he's done those 5 things. He's not worried about the rest of the thing. So he is doing his job. So she has stopped the bleeding and splinted the leg. And she has finished the intubation by then. So now what happens?
Dr. Manju, please come and help Dr. Divya. Since you are done with you control the bleeding, help Dr. Divya. And Dr. Divya, please reassess the patient.
So now he has given instructions to Dr. Manju to come from there. She did not come on her own. He gives instruction that come, now help her. And she is holding the bag. इस तरफ आ जाओ दिव्या, इधर से कर लो जरा. आप भी मंजू थोड़ा साइड में जाओ, उधर से वीडियो बना रहे हैं ना. Okay. So now all three have done what they had been asked to, and Divya's work is continuing. So what she did is, after this, she has checked that the airway is working, the respiratory rate is fine, and then she moved on to inspection, palpation, percussion, auscultation, and she is coming to a conclusion. So Dr. Divya, what have you found? Adip, idhar aa jao. Idhar aa jao.
So from I can see the breathing is less on the right side. On percussion there is resonant breath sound, and on auscultation there is decreased air entry on the right side of the chest. So I think it's a tension pneumothorax. So I'll take a whiteboard label, and then on the second intercostal space in the mid-clavicular line and insert the label.
So she came to a conclusion that there is a pneumothorax on the right by the systematic. So we have moved systematically and we have come to that conclusion. So Dr. Abhishek, attendant wants to know what's wrong with his sister. He's going on.
Dr. Anwar, please arrange for the chest tube.
Okay. So now this part is over. Now as soon as the collar was applied, he has become free, because till then he was holding the head. As soon as the collar has become free, he has got free, and now he has taken the torch.
Okay, so I'll check the people now. People reflexes are okay. And she response is there for painful stimuli.
So now, Dr. Arwa, yeah, we will do a log roll. So Dr. Manju, for a moment you disconnect the bag, we will do log roll and do the
Idhar se,
examination of
idhar.
bag. On the count of 3. And Dr. Manju, meanwhile you check the spine. And then you check the bag. At the count of 3. Ready? 1, 2, 3. Okay. 1, 2, 3.
Now we'll not do it, but we will normally repeat the same on the other side. So what we have done are actually 25 maneuvers, which we have done a total. We will give you a printout of this, also send it to you on your WhatsApp, the PDF. And these 25 things are what everybody would have done anyway. But what is the different is that we have done it in a systematic way. He has given instructions, like some person has done 4 things, someone has done 5, 6, and in effect, this entire exercise can be finished in 1 minute if everybody is working in coordination. The same thing can take half an hour if we are not coordinated, and we might miss. You'll go home and think, oh, अच्छा वो 23rd चीज तो मैं भूल ही गया था. So that is what is important, that we treating trauma victims should know that we have done everything in a systematic manner. After that, whether the patient survives or dies is not in your hand, but you can go home thinking that yes, everything correct was done for this patient. So if we can just sit down, I will go through some slides of what we did, and later on, like this time we have seen. And should we do this once more? After the lecture, maybe we can do this once more in a fast manner, because later on during the day you will be doing, we will be watching. Okay. So यहाँ पे B, when the slide show is going on, if you put B, it goes black. Exit करो. So as we were talking, now this, I can forward the slides with a pointer. Then I can come there.
USB लगा हुआ है, ये नहीं लगेगा.
अच्छा अच्छा. Okay okay.
क्योंकि एक ही USB.
Okay okay fine. Just give my phone to her. बीच में phone आ जाएगा कोई. Okay, so as I was talking that things can be done in various ways. So there are many plans, many books, many things which tell us how we can do things, but we need to have the same protocol followed by the hospital doctors so that everybody does it in a synchronized way like we saw in the master scenario. So there are 25 points which we have got, and this is what we were trying to discuss. So firstly, remember your patient is one. So treat the patient as one, not in various parts. So first thing, as you saw, what was done was talk to the patient. So you talk to the patient, check, is he breathing? Is the airway obstructed? Is there need for advanced airway management? So this is what Dr. Abhishek did. The moment he came in, within 10 seconds, he had the decision if any of these 4 things have to be done. So this is our PTC position: look, listen and feel. Then after that, when we say A was represented by Dr. Divya here. So she came, cleared the mouth, did a jaw thrust and decided whether any of these is needed, and spinal care has to be taken. So first thing you do, check for the airway, because what happens, an unconscious patient, the tongue can fall back and block the windpipe, and we do what is known as a jaw thrust and a chin lift. This is something which we cannot do in a trauma victim, because if you do this, you can actually injure the spine. So what we do is a modified jaw thrust. So you can see, if we are going to do this, you might injure the cervical spine. So we don't do this, we do a modified jaw thrust, where again this is a maneuver which we will teach you in your stations, how to just lift the jaw forward and not do this. So just by putting your fingers there. Then if required, we put in a Gudel's airway. We will teach you how to put this Gudel airway. Gudel airway is something which is a very simple device and it can save lives. There are types and types of collar. You should be familiar with the collar you have at your hospital. Then when it comes to action, whether any of these is needed, in this particular case we needed number 3. So we have reached till number 15, if you can see. 5, 6, 7, 8. Then 9, 10, 11, 12, 13, 14. Decompress the pneumothorax. While this was going on, 16 was being done by Dr. Manju and 17, 18 were being done by Dr. Anwar. So all this is going on simultaneously. So if we find that the victim is not breathing and there is no pulse, you go for a CPR. At the same time, what he did was he put in a large bore needle, took the blood, started the IV fluid. So we have come to point number 21. Dr. Abhishek by then had got free. So he checked the pupil, checked the awareness. Very simple formula we gave is an AVPU. Awake, response to verbal command, response to pain, unresponsive. In our MBBS days, for the exam we learn Glasgow Coma Scale. You learn one night before the exam and you forget one night after the exam. This is very simple, AVPU, and it conveys the message what we need. Then patient is undressed for thorough assessment and you do a log roll. After log roll, you go on to secondary survey. So the primary care is these 25 points. Secondary survey becomes, head to toe examination, where you're examining the head, neck, everything one by one. So that's the secondary survey: head, neck, chest, abdomen and limbs. When we talk about log roll, why do we say log roll? Because you roll the person like a log. Like the log is being rolled so that there is no twisting of the spine or any injury. So during the log roll, again the team leader is in charge, gives clear instruction: 1, 2, 3 roll, 1, 2, 3 roll back. Then comes secondary survey, something which we will have during our lectures. So with that we come to the end of this, and should we do one more quick demo? Dr. Abhishek?
Yeah, sure.
Okay. So Gauri, can you come once more? Can we have the top lights on? And as there are not many people, you can stand wherever you are. Sorry, if you tell me, I can also switch it. Okay, great. So we'll just follow those 25 points. So somebody's been brought in from the roadside accident. Dr. Tiwari, team leader, will take charge.
Hello, how are you?
1.
What's your name?
Look, listen, feel. 2, 3, 4.
Okay, so the breathing is rapid and shallow. Dr. Divya, I need your help. Can you please assess the breathing? She might need intervention. Dr. Anwar, can you please check BP and pulse? Put a wide bore cannula, 2 wide bore cannula, blood for investigation and IV fluid. Dr. Manju, can you please check the right foot? I can see there's bleeding. Stop the bleeding and put a splint.
So he's given clear instructions. Idhar se. Please come this side. इधर ही आके ये पाँव लेफ्ट
Let's do it left foot, no problem.
लगा दो स्प्लिंट लगा. So everybody is working together. Airway breathing has been done. She has stopped bleeding. He is checking the pulse BP. After they have finished, then
Okay.
So I have assessed the airway and I have performed the maneuver of chin left jaw thrust, and still I think the airway is obstructed. So I decided to intubate the patient.
so next she intubates the patient, and by then others have finished their job, so they will report to the team leader. Dr. Anwar.
Pulse is 140, BP is 70 by 60, and I put IV camera, IV fluid start, and investigation.
Dr.
Dr.
Manju, you control the... So can you please come and help Dr. Divya
To apply this.
to apply? Ajo. Cervical.
So she stopped the bleeding, applied the splint. He's taken the pulse BP, applied the cannula. So you can see the collar which was there, number 7, has still not been applied. But that doesn't mean the importance. So importance wise it still remains there. It has not been applied because Dr. Abhishek is the collar right now.
So I have again assessed the airway of the patient, and I have inspected, palpated, percussion and auscultation has been done, and I found out there is resonance on percussion, there is resonance on the right side of the chest, and on auscultation there is decreased air entry on right side. So there is right pneumothorax, and so I will take large bore needle, IV needle, and then I will insert it on the second intercostal space mid-clavicular line. And Dr. Anwar, please arrange for the test tube. I will insert the chest tube.
Okay. So now
Okay. So collar also applied now, and I will check for the response. So the pupils are reacting to light, and she is responding to painful stimulus. And
so at this situation he had the choice. He told Dr. Manju hold the bag while she is doing this. After that he can tell her that okay, now that you have done the airway, put the collar, or she comes back, holds the bag, and he tells Manju that you put the collar. They have to follow whatever instruction the team leader is giving. It shouldn't be कि अच्छा मैं collar लगा देता हूँ या आप लगा लो. Team leader को follow करना है.
And now we will do the examination of back. So Dr. Manju, you when they are examining, can you please examine the back and disconnect the ambu for a while on the count of 3. Dr.
So he's given very clear instructions to her that when the log roll is happening, she has to disconnect the bag, check quickly, and then come back and reconnect the bag.
Count of 3.
Jaldi se. So she is disconnected the bag, quickly gone to the other side.
1, 2, 3. Okay.
Okay. And then she has come back quickly, reconnected the bag,
1, 2, 3.
and then the same thing we will do on the other side, and this is done in a systematic manner. So we've completed all the points. Even while I am explaining it, hardly took us 2 minutes. So thank you. I think we will move on to the next part of the program. which is, we have the program. Next is the talk on airway and breathing. Okay. You have the slides here? नहीं आपके पास है?
हाँ आ जाएगा.
Okay. I'll take out my. आप मेरा पेन ड्राइव रहने दो उसी में.
ठीक है.
I'll use for my talk. Next one. ये वो उनके पास भी है. दिव्या ने मॉडिफाई किया है. अच्छा ओके सी ये इट्स हियर. शी इज गॉट इट ऑन हर पेन ड्राइव. ये लगा लो. मैं अपना पेन ड्राइव निकाल लेता हूँ. आप लगा लो. प्रोग्राम कहाँ है इसके बाद ये मेरा फोन.
कैसे चेंज करना है इससे ना, यही वाला से ना, या इससे कर दूँ, ये इजी रहेगा. Good morning everyone. So today I'll be telling you about airway and breathing in PTC course. So not needed. Yes. हाँ चल जाएगा. Thank you. So after the lecture, you will be able to understand the structured approach to airway and breathing, and you will be able to recognize and manage airway and breathing problems. So suppose we take a scenario in which a 25-year-old man falls off the back of a truck and hits his head. On arrival to your hospital, he is unconscious and he is breathing noisy. So what questions should come to your mind while you are assessing the patient in emergency? So you should think of how will you assess his airway quickly. What are the signs of airway obstruction? How would you open his airway, and you have to immobilize the cervical spine, how to do it. So while assessing the airway, we have to immobilize the cervical spine, and we have to see whether the patient, we have to check the responsiveness, first thing which we have seen in PTC. Then we have to check the airway. So if you think the airway is okay, patient is breathing okay and patient is talking, then you have to simply give the oxygen to the patient. And if the airway, you think there is an obstructed airway, you have to open the airway and then you have to apply oxygen. You have to assume cervical in all primary trauma cases. You have to always suspect cervical spine injury, and excessive movement of cervical spine should always be avoided, and it can lead to paralysis to the patient. So what are the basic techniques? It is the manual immobilization which we are doing initially as you have seen in the scenario. And other thing, as you have seen, after intubation, I have applied the cervical collar to the patient. And if cervical collar is not available, you can use sandbags, you can use tapes, as you can see in the picture. So look, listen, feel. In airway assessment, what we have to see? We have to see the consciousness level of the patient. We have to see whether the patient is cyanosed, or whether the patient, what is the color of the lips, and what are the colors of the face of the patient. So through skin color, you can assess the oxygenation of the patient. You have to see the chest movements, respiratory distress, any foreign body you are suspecting. Then you have to listen for the noisy breathing or stridor. and you have to feel if there is rib fracture or any lung trauma. You can feel the tenderness and crepitus. So what are the signs of obstruction? As I have told that the patient, there may be snoring, various sounds, gurgling, stridor. Then patient may be agitated. Patient may be agitated because of hypoxic injury or hypoxia. Patient may be using accessory muscle while breathing. That represents respiratory distress. Accessory muscles, it could be sternocleidomastoid, intercostal muscles. Then paradoxical chest movements and cyanosis. So this is the technique, chin lift and jaw thrust, which is used, and you can see there is cervical stabilization has been done. Manually cervical spine has been stabilized, and then we have performed this maneuver. So what are the airway adjuncts? So most common cause of airway obstruction in any unconscious patient is tongue fall, and that can be managed with the help of airways. So you can use oropharyngeal airway or nasopharyngeal airway. So in picture you can see first one is the oropharyngeal airway, most commonly used, that is the Goodell's airway, and nasopharyngeal airways. Then oxygenation through bag valve mask. Then there are also various advanced techniques which can use. If you don't know the intubation in emergency situation, you can use laryngeal mask airways, supraglottic devices, eye gel. These are used during if the person is not well versed with intubation. Then other things you can use is obviously tracheal intubation is the best in these patients if you want to secure the airway. And if you think it is a difficult airway, then what should we do? Or intubation has been failed, CV can't ventilate, can't intubate situation, then surgical airway can be done, that is cricothyrotomy and tracheostomy. So when you should think you should intubate the patient, if you are not able to maintain the airway and breathing using the basic technique, and if you think there is risk of aspiration, and in case of head injury, if you want to control the CO2 level, PCO2 levels. So it is not the lack of intubation or lack of tube which result in death of a patient, it is the lack of oxygen. So we have to oxygenate the patient. That should be our main aim. Surgical technique, as I have told you. Coming to breathing. So in breathing, we have to, what things we have to see in look. We have to see again for the color, for the respiratory rate, we have to see whether the accessory muscles are used by the patient for respiratory distress. Then if there is any obvious injury in the chest, there may be penetrating chest injury. Patient is having flail breathing or flail chest, and if there is any other chest wound. In feel what we have to see in breathing. We have to look for the trachea. From our finger, we have to see whether the trachea is in the midline or is shifted. So if the patient having pneumothorax, trachea will be shifted to the other side. So tracheal shift. If there is rib fracture, there will be tenderness or crepitus. You have to see for the chest wall movements. If there is any subcutaneous emphysema, you have to see that, and we have to percuss the patient. In percussion, you will see there will be resonant sound, resonant percussion. If or dull, it means if it is resonant, that means it is pneumothorax. Okay. And we have to listen. So listen, what in listen we'll auscultate, we'll see the breath sounds. As we have seen that breath sound, there is decreased breath sounds in pneumothorax. You have to auscultate the heart sounds also. You can auscultate simultaneously. There can be pericardial tamponade, and bowel sounds. You can see the patient may be having bowel injury, and the patient may be having absent bowel sounds. That may tell you about the bowel injury of the patient. So how will you manage? So you have to secure the airway, and then you have to give oxygen to the patient. You have to assist the ventilation if necessary, or the patient is breathing spontaneously, the patient is having obstructed airway or tongue fall, you can simply insert an airway and the patient will start breathing. So you don't need you don't need assisting ventilation in these patients if the patient is breathing spontaneously. But if the patient, you have intubated the patient, you have to assess the ventilation and we have to treat the cause. So what was the cause in this patient? It is the pneumothorax or hemothorax. And we should always be beware of airway injury, tension pneumothorax, open pneumothorax. There can be massive hemothorax, flail chest, lung contusions. So we have to identify all these injuries. We have to take action in all these injuries. Otherwise, we may lose the patient. So this is an X-ray in which, can anyone tell? It is written there. There is a tension pneumothorax on the right side, and you can see there is a large tension pneumothorax. And what we do initially, in the second intercostal space, mid-clavicular line, we insert a large bore needle there. So you will hear a hissing sound, and the definitive management is to insert an ICD. So in ICD is in triangle of safety, in the right side of the chest. Okay. So what are the signs of tension pneumothorax? You have to look for cyanosis. There will be tachypnea. Then you have to feel for the tracheal deviation to the opposite side. Then there will be overexpansion on the ipsilateral side. There will be increased resonance on percussion, and there will be reduced BP. There will be hemodynamic compromise of the patient. Patient will be having tachycardia and reduced cardiac output. Then which results in reduced blood pressure. And during auscultation, there will be decreased breath sound on the ipsilateral side. So how to manage, which I have told, that immediate decompression is needed using large bore needle in the second intercostal space, mid-clavicular line, and then we have to insert the chest tube. So it should always be a clinical diagnosis. We don't have to wait for a chest X-ray to be done, and we have to treat it before X-ray is being done. So any query related to airway, you can ask. And to summarize, so always if you get a patient in emergency or any trauma patient, you have to first assess the responsiveness as we have seen, and then in airway and breathing you have to open the airway, give oxygen to the patient, then assess ventilation if it is required. You have to consider for intubation. You should not wait for it, that you are thinking that whether to intubate the patient is unconscious, patient is having stridor, patient is not awake, and then you are seeing that we'll intubate him later or then this or that. We should not think about it. It's better to intubate early. So if you should consider intubation, and we should never forget to, in any trauma case, we should never forget to immobilize the cervical spine. Thank you.
Divide people into groups. So again, let's have a raise of hands. I want to see how many people we have finally.
13 in
Total 13.
Giving them color tag.
Okay.
So they can go in that group, color-wise.
Okay, that's great. So three colors you are giving, na?
3 colors. Sorry, 3 colors.
Three colors.
3 colors.
Give me back black.
So we are giving red, yellow, and green.
Red, yellow, and green.
Okay. So Ajay, I think. Okay. So, green, you can come here to the airway station. Everyone who's got green moves to the airway station. Yellow can move to the C spine station there.
Any chaos happens not because of that particular event, but mostly the way we are handling the patients after that. If you can see the videos, how policemen are handling, how they are transporting, how they are just taking the patient is hanging down, somebody is lifting legs. So that leads to more injuries and more casualties. So if we can avoid that, we can prevent maximum loss. So in this scenario, now we assume there are 4 or 5 people available for help. So in that case, one person will stabilize the cervical spine. In that case, Dr. Agnivesh will come here and he will stabilize the spine nicely with firm grip here. So that way the cervical spine is stabilized. Okay. Then log roll we already learned in the previous session how to do it. So at the log roll, I'll put my hands from one side, and at the second side when we do the log roll, we put the hands and over above. And when patient lie down, we lock it together. So that way there will be 3 people. 1, 2, 3. They will lock the hand and at the count of 3, lift and take away. Okay. So now 1, 2, 3, 4, 5. Can we take your help, sir? Okay. So you can stabilize the spine. Okay. आप लोग आ जाओ, आप लॉग रोल करेंगे, 2 लोग लॉग रोल करेंगे, क्रॉस योर हैंड्स, सर के साथ आप आ जाओ, इधर आ जाओ। सर हाँ मैं आ जाता हूँ, चलिए सर आप इधर आ जाइए। I'll do 1, 2, 3. ओके आप अपने हाथ डालो, बाहर निकाल लो, नहीं सीधे हाथ, अभी नहीं, अभी सिर्फ हम लॉग रोल समझ रहे हैं, शोल्डर के ऊपर, अभी नहीं, हाथ डाल लीजिए।
All the hands at the prominent bony areas, not in the soft tissue.
Okay. Now 1, 2, 3. Okay. Again opposite side, huh? We'll come there. So 3 people are doing simultaneously. Okay. 1, 2, 3. सर आप लॉक करेंगे। Now he is there. So similarly now अब आप अपने आप हो जाओ, एक बार समझा दिया है, आप इधर से आ जाओ, आप इस तरफ आ जाइए थोड़ा, अभी वो जो लॉग रोल कर दिया था ना जैसा, टर्न ले लीजिए, हाँ ऐसे, हाँ आप अपना हाथ डालिए, आप भी डाल लीजिए, यहाँ से निकालिए उस तरफ हाथ सीधा ऐसे, लेट जाइए, अभी रुकिए, उस तरफ हो जाइए अब आप, ठीक है आपका हाथ है ना, 1 मिनट थोड़ा और हो जाइए, लेट जाइए। सो दिस इज वी अज्यूम वी डिड काउंट 1, 2, 3 लॉग रोल बोथ साइड एंड वी लॉक टुगेदर। ओके अच्छे से पकड़ा हुआ है ना, आप थोड़ा और नीचे ले लो हाथ को, वरना हमें इंजरी हो जाएगी। वी शुड सेव अवर सेल्फ ऑल्सो। अच्छे से हाथ लॉक है, 1, 2, 3 सी, देयर इज नो एक्स्ट्रा हार्ड वर्क, नथिंग, यू आर ऑल्सो कंफर्टेबल एंड यू कैन वॉक अप टू 2 किलोमीटर्स लाइक दिस। सो दिस इज द वे। चलो आ जाओ, लेट्स गो। Okay. So this is one way. There is one more way to do log roll, which to transport. When there is not much of help available, only 2 people are there. Okay, understand? So अब जैसे आप अभी नीचे आ जाओ. In that condition, what we do is, I hold my hand like this, you see, or maybe right hand. आप आ जाओ, ऐसे करो, opposite side. ये पकड़ो आप मेरे टाइट, है ना? पेशेंट आएगा, पेशेंट को एटलीस्ट आप बैठ जाओ ऐसे, अपनी स्पाइन को स्टेबलाइज करो। कोई आप आ जाओ, बैठो आराम से, कोई बैठा रहा है ऊपर बैठ जाओ, उस पर, ये झूला है आपके लिए, हाँ बैठ जाओ, हाथ टाइट पकड़ना है, अपनी इंजरी बचानी है, बैठ जाओ आराम से, बैठ जाओ, कोई दिक्कत नहीं। हाँ यस, कंधे शोल्डर के पास डालने हैं, इंजर्ड है नहीं चल सकता। 1, 2, 3 उठो आराम से, यस यू सी 2 people कैन ट्रांसपोर्ट, इट्स वेरी इजी। आ जाओ, देखो घुमा के लाते, see it is really very easy. Okay, now he can lie on stretcher, we assume कि अब इसको हमने लेटा दिया है। So these are very basic things which everybody in police force, in transport, they all should know how to transport and minimize the injuries. Okay. There is one way where single people can also take, but that we won't learn because we need to save ourselves also. There is a way out, but which is not indicated. It is like mouth to mouth breathing, obsolete now. आप इसका बता दीजिए। आप तो पेशेंट हो हमारे। आपको भी आता जा रहा है ना समझ में सारा?
यहाँ से आ जाएगा सर, हाँ ये वाला यहाँ से। अभी क्या है, इसको हम साइड में रख लेते हैं, एक उधर एक उधर। आ जाओ आप। अभी हमारे पास चीज़ें अवेलेबल है, एम्बुलेंस भी है, सभी कुछ है। तो मान लीजिए ये सर्वाइकल कॉलर है, ये आप लगा दी। सबसे पहले स्पाइन स्टेबलाइज करना है, हमने वो कर दिया। Yes, sir.
This is a hard cervical collar. Okay, we all know. So this is the velcro part which will fit, and this is the chin part. Okay. So the way to slide it is just slide it like this over here. It will easily come out from the other side, and then you place it under the neck and just slide. Okay. Similarly, the other one which is the ER Philadelphia collar which we use. Again, same principle. It gives better immobilization to the cervical spine. Again, you have to slide it below the head like this, and then again you pull it. You don't move it. You don't move it. And you then just close it the way you are going. Right.
So this is very important to understand.
So this is a adjustable collar. Okay. So you can vary the height from regular to necklace to medium to small to like this. So you have to pull this, get it behind, and then you can adjust this height of the.
So according to the patient neck or age, child or adult, you can adjust this.
Lock it back.
And check it from the temporomandibular joint to the your trapezius level. 4 fingers you can take it 4 fingers. So how long you need it, you can adjust accordingly.
So for a hard collar, is there any measurement or like?
Hard collar will come in standard size.
Yeah, but this again, this is expandable, so you can. So this also you can remove it. You can make it this also, and you can make it thin also. So one contrary thing is that what you will feel is thicker and obese people, they have smaller this thing. So if you see a patient who is obese and stout and thick, they will have shorter necks.
Short neck.
Whereas a thin, slender, lean person will have a longer neck. So whenever you see obese patient, the first thing should not be to increase it. The first thing should be that it's going to be a smaller one.
Smaller.
Yes, the girth will be longer, but the distance is smaller. So the you know what is the advantage of this versus this?
So here you can just palpate the means if there is a rest or something, you can use
One
check
other.
pulse. You can adjust accordingly to the size.
That you can do this also, but that's a good point. So again, it gives access to the airway. So if you have a tracheostomy or if you have some other airway which is going you are managing, so this gives you access to that. That is why even in the Philadelphia collar, this one. So there is a hole here. This is so that you can adjust the airway from.
So now we assume that this is applied on him. We won't put it for too long because he will be uncomfortable. And then we do log roll. Put this scoop from one side, opposite side log roll, and then opposite side. So now you all can just show me. It's very simple.
So Hinduja, we'll just put you are the lead now. You are doing the log roll.
Yeah, you take the lead and ask us what to do.
Can I have 50 minutes?
Okay, I am ready with this. Log roll, you need to cross your hands. And yes, little far away, come here. Then the pressure will be less, your efforts will be minimum. 1 second, on your count.
On my count, to my right, to your side, okay? 1, 2, 3.
So, aram se. There's no hurry. Okay?
On my count, down. 1, 2, 3.
Okay, now this side we will do log roll. When you say.
You do the log roll.
On my count, 1, 2, 3. On my count, 1, 2,
Okay.
So then हाथ बीच में so that they don't dangle in.
This is very perfect. Now you stabilize the spine, you secured everything, and now at least whatever is done is done. You won't give more injuries to the patient. Okay?
Your knee is locked. You have enough space to even lift.
Listen.
So even when you're lifting using your arms, you're not lifting using your back.
And you need to follow team leader. This is we all know what to do and how to do, but this is about how to manage in a situation where there is disaster or accident. So you need to follow your leader so that we all work in synchronized way. That is very important, and anybody can be a team leader. So this is with this thing. Now if we don't have a collar spine to stabilize, then we can use this thing also, or we can use sandbag. So we can put one sandbag this side, one this side. That also helps. If that is also not there, you can fix the tape like this from here to here. So that also stabilizes. So there are various other methods with the help of which we can stabilize. So this is, and you want to add anything else now in this?
So only one thing which you all should be aware about is in children who are less than 8 years, their head is much larger than their body. So there, the head actually needs to be at slightly lower level than the board. So if you are using this board and keeping the child's head at the same level, actually the head is going into flexion because of this thing. So there, if possible, if it is feasible, you should have a layer, 1 inch layer, and the head should be 1 inch lower than the trunk. So this is because children, their injuries are more common at the craniovertebral junction. So there, if you put them on the flat bed like this, you are causing flexion. So if you have the sort of availability over there, so try to keep the child, the head 1 inch lower than the level of the.
So can you use any blankets and all?
You can use blankets, you can use any other thing. If there is possibility, then you can keep the board here and let the head be like this. So, I mean, if there is another board, so something like that. So there can be changes which are made, but the key is that it should be in your mind that children less than 8 years, head is larger, so adjust that space.
Okay, guys.
So flexion injuries can be avoided. So you want to practice?
Yeah, I think you better practice. You can take a turn.
We are done here, sir.
You can take a turn. Make sure that you do this repeatedly so that you
You come
master
on
the
that
skill.
side, Eamon, you come on this
Yeah.
side. So show me how you will open.
Yeah.
Yeah, open here. So yes, so you both communicate that
Kholiye.
you opened and then you try to detach.
Yes. Like this.
Yes.
Yes.
That's why you communicate that okay, detach, pull.
And other side also?
And again, for before taking the charge, there we need to give a clear instruction. So rather than point your fingers, just verbalize whatever instructions you want to give.
As sir is telling, it is very, very important. We all are here to learn that communication and verbal commands are very important in all these situations. There should be no confusion because that is the only thing which creates problem. ठीक है.
Any questions? Get yourself familiar with the different types of collars, get familiar with how you adjust the height, so that on the day when you're going to do it, you're not spending time to figure it out. So play around.
Finished here, move to
Yeah.
chest tube. Okay?
Just leave it.
Yeah. So just you people move to the next one. That is the chest
Yeah. As soon as it is free, so they are getting familiar with the things.
दो लोगों को ट्रांसपोर्ट करना है तो सर वो पोजीशन सर हाथ
हाँ, देखो अपना राइट हैंड तो फ्री रखना है, लेफ्ट से ये पकड़ लिया, यहाँ लॉक करो, मेरे हाथ को पकड़ो ऐसे, टाइट हो गया, अपनी स्पाइन भी संभाल ली है, आराम से ऐसे बैठना है सपोर्ट लेके, फिर आपको पेशेंट पैर टूट गया है, नहीं चल पा रहा है, तो उसको नीचे इस पर बैठ जाएगा, दोनों कंधे एक हाथ इधर एक मेरे इधर रखेगा, और हम 1 2 3 करके पहले अपनी स्पाइन संभालेंगे, वो तो संभाला हुआ है कंधे पे हाथ रख के, 1 2 3 और उठो। ये अब आप कितना भी दूर तक ले जा सकते हो, ठीक है ना। ये है, और अकेला एक बंदा है तो वो भी कंधे पर पीछे टांग के सपोर्ट लेके उठ के 1 2 3 करके जा सकता है, बट वो हम अब मतलब पॉसिबल नहीं है प्रैक्टिकली, तो उसको नहीं बताते ज़्यादा। So you all understood everything here. Transport and stabilization of spine is clear. If any question, you can ask us. Otherwise, I hope that you all understood everything. Good. So, आप लोग यहाँ आ जाइए. So my team is here, sir. Now they are ready. We are free. प्रेजेंटेशन है उसी पेन ड्राइव में, हाँ फिर
वो तो लगा हुआ।
Sure.
माइक आप डॉक्टर मंजू को दे दो, ये वाला डॉक्टर मंजू को कनेक्ट करो। नेक्स्ट रिकॉर्डिंग
काफी अच्छा लगा।
ये रिकॉर्डिंग होगा, आप करेंगे कैमरा वो तो
मैं करूँगा मंजू, मैं अब कमेंट्री दूंगा, मंजू रिकॉर्डिंग करी, मैं कमेंट्री दूंगा, आप करोगे। चल रहा है? Okay, sound okay? Sound is fine. Okay, so welcome everyone. Now this is a chest tube station, and what here we are going to teach you are the steps. Idhar aa jaओ, camera. We are going to teach you the steps on how to put in the chest tube. Chest tube is required for two reasons. One, if there is air inside, and second, if there is blood inside. These are the only two situations. Now, the simplest place to put in a chest tube is in the anterior axillary line, 5th intercostal space. You saw in the scenario, in an emergency pneumothorax, you are putting it here. But when the proper chest tube is put, that was the needle, you put it in the 5th intercostal space, anterior axillary line, because that is one of the safest place to put, and it's very unlikely that you will cause any injury or any problem. So the step one, what she is going to do is clean and drape. Step 2, she will identify where is the space. So when we have the various spaces, we have to go over the, over the rib or under the rib? Anyone? Where is the neurovascular bundle? So neurovascular bundle is under the rib, so you have to go over the rib. So when I say 5th intercostal space, in the 5th intercostal space, under the 5th rib is the neurovascular bundle, so you have to go over the 6th rib, like this. So next step she was going to give, she's given the local, identified the space, give the local anesthetic, aspirate, take, put the needle in, and next we pick up the blade to make an incision. There is what is called as a surgical incision and a medical incision. Anybody knows the difference between surgical and medical? Surgeons usually give a big incision. Physicians, they give small incision, then they are struggling to put the tube in. That is why this has been made for the physicians. Show that rod. You will never see a surgeon use this. They always put the directly, because the skin is the toughest part of the body when you are putting in anything. Even when you are putting an IV, skin is the toughest part. So the incision should be more than the diameter of the tube. So if the tube is 1 centimeter, your incision should be 12 millimeters. So next she is doing is she is given an incision. After that she takes the artery forceps and dilates the muscle. So the incision is just skin and subcutaneous tissue. Don't stab, just a small incision. Open the muscles. Then she puts in her finger to check the space. So if the finger is moving freely, that means you are in the right space. Then she picks up the chest tube with the artery forceps. If there is blood, you go down. If there is air, you go up. Okay, introduce. All the holes should be inside. Right? Then there will be air or blood coming out, there will be some movement. Then she connects this to the underwater seal. Why underwater seal? Anyone? So nothing comes back. That is why this underwater seal with 100 ml of saline has been applied. And now finally she is going to fix. So fixing practice we will not do here because afternoon we have a suturing knotting. Okay. So what she is just going to do now is to put two fixation. Either you put a purse string or you put one stitch there, one stitch here. Put one extra stitch so that it prevents moving. These trauma patients, they are going into X-ray, CT scan here, there, shifting around. If the stitch is not firm, this will slip out. Okay?
Yes,
ठीक है, मत लगाओ. Okay, take it out. So now, one by one, everybody is, so when she is taking it out, see what she is doing? Clamp the tube and close it with the back of the.
इनके आपके पास अभी नहीं आया है बैग, तो आप क्या करेंगे?
बैग नहीं आया तो इसको आप ऐसे करोगे. ठीक है, अब सब लोग एक एक करके करेंगे और आप लोग देखोगे सब ठीक कर रहे हैं. सारे स्टेप्स करते करते सबको स्टेप बताना है कि अब मैं ये कर रहा हूँ या कर रही हूँ, और सारे स्टेप्स हम एक एक करके करेंगे. चलो आ जाओ, पहले आप आओ.
First step would be identifying the site, then cleaning and
So which one is your side?
go on to the fifth intercostal space where axillary about the rib.
बैड हो गया है पेशेंट का, उसको लेके जाना है. तो कैसे क्या कर सकते हैं हम लोग आपस में? वो भी बड़ा सिंपल है कि आप आ जाओ, अपना राइट हैंड फ्री रखो, लेफ्ट हैंड राइट, अपने लिए बैक पकड़िए, मेरा पकड़िए, बैठो, आप आ जाओ, उस पर बैठो, कंधे
उसके बाद आप धीरे धीरे डीप जाओगे.
इसमें डीप जब जाओगे तो गिव भी आ सकता है, बिकॉज यू माइट फील दैट यू आर इनसाइड. नाउ अ नीडल टच टू द लंग इज हार्मलेस, कुछ नहीं होएगा. सो डोंट फील स्कैर्ड. एनेस्थेटाइजिंग द प्लूरा इज वेरी इंपॉर्टेंट बिकॉज पेशेंट विल नॉट मूव. तो एक तो स्किन में पेन होता है, दूसरा प्लूरा में पेन होता है. तो डोंट बी हेजिटेंट एंड ऑब्वियसली पेशेंट का मसल देख के आपको आइडिया हो ही जाएगा कि कितना मोटा है पेशेंट.
ये भी बहुत अच्छा आइडिया होता है चेक करने का कि कितना थिन जाना है, कितना थिक जाना है, कितना थिक जाएंगे उसके से पता चलता है.
ओके, नेक्स्ट क्या करोगे आप? या इंसिजन देने के पहले चेस्ट ट्यूब चेक कर लो, उसका डायमीटर से बड़ा होना चाहिए. यस.
Where patient cannot walk and you need to take him out to safety. Okay. So now about the scoop and collars and how to adjust
आपको
them.
सेंटर में भी रहना है, बहुत 6 के बहुत नजदीक है.
So let's see, these are the three common types of collar which you will get. Soft collar is not meant for cervical. So the easiest one is this.
तो बोन के ऊपर आप कट करोगे ना तो प्रॉब्लम होगी. बोन से थोड़ा ऊपर रहना है. इवन दो द ट्यूब इज गोइंग ओवर द बोन, the incision should be little higher up.
आर्टरी बहुत ज़्यादा डीप नहीं जाएगा, बस डीप जाने से क्या होगा, हम लंग में छेद कर सकते हैं.
Sometimes there are labels and also you have to keep the label upright. So that
थोड़ा सा आपने मसल स्प्लिट किया, बाकी का काम आपका फिंगर करेगा. फिंगर से आप लंग में होल नहीं करोगे.
चेस्ट वॉल पे क्या है तो फील करना.
दूसरा, इन ट्रॉमा वी आर वेरी लकी. इट्स नॉट लाइक मेडिसिन. मेडिसिन में आप ये सब कर रहे हो, पेशेंट टीबी का पेशेंट है, फाइब्रोसिस है, लंग है, फाइब्रोज लंग में तो आप लंग हिलेगा नहीं, आप करोगे उसको तो उसमें छेद कर दोगे. हियर यू आर लकी, ट्रॉमा का पेशेंट है, उसमें हवा भरा हुआ है, इसका मतलब लंग तो वैसे ही दूर है. लंग इज ऑलरेडी कंप्रेस्ड, ब्लड भरा हुआ है, लंग इज कंप्रेस्ड, सो चांसेस ऑफ मेकिंग एन इंजरी इज वेरी लेस बिकॉज द एयर और द ब्लड हैज ऑलरेडी पुश्ड द लंग अवे, सो यू आर वेरी सेफ.
क्या मिला आपको?
न्यूमो, तो टुवर्ड्स द हेड एंड.
जब आप फिंगर से चेक कर रहे होगे ना तभी कई बार पता चलता है.
फिंगर आप डालोगे ना तो हवा आएगी या ब्लड आ जाएगा.
आपको पता चल जाएगा मुझे आर्टरी नहीं
size increases, small, medium, large. What actually increases is this rather than this.
उसकी नोक पे होना चाहिए.
हाँ, उसको थ्रू एंड थ्रू मत करो.
अभी भी आपके आर्टरी बाहर, ट्यूब अंदर होना चाहिए.
डालोगे अभी?
The principle remains the same. Without moving the patient's neck,
एक्चुअली में करेंगे तो ऐसा.
somebody is holding the patient.
यस, थोड़ा सा करके आर्टरी निकाल लो और चेस्ट ट्यूब को, हाँ चेस्ट ट्यूब को पुश कर दो.
पुश करके आपको काउंट करना है कि आपने कहाँ पे डाला है. मान लो आपने 10 पे किया, 15 पे किया, 20 पे किया.
आप ये पकड़ोगे, आपके असिस्टेंट करोगे.
ये नहीं है तो क्लैंप करोगे.
चलो, वेरी गुड. इसके बाद आप स्टिच कर दोगे. नेक्स्ट, स्टिचिंग का सामान आ गया है क्या आ रहा है?
सर स्टिचिंग का हमारे पास सूचर्स तो
नहीं
है.
नहीं, वो J&J वाला.
हाँ, मुझे इस फॉर्म कर लो एक फॉर्म.
नहीं, मैं करता हूँ. अच्छा, तुम्हारे पास सब नंबर सेव, इसके बाद कर लेना, इनके लेक्चर होंगे. मैं पूछता हूँ उनसे, मैं पूछ लेता हूँ.
ये सैनिटाइजर नहीं है यहाँ.
वो उधर है, वो ला रहा है.
Hard collar is when you don't have anything. That is better. See, hard collar gives you protection from flexion. When you lift the patient up, this head will hang back.
ये रिकॉर्डिंग इनको लगा दो.
फर्स्ट पेन रोटेट करना है. सेकंड में आपसे पहले चेक करेंगे कि इंसान आपको कहाँ है, देन आप चार्ज करेंगे.
बाकी का रिकॉर्डिंग ना इनको लगा दो.
So this is always corrected, but there is nothing else.
इतने दूर से नहीं आएगा. मेरा माइक तो बहुत अच्छा है. ओके, थैंक यू. हाय डॉक्टर श्रीराम गुप्ता. प्लीज़ आ जाइए, आप इधर आ जाइए तो आपको ज़्यादा दिखेगा.
Basically, the incision has to be closer to the lower knee. बड़ा लेवल है.
इस ग्रुप में सिर्फ चार लोग हैं.
Now, yes. That is needle holding.
And ये बाहर है और 1 2 3 पर एक साइड से ये जाता है. Then opposite side लोगों को 1 2 3 आता है.
जब आप आर्टरी से डायलेट कर रहे हैं ना तो बहुत कम ही करना है आपको. जस्ट स्किन के पार्ट को ही करना है, डीप नहीं जाना है. उसके बाद बाकी काम हम फिंगर से करेंगे.
Yes. वो completely slide into the fluid space. The blood coming out. Okay.
Yes.
So,
No.
so this is the end which will go inside because these are fenestrations, right? Okay. बाहर में निकल. Yeah.
इसमें तो गिब्बे नहीं है. get a giveaway.
थोड़ा नहीं है.
एक्सरे करने के बाद if you think that tube is in situ, अच्छा पोजीशन है,
Okay, so they need to be done together. Otherwise, if I
next?
open it too much, then it will get wrong.
yeah.
Press, release, push.
अब आप आ जाओ
Then we will get it. And then side.
Which side? Space. Yeah.
Over the 6 rib.
And
And then
middle, anterior, posterior, axillary line.
mid axillary.
Anterior axillary line. Yes. Okay, so now
लॉन्ग रोल में भी
अब दे दो ना.
आप उधर से स्कूप लेके आना
Practice.
इधर से दो लोग लगाएंगे
फर्स्ट आप सेप्टेनिस. हाँ ठीक है.
And then deep.
डीप.
Like this. After this.
और एस्पिरेट करके ना चेक करते रहना है.
It has adrenaline.
तो ये आदत होनी चाहिए आपको हमेशा जब भी आप लोकल दे रहे हैं ना, जैसे आपने ये किया, ये आदत होनी चाहिए मतलब.
Because you don't want to inadvertently go into the artery. The local anesthetic will go into the artery. You will have systemic toxicity. Okay. So you have given the local now.
Then after incision, before taking incision, we have to measure the size.
Yes.
Size.
First, you have to just leave it there. Just leave it there. You won't be able to apply. You will not have too many people.
और ये ध्यान रखना कि पैरों को ये ना कर
Now you are
जो भी बोलना है आप जोर से बोल सकते हैं तो माइक में भी
out
आएगा.
of the space. So you have to go close to the lower rib. Yeah. Okay.
लॉक कर दिया
Yeah. It's big enough. Now,
ये आप बाहर निकालिए ये
no. You take an artery. Open up the incision a bit.
इम्पोर्टेंट है स्ट्रेप का बाहर होना उस तरफ का भी अंदर है
Okay. ज़्यादा deep मत जाओ.
तो स्ट्रेप
बाकी काम
Use your
फिंगर.
Completely in. Okay. Now.
स्ट्रेप करिए हाथ अंदर कभी कभी ये हाथ बाहर रहते हैं गड़बड़ी को ट्रांसपोर्ट करते हैं फ्री फॉल होता है इसलिए भी शोल्डर पर डिस्लोकेशन हो जाता है
Okay. So, assuming this was she's lifting.
Yeah. No, it's okay. No, it's okay.
Yeah, you're doing fine.
क्या मिला आपको? नीमो और हीमो. यस.
Pneumo? Okay, yeah, you're right.
नीमो मिलेगा तो कहाँ जाएंगे? नीचे और ऊपर?
ऊपर. Yes.
अभी नीचे जा रहे थे आप.
Go. बस.
नहीं नहीं नहीं
इतना ही artery
बहुत
मिला
कम.
है.
मैं बताती
Poke the
हूँ.
lump.
जस्ट आपको इतना जाना है. क्यों? क्योंकि हमें बस उसको अंदर बस एंड इसको यहाँ पे होल्ड करेंगे आप. निकालो आर्टरी बाहर. हाँ धीरे धीरे पुश करेंगे. ठीक है. कैसे पता चलेगा आप राइट प्लेन में हैं? आपने डाला हो सब कुछ. ठीक है.
Come, air will come out.
एयरवे कम आएगा तो नीमो है ना. और अगर ब्लड आएगा तो
It's Pneumo.
मैं इनको कंफ्यूज कर. आपने अभी कहाँ डाला? नीमो में और हीमो में?
See, irrespective of it is pneumo or hemo, you will see collar movement in the back. Okay, that is a confirmatory sign that you are in a pleural space. क्योंकि pleural space में है तो the pressure will increase and decrease as per the respiration. ठीक है. अभी यहाँ पे आपने लगाया. Always make sure that the bag is filled in here.
100. ये इसमें एक
Water
लाइन
seal has to be there. नहीं रहेगा तो फिर patient will have उसका जो pneumo रहेगा वो बढ़ जाएगा.
इनकेस ये नहीं है तो हम उसे क्लैंप कर देंगे.
Yeah, you'll clamp like this till the back comes. और इसको फिर आपको आर्टरी के पीछे से लगाना है. You not use this part because this part is traumatic. तो ये वाला part use करना है.
नेक्स्ट.
When do we use a trocar? Sorry?
ट्रोकार.
This is if you think that tube is not going in properly. So sometimes I think this is
जब thickness होता है then हाँ.
So in medical indications, if you have TB and all of these things, so there are a lot of adhesions, or if it's a malignant diffusion, not for trauma.
मैंने तो कभी यूज ही नहीं किया.
Yeah, even I haven't used it. कभी नहीं used it.
इसलिए मैं उसके बारे में ज़्यादा नहीं बता सकती. टू बी वेरी फ्रैंकली मैंने सर्जिकल टीम से हो तो हमेशा ड्रेन ही डाला है डायरेक्ट. ये सब नहीं किया.
Medical emergency में भी also
painting just palpate the fifth intercostal space just above the sixth rib.
तो ये आपका फिफ्थ है.
Discharge.
अज्यूम कि यही फिफ्थ है आपका. फिफ्थ इंट्राकॉस्टल स्पेस है. अपर बॉर्डर ऑफ द सिक्स रिब.
Yes.
Then we give a local anesthesia.
Okay, दे दो.
एक मिनट का फोन आ रहा है मुझे. मैं उससे बात करती हूँ.
First we give instruction skin. एस्पिरेट करेंगे एंड थोड़ा डीप जाएंगे,
बराबर,
एस्पिरेट करेंगे,
यस,
उसके बाद
इंसिजन
इंसिजन से पहले हम
मेजर 2-4 के बाद तो आपको मेजरमेंट की जरूरत ही नहीं पड़ेगी, आपको पता टक के और हो गया। तो स्टार्टिंग में जब 1-2 बार डालते हैं देन उस समय हमें चलना चाहिए होता है।
always take it like this, hold it like a pencil, take it like this, yeah. It's controlled that way.
इतना हल्का दोगे तो टूप ही नहीं जाएगा, और करो।
बड़ा करो,
बेक
हम इमरजेंसी मेडिसिन,
बड़े होने में कोई प्रॉब्लम नहीं है, छोटा होगा तो आपको फंसी होगा।
हमारी तरफ से सर आके देखिए, उसके बाद हमारी तरफ से पेशेंट स्टार्ट
ऐसे डायरेक्ट करना है, अंदर डाल के ओपन करना है, लाइक दिस।
और हमें क्या ओपन करना है? जस्ट स्किन ओपन करना है और थोड़ा सा मसल को हम डायलेट करेंगे।
ओके, नाउ
आप कर देंगे।
न्यूमो अब इस पे न्यूमो ज़्यादा
see down matlab you don't have to go vertically down, you have to go along the curve of the diaphragm, right? हो गया, ठीक है।
किसी असिस्टेंट को आप हेल्प के लिए बोलेंगे, सिस्टर होगा वहाँ पे, कोई भी होगा, उसको आप बोलेंगे होल्ड।
You have to give clear instructions, मुझे हेल्प चाहिए, प्लीज अटैच।
डिटैच के टाइम पे
हाँ, इन केस अगर हमारे पास बैग नहीं है देन हम इसे क्लैंप कर देंगे कुछ टाइम के लिए और हम फिक्सिंग करेंगे, ठीक है? इसके बाद का बाद फिक्स करना।
Cleaning and draping. So 5th intercostal space below the rib, just above, so below 6th.
Just above the lower rib, yeah.
अज्यूम करते हैं यही है।
What do you paint and drape with? You use betadine and chlorhexidine, okay?
डीप, यस।
Okay.
जब आप लोकल देते हैं ना, दोनों हाथ से देना है। क्यों? कि वो हिलेगा, मूव नहीं करे इसलिए। यस सर, 2 बचे हैं अभी तो, स्लो है थोड़ा। ठीक है, जल्दी जल्दी करते हैं।
Yeah.
नाइस।
मेजर करो, yes. Very good.
फास्ट कराते हैं थोड़ा, सब खड़े हैं ना।
और है ना इसके लिए?
इतना डरने की ज़रूरत नहीं है, ऐसे इंसिजन नहीं दे सकते हैं। गो लाइक दिस एंड कट, ओके? बहुत डीप नहीं जाना है, बट स्किन ही कट करना है।
Yes. Okay.
Yes.
Now,
फील विद योर फिंगर। नहीं, दोबारा।
that is needle holder. Yeah. Needle holder रखना चाहिए था, मतलब them they should know what's RTO.
नहीं, जो लोग सर्जिकल से हैं वो तो देख ही लेते हैं, वो तो फटाफट उठा लेंगे आगे। कंफ्यूजन भी बहुत ज़्यादा ज़रूरी है, सब अच्छा करेंगे तो पता ही नहीं चलेगा गलत कहाँ पे हुआ है। बस एक बार अगर वो अंदर चला गया तो आपको आर्टरी बाहर निकाल लेना है, इसको होल्ड करना है, ट्यूब को। एक हाथ से ट्यूब को होल्ड करें, दूसरे हाथ से निकाल लें, उसके बाद हाथ से आप पुश करेंगे। कैसे पता चलेगा कितना जा रहे हो आप अंदर? नहीं, कैसे पता चला आपको कि सही?
एयर कॉलम या एयर का गसिंग आउट।
हाँ, ठीक है। और अगर ब्लड आ रहा है तो कहाँ जाओगे आप? कौन सा प्लेन है? राइट,
Okay, done.
ठीक।
इनका हो गया ना, this batch
अच्छा,
is over.
ओके सर, फिनिश द लास्ट।
Okay. Now next group come.
अच्छा
Here we have only. Okay, here also we have 5.
नहीं सर 6 है.
Mic दे दो अपने.
ले लो ले लो ले लो. मेरे हाथ ही है.
We don't need mic.
चाहिए ऑडियो के लिए चाहिए लाइव चल रहा है.
अच्छा उनको सुनाएंगे
किनको?
दे आर रिकॉर्डिंग
अच्छा.
अगर मैं ऐसे करूँ तो
Okay. So
अगर मैं ऐसे ही डालूँ
what's the problem?
That will be wrong placement.
Why?
Not like
तो क्या होगा?
not enter the.
नहीं आपको इंट्रो में मैं अपने डाल देता हूँ. चला जाएगा. कैसे चलेगा? पेशेंट तो अनकॉन्शियस है, आप तो कैसे भी डालो. अगर ऐसे डालोगे तो भी चला जाएगा. तो क्यों? वही तो मैं पूछ रहा हूँ, अगर ऐसे डालोगे तो क्या होगा? फॉल बैक ऑफ
Further push कर देगा it all टंग को.
जब तुम ऐसे डालते हो ना तुम्हारी जो टंग ऐसे है ये बीच में है
और अंदर जाएगी.
और अंदर है. ये तुम डाल रहे हो ये फेरिंग्स की
Pharynx.
फेरिंग्स
And then we rotate it 180.
180 degree you rotate it.
हार्ड पैलेट की
ठीक है. And this is the bite block. इधर आएगा teeth.
फॉल बैक ऑफ बंद हो जाएगा. ठीक है.
Yes. Thank you, sir.
What is this?
आप लोग भी देख कर
कौन से डिपार्टमेंट में हो?
Ortho.
अच्छा.
वेरी गुड
Then you should learn. What is this? Nasopharyngeal airway. This was oral airway.
Okay, that was
है ना?
this one.
हाँ. This was Goodell's airway. This is nasopharyngeal airway. So nasopharyngeal airway means it will be inserted through. And how do you decide the size of the airway?
इसका कैसे?
दोनों का.
इसका साइज कैसे देखते हैं?
अच्छा बता देते हैं.
चलिए बता देते हैं. टाइम दो. ठीक है.
Color coding is also.
हाँ, color coding is for number of the number 3, 4. It is start from 000 for infants, neonates. Yeah, 00, 0, 1, 2, 3, 4.
ये यहाँ से
L of nasi to tragus. This is for nasopharyngeal airway, and for oropharyngeal airway from angle of mouth to the angle of mandible. ठीक है, this is the correct size.
Yes.
You will decide, and then how will you insert? You will always apply jelly in these.
Jelly, yes.
Always apply. You will not cause further trauma to the patient.
Right.
And then how will you insert? You have applied jelly. How will you insert?
This is through the nasopharynx.
Nasopharynx.
Yeah, so
Nose. And you will always keep it like this.
like
Okay?
this. Okay.
कहीं जाके स्ट्रक हुआ.
हाँ.
तो ये हमारी नोज जो है ना नैरो हो जाती है. सबका डमी ऐसे ही बनाया जैसे कि है ना हम लोग.
Yes.
वहाँ जाके रोटी
डालो. डालो. शायद जाए. हाँ, जा रहा है. ठीक है?
और तो वाला हाथ नहीं चलाना.
हाँ सर.
हाँ, जाओ आराम से जाओ. ट्विस्ट करते हुए जाओ. ट्विस्ट करते हुए जाओ. हाँ, जाओ. वेरी नाइस.
वेरी नाइस.
ये तो बहुत अच्छा डाला. हाँ.
राइट The only thing is just be gentle.
Yeah.
You don't want to cause any further trauma.
Correct. Thank you.
हल्का जैसे स्ट्रक हुआ.
Yeah, just थोड़ा सा.
And what is this?
No.
This is laryngeal mask airway. If we don't know intubation in any emergency situation, I know.
It's for that
So that only. If you don't know intubation, it's very easy. So if the patient is, you want to ventilate the patient, what you will do? You will hold it like this. Then through the hard palate, you will push it like this, and then you will insert it like this. Okay. Okay. And then you will inflate with approximately 20 ml of air.
Okay.
ठीक है? It will come a little out.
LMA के ऊपर लिखा हुआ रहता है
कितना ml?
कितना आपको
एयर डालना है.
Okay.
वेट के हिसाब से LMA रहता है 30 to 50, 50 to 70, 70 plus.
Okay.
The sizes are like that 3, 4,
So
5.
ma'am,
So it is for female, it is 3 number. For male, it is 4 number.
4 number.
So this is,
ठीक
you will decide. Okay. कितना ml air है? ज़्यादा लगेगा इसमें. ठीक है? 20 to 30 ml लग जाता है. And then you will check for.
आ जाओ आप हमारे स्टेशन
Right. Yes, ma'am.
So anyone, this is ideally for as orthopedic
You
surgeons.
can
you
also
all
practice
also, if
later if
needed.
you want, no? During
नहीं, ये अलग से बाद में आए हैं. बाकी तो आ गए. बाकी एंड में आए.
problem.
हमारा टीम का तो हो
What I
गया
mean
सारा.
is you can all practice at the lunch time
हाँ,
also
हाँ.
because everything is here and doubts are there. We are available.
ठीक है? Any other doubt?
Yeah.
You want to learn intubation also? Afterwards you will learn. Yeah. Afterwards you can learn. Okay.
ठीक है, आप इस ग्रुप में आ जाओ.
हाँ, हमारा नया ग्रुप आ गया है.
आप इस ग्रुप में आ जाओ.
ठीक है.
This is the new.
न्यू ग्रुप. हाँ, आई थिंक दिस इज न्यू ग्रुप. सो आ जाओ, इधर आ जाओ आप सब लोग एक एक करके.
How will you check for the response? Madam had taught now. In the morning we did a scenario, right? So, tap, and check for the response. Samjho? If the response is not there, the tongue, okay, gurgling sound, obstruction की वजह से the patient is not able to speak. Then what do you do? Okay, so chin lift and
jaw thrust.
Okay. After that, and you can use even airways for those things. What all airways do you know of? Oropharyngeal and
Nasopharyngeal airway.
How to get the size of the oropharyngeal and the nasopharyngeal airway. Oropharyngeal airway is from the
Angle of mouth to the angle of mandible. Nasopharyngeal.
is from the.
Ala of nasis. Ala nasi to tragus.
To practice the Gudel's airway insertion.
You people know how to insert the Gudel's airway?
All of you all know.
You know?
Come
Insert?
practice, please. This is for you all to practice. Best is lubricate whatever airways you all are using. Okay.
Very nice. Very nice.
उल्टा halfway through turn करो उसको 360 degrees and then glide it. Okay.
Very nice.
Very nice. So, take care of the lips while you are doing all these things.
I'm opposite hand to the left hand. This opposite hand. इसका कोई रोल
कोई रोल नहीं है.
उसका
आ जाइए.
nasopharyngeal airway.
lubricant लगाएंगे पहले इसको and then बस को सेट करना है. एक रेजिस्टेंस आएगा उसके बाद में
नहीं देखो.
You just
देखो ना ये
turn gently.
this is according to the contour of the airway ना. So you'll just insert it like this. Insert it and twist it.
थोड़ा सा twist करो.
हाँ. परपेंडिकुलर रखो. हाँ, परपेंडिकुलर रखो and then twist it. नहीं. टर्न क्यों कर रहे हो? हमारा तो एयरवे ऐसे ही है ना. ये कर्वेचर यही है ना. We'll not change the curvature.
Oropharyngeal airway में भी turn, क्योंकि नहीं तो टंग और सीधे डालोगे तो टंग और अंदर जाएगी.
हाँ.
जहाँ पे आपका हाथ रुका कहीं स्टक, क्योंकि नोज यहाँ पे नैरो हो जाती है, वहाँ जाके रुकेगा. हल्का सा वहाँ भी कीजिए, बहुत ज़्यादा नहीं करना. जैसे करेंगे एकदम हल्के से पुश कीजिए, जेंटली चला जाएगा.
ठीक.
Twist and it will go.
So this is much better tolerated by the patient. Nasal airway. It's always more comfortable.
Then your bag mask.
How will you do it?
How will you do it? Any idea?
CNE technique. Yes.
Excellent. Angle of the mouth and all the bony prominences. Lever on the soft. Very good.
Very nice.
जितना अच्छा सील दोगे इसको, जितना अच्छा सील दोगे उतना अच्छा
Ventilate होगा.
होगा.
Very nice. Good.
Want to practice?
Lubricate first, then
This I think last batch है. ठीक है. आप कौन से डिपार्टमेंट से हो?
I miss cervical spine.
अच्छा, आ जाओ. So when to insert the airway? Why are we inserting the airway?
Airway obstruction.
Airway obstruction. And how have you assess the airway obstructed? It is obstructed. How do you know?
Patient can't hold the breathing by themselves. There's secretion, trauma, any external obstruction or anything.
The main if you are having, the patient is having stridor. Okay? Stridor, and you are thinking the patient is having tongue fall, gurgling
Tongue
sounds.
fall, snoring sound.
Just,
Loud you are getting.
you're suspecting that it is a tongue fall. So you are inserting airway. What saliva? The patient will aspirate if there is saliva discharge. Yeah, to maintain the airway. So most common cause of airway obstruction is tongue fall. And for tongue fall, we are inserting to prevent that or to overcome that, we are inserting the airway. है ना? Either oropharyngeal or nasopharyngeal.
अगर सीधा ही डालना है तो क्या परेशानी है? इतना घुमाने की क्या जरूरत है?
Prevent the tongue fall back, like you'll push the tongue more if
Yes.
इसीलिए ऐसे डाल.
ये क्या है? हाँ. पहले में.
ट्राई कीजिए कोई और. आप ट्राई कीजिए.
हेड एंड पे खड़े हो. इसको always hold it like a pen. Index finger should be below the cuff. ऐसे क्यों? ऐसे पकड़ो ना. ऐसे पकड़ो.
Pen holding pattern.
Pen holding,
and
हाँ.
then this will glide and
It
it will be
will
over
glide.
the hard
हाँ,
palate,
open the mouth,
not on the tongue.
glide
tongue
it
से slide करने की
along the
कोशिश
hard
करोगे,
palate.
tongue और अंदर जाएगी.
हाँ.
And आपका LA में नहीं जाएगा.
अब नहीं जा रहा अंदर. चेक कर.
Inflate always, huh? And LMA are of different sizes as per the weight of the patient. Okay. So generally, females may number 3, males may number 4. And the amount of air to be inflated, to inflate that cuff, it's generally 3 के लिए 20 cc
ml.
air लगता है. Okay. It is generally written on the cuff. That's easiest for anyone to learn. कोई भी. You should
So if you are not well versed with intubation, better go for LMA insertion.
किसी को करना है और ये
इंट्यूबेशन करना है किसी को?
सबने किया हुआ इंट्यूबेशन इसके बाद.
पहले तो
हाँ, इसके बाद.
को assemble करेगा.
इन्फ्लेट करना है. गया अंदर.
निकाल.
This has to go full.
हाँ, it has to go full. And when you inflate ना, it will come out a bit. It will inflate and it will come out a bit.
अटक जाता है, चिमटी आएगी, लगेगा. All you need to do is
This will rest upon epiglottis. Okay. You're inserting it like this only ना. This will rest upon epiglottis.
हल्के से है, ठीक है. साउंड आएगा ऐसा.
जितना तुम लोग ऐसे करोगे ना, ये घिस के फिर खराब हो जाएगा.
और सबसे ज़्यादा पेनफुल होता है कि ये जो स्किन आ जाता है. बहुत पेनफुल.
चलो try, whoever wants to try and intubate me. नहीं.
उल्टा पकड़ना. फिर उंगली लगाना.
यहाँ से करेंगे. ये अटकेगा, लगेगी ना चिमटी. बहुत दिन तक
ऐसे ऑफ करना है. म्यूट है ना. ऑफ तो कर दिया था मैंने
ऑन
ऑन ऑफ रहने दो यहीं
It is designed ऐसे ना कि you can't go it the other way. I'm sorry, but it is designed that way that you have to enter it from the right side.
प्रैक्टिस कर लिया आपने ये नेक्स्ट बैच है टी ब्रेक हो गया अच्छा ओके
So whosoever have finished, go in for it.
ना वो जो आप कर रहे हो ना गौरव, डॉक्टर गौरव, सेम मिस्टेक हम लोग भी करते थे, ऐसा नहीं, लेकिन जो कर रहे हो वो ठीक है, डल तो जाएगा, लेकिन अगर मैंने ये 100% मेरा ये है, अगर आपको करना ही है तो इसको यहाँ कर दो, इसलिए तो सिंपल ये है, बिल्कुल कुछ नहीं लगाना, इतने हल्के से करा मैंने ताकत।
Okay, so once again, good morning everyone. Today we will discuss about very important aspect of our field, which is I think more or less ignored, that is wound care. What happens? Wounds and diabetic foot are major cause of death. It is much more than we think about. HIV or any other thing leads to deaths in India or in Asian region. In one patient, foot is getting amputated because he was not aware, because his doctor was not aware, and because they were negligent, not careful. When it starts, and at that right time, you should treat properly so that you prevent amputation and you can prevent death of the patient. So here we will discuss about few interesting cases with wound dressings. As you all know, there are conventional dressings which are available, but they have problem like heavy soakage, foul smelling, changing dressing 2 or 3 times a day, then cumbersome process. Once the patient is in the room, other members cannot sit there because of the foul smell, because of other associated problems. So now for all these things, there are advanced dressings and wound products are available which you can use, and they lead to very good result. Patient is also comfortable. So now for compression stabilization of any wound or ulcer, very good compression garments are available. As you can all see the problem soakage. So now there are waterproof dressing with negative pressure on the wound side. Small pressure you can apply in the form of over the stitch line. If you put that dressing, it will give small gentle negative pressure so that there is no collection in the underlying stitch region, so that infection or secondary gapping of the wound can be avoided. There are waterproof silicone layer dressing which you can just take out, check the wound and put back again. Advantages, they are painless. Advantages, you can just check the wound and again put it there. They are indicated to be there for 5 to 7 days. You can put the dressing for up to 5 to 7 days with heavy absorption capacity. So high absorption capacity wounds. Okay. ये एक लगा हुआ है ना? Okay. So this video I'll skip. Now what is the goal in wound management? This is very important and basic slide. So there is a wound and there is environment and there is a wound bed. Wound bed is the place over which the wound is there, and then there is environment. So what is the role of advanced wound dressing? To absorb the accident, to prepare the wound bed for healing, and to protect it from the external environment and contamination. So this is the basic purpose of all the wound dressings. And for that, now there are very good dressings available. I'll discuss about few specific dressings because the time is short. So one is allograft dressing. This is available in India as sterile dehydrated human amnion Korean allograft. So placental extract, it has multiple growth products which are there and they have converted into dressing. And for one, I'll quote a small example. The cost of this dressing, same piece, like 7 by 7 centimeter, the cost in US is around 1 lakh. The cost in UAE is around 40-50,000, and the same dressing cost in India is about 700 rupees. So the only thing is we don't know what is available and how and when to use it. So we can use because it is very good at reasonably priced in India, and we should use all these things if we are aware. Now this is a lady who came with a 3rd degree burn contracture, and this ulcer was there post burn from last 6 months, which was not healing. Then she came to me in OPD. It was clean. I just applied this dressing, human amnion Korean dressing, and you see after 5 days. After 5 days, 80% of the wound is healed, and then after one more dressing, it was completely healed. So the wound which was not healing in 6 months healed in 10 days. Now with this kind of infected wound, these dressings are available, and they have, one is plain, one is PHMB. PHMB is polyhexamethylene biguanide. So this is a local antibiotic with very good result. So infected wound with discharge, you can use PHMB coated dressing. There is one more dressing which is non-sticky dressing available in India. It is a US product. It is moist wound dressing with hydrophilic PVA, methylene blue and gentian violet, locally acting antibiotic, which absorb fluid with broad spectrum antimicrobial action. So how it works? It provides gentle negative pressure, it absorbs exudate, it removes toxin from wound bed, bind harmful endotoxin, and reduces pain. So when you take this dressing out, mostly when you keep a gauge piece in the cavity and you take it out, there is loss of healthy granulation tissue and painful. In a cavity you pack a dressing, you take it out, very painful. But this is painless, it slips out, and the granulation tissue which is coming, small microgranulation, that is also not lost along with the dressing. So it is very good in the deep cavity. It is active against so many organisms. For example, this patient with trauma and this very deep wound, it is a large thumb forceps going inside. If you keep a gauge pack inside and you take it out, it is very painful. Daily you need to do the dressing, that is also painful. So pack this, change it after 3 days, and when you take it out, it slips out, painless and low loss. So wound heals. The wound otherwise which is healing in 6 months, heals in a 1 month if you use these kind of dressings. Also, when half of the area of this patient was ready for grafting, half was not ready, so did a graft and applied over that half area. Remaining half, when it was ready, did the graft on other place. So this dressing protected one half of the graft completely. Now this is a patient with abdominal mucormycosis, and we all know the mortality is almost 100% in abdominal mucormycosis. This patient post-trauma mucormycosis, entire abdominal wall was removed. So the abdomen was like an open box and bowel was visible. There was no cover. On this also applied directly hydrofera, and over that WAC, nice granulation tissue developed. You can see the blue dressing over that black foam WAC dressing. You can see this nice granulation tissue coming over the intestine and omentum directly, and with that it was very healthy. Later on a mesh tucked inside, and over that also granulation came and did a skin grafting. So this is a single case in the world which was saved after abdominal mucormycosis, and patient is also doing well. Now this is very common problem, peri-FJ bile leak and all these things. These are very common problems which are happening, and the patient feels like somebody is burning his skin 24/7. So that burning sensation is there because bile is very irritant. But what to do? You just keep it dressing and change, but this is not healing. It is end stage terminal disease. At least you can give comfort to the patient. So what you can do is innovative dressing. This is sacral bed sore dressing which is available. Many companies available. So what I did was I applied zinc oxide paste and applied this dressing on one end and similarly on other end. So what happened? It covered the FJ tube. Whatever bile was coming, it was coming over the dressing, not on the skin. And whatever remaining was going inside also, because of this white foam, it is high absorption multi-layer coat, this white thing, whatever comes in the contact of skin, it goes automatically with the capillary action at the topmost layer. So the patient was comfortable next day. So this is, we don't understand that kind of pain, but to the patient it was a blessing. These kind of very bad sore, bedridden, 98-year-old lady and bedridden, quadriplegic, applied, nicely cleaned, hourly change of position, good nutrition, alpha bed and sequential back dressing was applied, and this lady with such a bad sore also healed in 2 months. Otherwise she was definitely going to die. Bad sore, they eat up the patient, we all know. And this lady, you see, did wonders. Why? Because of common sense, because of good nutrition, good basics and sequential back dressing. What is sequential back dressing? So one part heals, you leave that part and move 2 centimeters behind. So what happens? That sequentially the above area heals quickly. So this is sequential dressing and very important in bed sore. Now there is an open porous matrix dressing, and it is made of native collagen fiber and contain elastin. So how it works? So this is how all the wound healing works. Accelerate cell invasion, long-term survival and proliferation of fibroblast, good cell invasion and regeneration. These all things are required for wound healing. So now dermal implants are available, cadaveric dermal implants, which are very good For healing, artificial skin graft, you can say, you can apply in OPD also. No need to put in the operation theatre in the anesthesia, because most of the times these patients are very sick. They are not fit for anesthesia. So you apply these dressings, and the healing is not exactly similar to natural skin graft, but it is 60 to 70% faster than otherwise normal wound healing. So this is a patient, diabetic, morbidly obese, with joint involved, advised amputation outside at 2 hospital, came to us. You can see the condition of the wound, ankle joint is involved. Did multiple debridement, you can see artery forceps going deep inside the tunnel. So everything opened up and cleaned nicely. This you can see in the second slide. I am drilling the bone so that over the calcaneum I made small holes and applied high pressure wax. So granulation tissue came out from those drill holes, and it was over the bone. But still over the bone you cannot do anything, because you cannot do a graft and other things. These are the videos which I'll skip. You can see now over the bone, you can see red spots. This is the granulation tissue coming out from that hole. And later in the second slide, you can see it is nicely covering also, started covering over the bone. At that stage, applied this dermal graft in OPD, stapled nicely, and you see very good uptake, 80% uptake, and this wound started healing and healed in 1.5 months. You see this. Now these dressings can directly be applied, these dermal implants can be applied over open bone, over the open exposed ligament. You just need to put a vac over that, directly apply these, and after that you can do a graft, 100% uptake. So previously where it was contraindicated, now we can use there also. This is a exposed mesh with one large 30 by 30 centimeter mesh after hernia surgery, infected, slough coming out, but because of these all implants and dressings and vac, not even 1 centimeter of mesh was excised and wound healed nicely. This is how we apply it, which is very simple, so no need to demonstrate. This is a bed sore with, you can see a small kind of sore or developing ulcer over the scrotum, and this patient was having loose motion 25 times a day. So how you put a dressing which sustain there? It is not impossible, because watery motion, diabetic patient, morbidly obese, all these conditions, bedridden. So it's kind of headache. You don't know what to do. So in these kind of situation also what you can do is, and that also is going to develop Fournier's gangrene if not treated on time. So in these patients, the silicone based high absorption capacity dressings, and then this is Duoderm CGF colony granulocyte factors. This dressing is a square, so in the center I made a circle, applied in the perianal area, so that whatever that perianal raw bed sore area is there is covered nicely, and the patch applied over the scrotum, and over the top bed sores applied this high absorption capacity silicone based dressing, harmless to skin. So these all things, you see, after 20 days 100% healing is there. So this is very quick, but we should know what to use, when to use, and where to use. This is a bariatric surgery done at outside hospital. Patient came to us after 2-3 surgeries, pus pouring out from the incision wound and abdomen like this. 2 times we applied the vac, but you see the condition. It looks like it was not settling down. And always, whenever you take the vac out, in the container also it's coming, and the wound is also not healthy. So what we did was, we started packing in between, like we went under the liver, because everything is open, over the liver, suprahepatic space, near the abdomen, perisplenic, paracolic gutter, there also we packed that dressing, hydrophorablu, and then from the cavity when it started sucking out, it started showing response. Now you can see open abdomen, the liver and the stomach. So now it is relatively better. So we are very happy, just common sense, and this is after 2.5 months. It's healing nicely, no problem, and after 1 more month of the dressing, it completely healed. So these are all, again, this butterfly shaped dressing for the sacral bed sore is available, which is dedicated to bed sore. But not all ulcers heal with dressings. Sometimes you need to know why the wound is there. In this case, it is a non-healing ulcer, underwent skin grafting 18 times. And nobody did a Doppler. When we did a Doppler, it was a varicose vein with perforator incompetence and SFJ incompetence. And once we did this, it healed in a period of 6 weeks without any skin grafting. This patient came to us post RTA. His fault was he forgot to remove his side stent, and he was driving without helmet. So on a divider, he was taking a turn, he fell down, and this thing happened. So at one hospital, so many K wires and all those things were done. Then he was at other hospital, and then finally referred to us. So in this condition he came, and whatever we were doing, wounds we were cleaning, again slough was coming out. Every day we are cleaning and slough is coming out. So then we decided to do something else, otherwise this patient was not going to survive. So what we did, his eyes were also in bad shape, and you need to give eye drops every 4 hours. So how to give? If you, just in case, first of all, on the face, VAC is not applied anywhere in the world. If you apply also, how to give eye drops, because you need to seal it nicely, otherwise VAC will not work. So what I did was this, you can see the IV cannula. So I pasted here with adapt paste, Coloplast we use for stoma bags, fixed it here nicely, and lock. Seal, nice seal applied with adapt paste, and VAC is applied. So when you turn the VAC on, it was working. When you need to put eye drop, just open these knobs, put eye drops, close again, seal again, maintained. So very common sense approach kind of thing, and this worked. You see, this is a VAC with a pressure of 132. Nicely VAC working on the face, and whenever you want to put eye drops, just open the cannula, put eye drops, it will go over the eye, and close it. Again the seal is maintained. So these all things, all these complicated wound, all patient did well. Now this is also available, latest, these are imaging cameras. If you take the picture, they will give you the kind of feeling, how much area is reduced now, what kind of tissue is there, how is wound bed and edge is behaving, and also the type of organism present. It's gram positive or gram negative. So you see here, this taking the picture of the wound, and this is the image. So this is green, is gram positive. So immediately when you need something, you can start the treatment. So these kind of things are also there, which are very good advances. And this is Indian product. So you need to examine clearly the visible injuries. In ER, this patient was here like this, in shock, and when we were checking, this was the kind of thing, like a truck accident. But when we, and this kind of thing, tire marks. So examination, proper examination is very important. This is the slide to explain the same thing. This patient survived, did well. But you see, opposite side, when we checked in the operation theatre, this was the condition. Still not. From the abdomen, I am putting my hand and coming out from the pelvis. You see. So these are the kind of injuries which you can miss. But this is the same patient. Half area was ready, half I did the grafting. She had accident on her anniversary, and first consultant on call refused to treat. She will not survive. But then she was discharged after 2 months on her birthday. So you need to put your efforts. That's why we are here, to do these things. And this patient did well, and after 3 years again she came back with a baby as well. You can see the kind of injury she is having, but after 3 years she was there with us with a baby. Now this is a COVID positive patient referred from Iraq with intraperitoneal abscess, pancreatitis, post-trauma, and he needed debridement. Those days OTs were not there, oxygen was not there. In the COVID ward this patient was there, and COVID positive. So if we don't do something, anyways he is going to die with pancreatitis and other things. So we debrided in the COVID ward. This you can see the pus coming out. I am putting my finger inside under local anesthesia and MAC, and this patient did well with local debridement and drainage under local, and then applying the VAC. And you can see the wound healing nicely, and this is the COVID bedside treatment we did. And now the lady which I was telling, this is her photo with the baby. She came after like 4 or 5 years. So this is that lady with consent, this pic I shared. So important thing is, we all should know how to manage, when to manage, and how and what to use. And these do wonder. Any other patient will forget you, but the patient who you treated a wound, he will never forget you in the life. Thank you very much.
Yeah. Okay, so now we have a quick two talks, one on chest injuries and one is on abdominal injury. So when we talk about chest injury, what is our idea? Our idea is to recognize common life-threatening chest injuries, understand the principles and management of chest injuries, like we've just had a practice with the chest tube bottle also. So supposing somebody comes like this, what would you do? Anyone? How will you handle this? क्या करेंगे? Anyone? Will take out the knife? Then what will you do? अभी इमरजेंसी में आ गए, कैसे करोगे? First thing, what will you do? First thing, what will we do? Talk to the patient. Are you all right? Airway, breathing, circulation, that remains the same. Don't get frightened by the look as what is happening there. So you can do your assessment. You can have injuries, various kinds injuries are possible with the chest. So it is very simple. Anatomy of the chest is very simple. You can have pneumothorax, hemothorax, contusion, fracture, flail chest, pericardial, myocardial. These are the only possibilities that can happen. Anyone? What do we see here? This is black, no bronchovascular markings. What is this case? Pneumothorax. So simple pneumothorax you confirm by X-ray, put in a chest tube, and if considering IPPV, if the patient has to go on a ventilator, then all simple pneumothorax have to be given a chest tube. Another case, this is slightly different from the previous pneumothorax. What is this? Anyone? This is the mediastinum. So there is a mediastinal. So what is this? This is tension pneumothorax. When the air is coming from here and it pushes, then that becomes tension pneumothorax. So here the air enters the pleural space but cannot live. And so the intrathoracic pressure increases, venous return, all the problems take place, engorged veins, the cardiac output decreases because your preload is going to reduce. It's a life-threatening emergency, clinical diagnosis, urgent decompression, like we just saw in our scenario also. And you will see respiratory distress and important, distended neck veins, percussion note would be resonant and the trachea will be deviated to the opposite side. Immediate decompression, as we saw, this can be done anywhere. Second intercostal space is where we do the decompression. Sometimes with the needle you can even put a glove finger. So if you don't have a ICD, you can put a glove finger and cut it here. And this acts like a flap valve. So air can go out but it won't come inside. This is very simple. वो साइकिल का ट्यूब होता है ना, उसका जो valve होता है, same principle. How do you put in an ICD? We have just gone through this in the station. Everybody did that. Local incision, artery forceps, finger, put in the ICD. And once you put in the ICD, the lung is going to expand like this. Now, who is going to tell me what is this? Yeah? आप बताओ. What do you see here? Yes, yes. Everybody's सही आंसर आ रहा है थोड़ा जोर से. बायलैटरल न्यूमोथोरैक्स. और क्या दिख रहा है? ईटी ट्यूब भी है इसके अंदर. व्हाट्स रॉन्ग हियर? चलो, तो गोइंग इनटू टेक्निकल डिटेल्स, और what's wrong in the management here? Yeah, so here is a patient of bilateral pneumothorax. उसको हमने intubate भी कर दिया है, लेकिन उसका pneumothorax नहीं drain किया. So a clinical diagnosis of pneumothorax has been missed, and you have intubated the patient. He's not going to get better because we need to handle the pneumothorax also. Anyone here? What is this? Hemothorax. Exactly. So hemothorax happens more in penetrating. It can cause hypovolumic shock. Lung re-expansion may stop the bleeding. Consider thoracotomy only if the bleeding is very high. So the thoracic surgeons rarely gets called to emergency. Hemothorax है कोई बात नहीं. Emergency doctor usually puts in the ICD and everything, and उससे bleeding रुक जाता है. Very rarely you need a thoracic surgeon to come to emergency. Why? Because जो serious injury होती है, if the aorta में injury है या heart में injury है, वो patient तो मर गया. और जो simple injury होती है वो वैसे ठीक हो जाता है. So thoracic surgeon very rarely gets called to emergencies. What is this? You've seen black, you've seen white. Now this is a mix, black and white. क्या diagnosis? Anyone? This is called pulmonary contusion, and this can be life-threatening. It occurs with both. Suspect if there is rib fracture. Now pulmonary contusion, that picture is not visible on first day. So first day you will see अरे X-ray बिल्कुल ठीक है, 2 दिन के बाद ये X-ray दिख रहा है. So this is pulmonary contusion when the picture comes later, and this can be very serious because it's going to affect your ventilation. Picture comes later, and this can be very serious because it's going to affect your ventilation perfusion very severely. Difficult to see, but can anyone see what's there? Rib fractures. So rib fracture treatment, it can be associated with pulmonary contusion. So make sure there is no contusion, no pneumothorax. Otherwise, you just have to give analgesia. You don't have to do anything, and don't strap the chest. If you strap the chest, patient will develop pneumonia because of your strapping. ये वीडियो चल क्यों नहीं रहा? must be नहीं कुछ एम्बेडिंग का प्रॉब्लम होगा. इट्स ओके. वो सिर्फ ऑडियो आ रहा है, वीडियो नहीं आ रहा. इट्स ओके. सो नाउ दिस वाज अ केस and I don't have the video. Basically this is a patient of flail chest. So supposing this is a patient of flail chest, what happens? Anyone? Yeah, so what is paradoxical respiration? So when I breathe in, what happens? So supposing the flail chest is on the left, क्या होगा? Breathe in में और breathe out में क्या होगा? What will you see? Breathe in में chest क्या होएगा? What is the paradox? So breathe in में, if the flail chest is on the left, the right side will go up. Oops. The right side will go up and the left side will go inside on breathing in. Or breathe out में, this will go down and that will come up. So that is what is paradoxical respiration. When does this occur? Now to have a flail segment, you need a segment. So read this carefully. When 3 or more ribs are fractured in 2 or more places, so you need at least 3 ribs. 1, 2, 3. ये 3 rib fracture होंगे, 2 जगह पे होंगे, तभी ये segment flail होएगा. If the fracture is only on 2 ribs, then there is no flail segment because the rib above is splinting it, the rib above is splinting this. But if there are 3 rib fractures, then the central rib becomes free. And again it has to be fractured in 2 places. Only then it will become free. So 3 ribs, 2 places minimum, then only it becomes flail chest. Now this is an unstable segment. It can cause severe respiratory distress. In addition to analgesia, giving oxygen, intubation and IPPV has a great role in such patients. Myocardial, pericardial, great well, airway rupture, esophageal, most of these would die before they come. What is this, anyone? The heart. So this is a pericardial injury and this can lead to a tamponade again. Here, anyone? Can see the air under the diaphragm going up. So this is a diaphragmatic injuries with the steering wheel there. And that is after the repair. So some questions. What do we see here? CT scan. Can see a pneumothorax. What don't you see here? What should have been here? Chest drain. So patient has gone to the CT scan और CT scan से pneumothorax का diagnosis हुआ, which is not good. This diagnosis is clinical diagnosis. And this is even worse. As we saw earlier, bilateral pneumothorax diagnosed by CT scan. So management is ABC, recognize life-threatening injury, surgical intervention is rarely needed. This is what is there in the chest. I'll continue with the abdomen. Aap on kar do. Any questions about chest injury? And everybody is happy with the chest tube insertion planning there. Now after this we will have scenarios, and after scenarios we will have another skill station where we'll get you to do knotting and suturing also. So abdominal injury. What will you do? Patient has come, क्या करोगे? Intestine अंदर करोगे? क्या करेंगे? Yeah. So the answer is always ABC. Why do we do ABC? Because we are following what kills first. सबसे पहले जो आपका विक्टिम है वो कैसे मरेगा? तो सबसे पहले वो एयरवे से मरेगा, इसलिए आपको एयरवे देखना है. फिर वो ब्रीदिंग से मरेगा, फिर वो सर्कुलेशन से मरेगा. इसको हम बाहर छोड़ देते हैं, 2 हफ्ते तक कुछ नहीं होगा उसको. So recognize common life-threatening injury, understand the principles. So initial assessment is always ABC. You have penetrating injury and blunt injury. There are only 2 types of injury. So another case, what will we do? Rod through the abdomen. क्या करोगे? ABC के बाद क्या करोगे? Okay, let's move further. No, you are in the emergency, you have done the ABC. What's going to happen next? सर्जन को फोन करोगे. I'm a GI सर्जन, आप मुझे फोन करके क्या बोलोगे? हाँ, ओके, वेरी गुड. और क्या बोलोगे? और आप मुझे बोलोगे कि एनेस्थेटिस्ट को हमने कांटेक्ट कर लिया, पेशेंट ओटी में शिफ्ट हो रहा है, आप आ जाओ. So you don't have to wait for me to come to emergency to shift the patient. So before calling me, you call the anesthetist कि इसको तो शिफ्ट करना ही है, because there is no alternative. This is a penetrating injury, इसकी सर्जरी तो होनी है. So you don't have to wait कि अच्छा सर्जरी ऑन कॉल, अभी उठेगा, फोन उठाएगा, फिर कहेगा मैं एक ड्रेसिंग कर रहा हूँ, 15 मिनट बाद आऊँगा. You have to take action directly from your end. Another thing, abdomen, if you have a stab here, what can be wrong? ये chest में stab है. What can happen here? What else can happen? So like if कोई आके मुझे चाकू मारेगा, so I'm not going to be standing like this कि okay आ जाओ मारो. Either I'm going to be fighting back or I'm going to avoid. So to avoid I will bend forward. This is the natural reaction कि आप ऐसे bend करोगे. तो आप जब ऐसे bend करोगे तो this knife what will happen? it will go into the abdomen. The diaphragm on inspiration goes up to fourth space. So a stab even in fourth space can have splenic injury or liver injury. It can go like this. So this was one patient. This is actual my patient photo. Gunshot wound there. ऐसे कुछ पता नहीं चल रहा है. When we went inside, the bullet was actually in IVC. So we were looking around and my registrar was there, new registrar. So he says, sir, वो bullet मिल गया, ये रहा. मैंने कहा रुको रुको रुको. Before that, उसने bullet निकाल लिया IV से and the big fountain. तो उसने bullet वहाँ से निकाला, मैंने अपना अंगूठा वहाँ लगाया, wait. So put it there. Luckily cardiac OT was next door. Cardiac surgeon came, अपना वो Satinsky लगाया, lens लगाया, 4 stitches and IVC repair कर दिया. So the bullet injuries are very tricky. Sometimes one bullet you will see one small hole. Inside it has made 7 holes in the intestine. So when we are looking at the patient, look for laceration, penetrating injury, distension, bruising, external urethral meatus like bruising, what Dr. Abhishek was showing. So bruising will give you an immediate clue कि bruising है, इसका मतलब कहाँ पर injury हो सकता है. Be gentle. ABC is very important. When you do gastric decompression, NG tube, catheterization, all surgical patient don't even think. सर्जन से पूछने का जरूरत ही नहीं है. NG tube डाल दो, catheterized कर दो, IV cannula लगा दो. So पूछना ही नहीं है. We have special investigations. Ultrasound is there. Now fast, most of you will get trained about fast. It's very simple. You just have to look for fluid in 4 quadrants. Fluid बड़े आराम से दिखता है. And once you have learnt it, then this will start looking red. ये जो black दिख रहा है ना, you'll say अरे अच्छा blood है, blood है. CT scan is important. Some cases like pancreatic injury, there's no other way to diagnose. Laparoscopy, again this video is not working. This is a laparoscopic video of mine where we put in the laparoscope to diagnose. So when is a laparotomy required? So very important question. Now for all specialties, when a patient is there with abdominal injury. So now this slide, if you remember this from my side, as a GI surgeon, this is good enough, what I am going to show now. So as we said, abdominal injury, there are only 2 types, penetrating injury and blunt injury. So if there is a penetrating injury, all penetrating injuries have to have laparotomy. Simple, कहानी खत्म. तो 50% काम हमारा हो गया. Penetrating में laparotomy करना ही करना है. Shift the patient to OT, inform the anesthetist. When it comes to blunt injury, is the patient stable or unstable? Stable or unstable means BP pulse. If the patient is unstable, laparotomy. We are not going to think about it. If the patient is stable, now we have time to breathe. So अब this patient we can observe or do investigations. If while observing patient gets worse, laparotomy. If he gets better, continue observation, continue investigation. So this is not part of the original slides. If you want to take a picture of this, because this slide is all I want as a surgeon for anybody in the emergency to know when it comes to laparotomy, because this will tell you किस patient में laparotomy होनी है, किस में नहीं होनी है. As simple as that. And this is simple maths, no thinking. Any questions? So, summarize common site of injury. Assessment can be difficult. There could be hidden hemorrhage. Continuous reassessment is very important. So, same patient who has good AVPU, good pulse BP, suddenly goes into shock. Think, could it be some internal hemorrhage in the chest, or abdomen? So now we will move on to the scenario stations. So we've got 4 groups, na?
Yeah, but we have to create the 4 groups. So you will stay seated for 2 minutes. Can I ask the faculty to come back? We'll distribute and then I'll get the groups.
Okay. So I will ask the faculty, Manju, you move to 1. Dr. Anwar. Next, Dr. Tiwari and Dr. Divya. So we've got 4 there. I will join the table with Manju. बराबर होना चाहिए जरा, just count so that ask the other two to help you handle. After he has finished, then you 3 will give feedback as to what could have been missed and what things could have been done better. After you have finished, then we talk. So we don't talk till the end, and at the end then we just go through कि इसमें से क्या miss हुआ है, sequence follow हुआ है या नहीं हुआ है. तो आप चलो पहले बाहर. And
इसमें हम सिनेरियो कौन सा करेंगे?
A1 नहीं, पहले A1 और A2 करेंगे, then when the thing rotates then we go to B1.
अच्छा अच्छा, ठीक है. कोई भी वॉल्ट.
The scenario is a 35-year-old Australian tourist has fallen off his motorbike in Kullu, Manali. On arrival in hospital, he is having difficulty in breathing. He smells of alcohol.
ये वॉलंटियर हैं, ये आपका क्वेश्चन पेपर आ गया, तो टीम लीडर को बुला लेते हैं. आप समझ गए ना क्या करना है? आइए आइए. यू आर द टीम लीडर, आप उधर जाइए. तो सर ने एक सिनेरियो जो है वो बताया, ठीक है कि बोलिए आप बोलिए कि ये है, ये पे
35-year-old was fallen from the height in Kullu, Manali. On his arrival, he is having difficulty in breathing and he smells of alcohol. He smells of
alcohol.
Difficulty in breathing.
ये आपकी टीम है दोनों, आपके हेल्प के लिए. वॉट एवर ए या बी, आप अगर नाम याद नहीं है तो ए और बी रख दीजिए, या कुछ भी एक्स वाइज है. तो या तो आपको स्टार्टिंग से करना है. यू आर द टीम लीडर, जो भी आप इंस्ट्रक्शन दोगे ये फॉलो करेंगे. या
तू बोल तो आमंत्रण
या आप बोलिए.
आपका नाम क्या है?
ना ना
Hello. Hello. Dr. Prachi, patient has I'll first look, listen and see. There is, it appears to be the breathing on the left side. So we might require to further intervene. That's why you take over. Your name, B, person B. Patient has a history of fall. So please assess the peripheral, if there is any injury, and immobilize. And after that, you take over the IV board cannula.
Can I attach the monitor?
Yes. Take the vitals and attach the monitor.
I'm just exposing, inspecting. Do I see anything on the chest? Okay.
First you, yeah.
Okay. Just focusing on both the sides. On auscultation, is there any abnormality? Do I hear?
Yeah. The air entry is positive or not?
So, yeah, is there air entry on the right?
Okay. Have you remembered this? Yeah. What is the BP? Yeah, vitals, pulse. So, yeah. Okay.
BP is normal. Heart rate is
You tell?
120 by 80.
What is the BP?
120 by 80. Heart rate is 100.
Heart rate is 100. Okay. And what about the saturation?
Chest is
Yeah, tell.
normal. So we can start him on oxygen. 15 liter NRBM we can start. Oxygen we are starting at 15 liter right now.
So there's none. Now we'll just log roll and check the patient.
Okay.
Should we just check the pupils quickly and sugars?
Yes.
So I'll check.
Okay.
Pupils, and we are checking the sugar. Check.
Okay.
Chest was normal, right? Okay. So we have done quickly just airway assessment if we can.
Okay.
And open your mouth. Zip दिखाओ. Okay, he is following the command.
जस्ट लाइक वो जैसे कि एक ड्रंकर करता है, मैं हट जाऊँ छोड़, लाइक दिस. हाँ, वो ओपन इज माउथ, वो खोलेगा ही नहीं, खोल ही नहीं रहा है आपको.
So we can go ahead and do the log roll.
We'll go for log rolling on the count of 3. Yeah.
One person
First on this side.
is on the other side.
Yeah. So on count of 3, ready? 3, 2.
दिस इज अ मिस्टेक.
Yes.
ओके, क्रॉस द हैंड. ये
So 3, 2, 1.
okay.
I'll ask somebody to check
okay,
it.
there is
And
no
then-
spinal
yes.
injury. Okay, this
Back
side.
back to normal. Yes. 1, 2, 3.
यस, सेम साइड ऐसे ही करना है. हाथ को रॉक करना है. अगर आपने हाथ को नहीं पकड़ा तो ये उधर चला जाएगा, तो हाथ को भी इंक्लूड करना है. ओके,
Now on the other side.
या,
On the count of 3.
यस. Yes, 1.
3, 2, 1.
Yeah, there is no spinal injury. That means no is there.
3, 2, 1. Back.
Okay. ठीक है.
Now I'll immobilize the spine. With the help of with the help of the collar. लगाना नहीं है, just रखना है.
Yeah.
Okay? So I'll place the collar after this. Now again for the secondary survey, I'll based on the history of the patient. So I'll look for any pelvic.
Yes.
If at all present, I'd like to immobilize that.
You have checked the pulse and BP. Now reassess the pulse if the BP is low. You have started IV fluid and blood sample आपने भेज दिया है, then ये सब है. तो अब IV fluid दे दिया क्योंकि कहीं से आपको कोई ब्लीडिंग जो है ऐसा मेजर ब्लीडिंग नहीं मिला. तो लेकिन BP फॉल कर रहा था. BP what was the BP? 120/80. It means there is no patient शॉक में नहीं है, BP is normal. लेकिन फिर भी रिकन्फर्म करने के लिए कभी कभी क्या होता है कि हमने देखा ना BP अभी ओके है, आफ्टर 10 मिनट्स BP सडन फॉल करता, तो दिस इज तो रीअसेस करना ज़रूरी होता है. इन्होंने कुछ मिस किया एज ए टीम लीडर, आपको लगा?
GCS चेक कर सकते थे पहले.
नहीं, उन्होंने किया. हाँ, दोनों बताइए आप, इन्होंने कुछ मिस किया एज ए टीम लीडर? बताओ यार. एक
done some mistakes.
कुछ मिस्टेक किया है.
Probably failed to expose the patient.
Just that, so important. But otherwise, you tell me, she has done any mistake?
मोस्ट कॉमन साइन क्या होता है ड्रंकन मैन में? मोस्ट कॉमन साइन जो आपने मिस करा है. आपने सब कुछ बहुत अच्छे से 25 पॉइंट्स सब कुछ बहुत अच्छे से किया. जो चीज़ ड्रंकन मैन में मोस्ट कॉमन होता है वो ये आपने नहीं बोला है. फॉलिंग बैक ऑफ टंग, एयरवे आपको एयरवे क्लियर करना था, अदरवाइज पेशेंट का.
So how do we secure the airway?
jaw thrust, put the क्या था, ओरोफेरेंजियल गुडविल.
तो unconscious, how will you tell?
क्या, क्योंकि है ना,
Collar can be applied before पूरा till the time it goes.
क्या कॉलर, आप जब तक आप कॉलर अप्लाई नहीं करोगे आप फ्री नहीं होगे. आप ऐसे ही पकड़े रहोगे. तो स्टेप बाय स्टेप भी करना है. ठीक है. एयरवे पहले आपने नाम पूछ लिया, कॉन्शियस लेवल, एयरवे.
Not conscious, you have stabilized the spine, then she has taken the airway, she thought she will require some intervention.
हाँ.
She just lifted the chin, see her breathing improved, she just took the mouth gag or something.
अभी ठीक था वो, आपने बीपी देख लिया, लेकिन जब एयरवे उसका ब्लॉक है तो ये ब्लू कलर हो जाएगा, सैचुरेशन फॉल कर जाएगा, सब होगा. तो आपको उस टाइम सही है. इसलिए जो 24 पॉइंट्स ठीक थे, मिस क्या किया, जो पहला पॉइंट था वही मिस कर दिया. ठीक है, सिक्योर एयरवे. ठीक है. प्यूपिल्स, देन प्यूपिल्स चेक करने हैं कि रिएक्टिंग है या नहीं है. ड्रंकन मैन में रिएक्टिंग होते हैं या अनइक्वल होते हैं या क्या होते हैं, क्या देखा है एमरजेंसी में? अनइक्वल कब होंगे, सेम कब होंगे? क्योंकि ड्रंकन है, कैसे गिरा है आपको नहीं पता, हेड इंजरी हुई है, कुछ हुआ है या नहीं हुआ है, ज़रूरी नहीं है ब्लीडिंग हो रहा है ना, तो इसलिए प्यूपिल भी इम्पॉर्टेंट होता है। ओके, एनीथिंग एल्स, कुछ और मिस हुआ है? इसीलिए था ना ये टीम लीडर थे। अब आप टीम लीडर बनोगे तो आपको बोलना पड़ेगा, ये आपको सिर्फ फॉलो करेंगे, चाहे गलत बोलें या सही बोलें आपको, ठीक है? हाँ,
और यू कैन कम,
आ जाओ कोई बात नहीं, अब तो पता ही है, ठीक है, जाओ। करो, ये आपके पास इमरजेंसी में आया, ड्रंकन है।
तुम लोग ने पहले देखा, इसको बता,
सेम पेशेंट,
35 मेल,
30-year-old had history of fall from the height while on airway after assessment. It's just the history.
Just history.
35 male, he had difficulty breathing, he had a history of fall from height. He also under the influence of alcohol.
हेलो, आपका नाम बताओ। दीपिका। Attach the monitors, take an R4 IV cannula while doing that, collect samples for CBC, and blood group cross match.
Okay, fine.
And start the IV fluid 0.9% 500 ml. Okay. Can you just do the
Tell her the BP and heart rate.
Ma'am, I've attached the monitor. The BP is showing 120 by
Just
80.
from the angle of mandible, yeah, try to lift. Is there any noise was coming in the beginning?
जो हाँ ड्रंकन में होता है, मोस्ट कॉमन मैं बता देता हूँ कि जब उसकी फॉलिंग बैक ऑफ टंग हो रहा है ना, साउंड लाइक इस तरीके से साउंड आ सकती है, या मतलब उसका कहीं ना कहीं ऑब्स्ट्रक्शन हो रहा है। ये एक मतलब जो प्रैक्टिकली आपको देखने से लगता है, ठीक है? तो आपको गुडल्स सुबह रखा था शायद, देखिए, तो आपको उसमें गुडल्स जो है वो, हाँ, एयरवे क्लियर हो गया।
After clearing airway, I'll expose the patient. I'll
Start a 50 liter oxygen also.
Cervical column is
दे दियो।
And the BP is 120 by 80. Heart rate is 100
नाउ सैचुरेशन इज हो गई। जब उसका फॉल बैक ऑफ टंग हुआ था, आपने ना एयरवे क्लियर कर दिया, सैचुरेशन इज हो गई, ठीक है?
Anything else you want to do? Anything else you want to take? Second one, sir.
Yeah. So we'll just measure, see if there is any long bone pelvic, just see if there is a distracted pelvis and any long bone injuries majorly. Okay, other than that, meanwhile, I'll just quickly check the pupils and we'll just check the sugar. Yeah. So we can check the sugar. How much is the sugar?
शुगर का नहीं, पहले आप उसको स्टेबलाइज कर दो।
लॉन्ग एस्टिमेटेड एक्सपोज करके,
हाँ,
एक्सपोज करके pelvic
ये जो सैंपल इन्होंने लिया है, जो सैंपल लिया है ना, उसी में शुगर हो गया होगा, ठीक है?
And the chest injury, sorry, auscultation was normal. So there is no per se life-threatening chest injury. So we'll quickly go ahead with the log roll for the patient.
ठीक, उसमें
We
होगा
can
तो
apply
एक
the
मिनट
pelvic
जस्ट
binder before that.
there is injury, we'll apply.
There is injury.
There's no long bone fracture or deformity, and can you see any
So at the
injury?
count of 3, we can just quickly log roll. 1,
ठीक है,
2, 3.
यस, ठीक है।
Spine is okay.
1, 2, 3.
ठीक है, ये आपका हो गया। तो इसमें मेनली यही था जो कॉमन था डायग्नोसिस, ड्रंकन मैन था, तो फॉल बैक ऑफ टंग के हो गया था। जब आपने एयरवे क्लियर करते के साथ ही पेशेंट बेटर हुआ, ऑक्सीजन स्टार्ट किया। सर्वाइकल कॉलर आपने इसलिए दिया कि अभी आप नहीं जानते कि सर्वाइकल इंजरी है या नहीं, क्योंकि ट्रॉमा के केस में हम मान के चलते हैं कि कुछ भी हो सकता है। और जब सर्कुलेशन का स्टेप आ गया वो सब किया तो लॉग रोल आपका कंप्लीट होने के बाद सीनियर होगा, उसके बाद जिसको भी बुलाना है। नाउ द सेकंड सिनेरियो, हु इज द टीम लीडर, ठीक है। आप जो एक
सिनेरियो चेंज करेंगे।
हाँ है 25 year old woman has been assaulted with cricket bat. Okay. On arrival in hospital, she has extensive facial injuries and respiratory distress. She is sinus and is making growing sound. Okay. उसको 25 year old woman has been, तो क्या आप क्या मैनेज करो? You are the team leader, ठीक है। तो वो हो सके एक 25 year old woman has been assaulted with a cricket bat. Okay. On arrival in hospital, she has extensive facial injuries, stridor, respiratory distress. She is sinus and is making groaning sound. ये आपको दिख रहा है। Just 5 minutes और। तो अब आप क्या हो? You are the team leader. How you manage? कैसे करोगे आप?
First of all, I'll check. So like we go with ABC. So I'll check the airway. So is she which is the GCS, because there could be head injury and all. So we'll rule out that. If GCS is
आप करो, आपको मुझे आप करके बताओ, मुझे नहीं पता, आपको सब मालूम है, मुझे नहीं मालूम।
फेशियल इंजरी है बहुत सारा।
फेशियल इंजरीज है, बैट से मारा है, हस्बैंड ने बहुत मारा है बैट से। केस फेस मत करना।
हेलो खुद ही बात करती हूँ लाइक
Okay.
So she can't speak because maybe the facial trauma on the side. So I'll check for the airway. I'll ask her to open her mouth. So she can open her mouth. Can open her mouth. Grunting sound is coming. Okay. So sir,
Respiratory मैंने बोला ग्राउंडिंग साउंड है, रेस्पिरेटरी डिस्ट्रेस है। What does it mean?
So the airway can be blocked.
और आप इंस्ट्रक्शन दो ना, ये दिस इज योर टीम। अभी आप ही सब कुछ बोल रहे हो, अकेले आप कैसे करोगे? आप इंस्ट्रक्ट करो ना, आपकी 3 लोग ये हेल्प के लिए खड़े हैं।
Stabilize the cervical spine. Yes. Prachi, please check the airway.
Please check the airway and get the tools and we will secure the airway.
उसको भी इंस्ट्रक्शन दे।
Chin lift and
उसको भी इंस्ट्रक्शन।
Please check any external.
Large bore cannula.
Large bore cannula and attach monitors for the vitals.
I'm starting 15 meter off.
एंड ये थर्ड वन आप पे बच गए। या
Extremity injuries and
वो सब देखिए, ठीक है। आपने सबको इंस्ट्रक्शन दे दिए।
फेशियल इंजरीज में will you be able to
with the wheel plan. For the emergency meeting we can
इजी रहो, बहुत ज़्यादा टेंस ना हो। एग्ज़ाम नहीं है कि फाइनल ईयर एग्ज़ाम है, इजी होके करो। ABC याद रखो, ABC। ए से एयरवे देखो, पहले आपने उसको कॉन्शियस लेवल देख लिया, ठीक है। मैं रिपीट कर रहा हूँ, कॉन्शियस लेवल देख लिया, नहीं है वो नहीं बोल पा रही क्योंकि उसको सांस में दिक्कत है, वो क्या बोलेगी है, ठीक है। उसको साउंड आ रही होगा, इसका मतलब एयरवे ऑब्स्ट्रक्शन है। तो आपने जब उससे बात की, ए देखा, एयर के बाद आप ब्रीदिंग, आपने ब्रीदिंग के लिए इनको रिस्ट्रिक्शन कर दिया, सर्कुलेशन के लिए इनको कर दिया, डी के लिए इनको इंस्ट्रक्ट कर दिया। सेम सीक्वेंस आपका आ गया। इन्होंने अब वो तो हम लोगों ने अलग अलग करके दिखाया, ये अपना काम शुरू कर देंगे, ये अपना कर देंगे, ये अपना शुरू कर देंगे। कोई भी ऐसा नहीं है कि वेट करेगा कि पहले इनका पूरा होगा, तो ये करते रहेंगे। आप इनको इंस्ट्रक्ट कर दिया, अब इनका काम, आपका काम हुआ। फिर जैसे ही ना कॉलर लगा देंगे, आप फ्री हो जाओगे, ये भी फ्री हो जाएंगे, ये आपके हेल्प को आ जाएंगे, ठीक है। तो ये दिस इज द, हाँ, तो ABC आप याद रखो कि A को इंस्ट्रक्शन दे रहे हो, B आप A आपने देख लिया कि लुक, लिसन एंड फील, B आपने इनको दे दिया, C इनको दे दिया, D इनको दे दिया। A आपका काम है क्योंकि आप है ना यहाँ पे खड़े, ठीक है। लुक, लिसन, फील, ठीक है, ठीक है, आराम से, तो टेंस मत हो, ठीक है। कुछ एक मिनट जस्ट देखिए। तो इस केस में क्या है, फेशियल फ्रैक्चर ब्रीदिंग डीप, हाँ, इंट्यूबेट करना होगा क्योंकि रेस्पिरेटरी डिस्ट्रेस है, ग्राउंड साउंड है, और उसको हाइपोक्सिया हो जाएगा, नहीं तो फिर ब्रीदिंग नहीं है, तो इसलिए इंट्यूबेट करना होगा, सर्वाइकल कॉरल लगाना होगा, ठीक है। और जब जानने के बाद, और प्यूपिल आपने चेक नहीं किया, थोड़ा टेंस हो गए थे आप, इसलिए AVPU याद रखिए। प्यूपिल इसलिए चेक करना है कि उसको बैट से मारा है, तो जब मैं मारूंगा तो मैं ये नहीं देख रहा कि यहाँ पे लगेगा, यहाँ लगेगा या हेड पे लगेगा, मैंने मारा है, ठीक है। तो इसलिए आपको प्यूपिल देखना ज़रूरी है, ओके। और फिर रोल करना है, क्योंकि बैट अगर यहाँ ना लग के यहाँ लग गया तो हो सकता है कि कोई इंजरी हो, ठीक है। तो याद ये रखो, ए आपको करना है, ए बी के लिए इंस्ट्रक्शन इनको, सी के लिए इन्हें, डी के लिए इन्हें, और फिर उसके बाद ये फ्री हो जाएंगी, आपके हेल्प को आ जाएंगे, ये करेंगे, ठीक है। हाँ, यही करना है, तो आपके पॉइंट सारे पूरे हो जाएंगे। लेकिन अगर आप ये करोगे कि ये एकदम आके सब कुछ अपने आप ही करोगे ना, तो आपको याद ही नहीं रहेगा कि आपने दूसरे को इंस्ट्रक्शन क्या दिया। ये टीम वर्क के लिए है। जब अकेला होगा वो लंच के बाद बताएंगे कैसे, ठीक है। ठीक है, अच्छा आप सर अब जो सिनेरियो 3 और 4 कराना है इन्हें, अच्छा ए और बी तो फर्स्ट और सेकंड तो आप लोगों ने उधर कर लिया है, ठीक है।
So we are having this 45-year-old male prisoner and he's stabbed in the back in a fight. So he is having problem in breathing and he's complaining of pain in the right face.
आपको भी है ना, तो ये लोग करेंगे ना, आप भी ऐसे जज वॉच करो, तो जो मिस होगा बाद में बोलोगे कि ये आपने क्योंकि ऐसा ठीक है, आप 45
he is stabbed in the back in a fight. He is having breathing problem and he is complaining of pain in right chest, right side.
Circulation, BP is 90/60 and heart rate is 120. Then the patient is alert and extremity is normal. Log roll reveals stab wound on right lower chest. Okay. So, how will you manage? Okay.
Let's call the team leader. Come. I can start.
Yeah. You just start.
First,
You just. We are not here.
okay. All okay? Name?
Samir. I can speak like I'm not conscious in that thing. Yeah. I'm just because I hear that part. So
He's able to talk with difficulty, no?
yeah.
You have to remember that. Okay? Just ask what is.
Okay.
I'm feeling difficulty in breathing and all.
You don't have to talk. You are having difficulty in talking, okay?
He is having difficulty in.
We have not explained her the
Scenario.
Scenario team leader will not know. हाँ, हाँ.
the 45-year-old male. He has a history of.
She just has to complete the point. She will give you instruction. You people have to complete the point. Only you people know the scenario. You will help.
We'll just tell that this much. 45-year-old male stabbed and having problems. Come with pain in the right chest. इतना ही बताएंगे.
इसको हाँ, ठीक है. He's a 45-year-old male which was stabbed in the back in a fight. He's having problems in breathing and he's complaining of pain in the right chest. Okay. And now they know everything about the ABC. Okay. Just a lot.
Do I see any secretions or any
Vitals,
any foreign body?
any external, whatever we have told you.
I'm just going to expose. On inspection, I see some nothing. On purpose, there is hyperresonant on right side. I'll just quickly auscultate. There is no identity. Right side. Trachea is deep. Okay. So it looks like a tension pneumotorax.
pulse is
You're not going to
110.
help. Team leader is the boss.
Slight tension on the right side from my assessment.
On the vitals part, a pulse appears to be 130, BP is 130/90.
90/60.
Sorry, 90/60. Saturation is on the low side, and I have secured cannula.
Extremity deformities, no deformities.
No extremity
We'll ask for survival.
Collar.
Back assessment. That's
Check.
pupils. These are equal reacting. Okay. Starter and oxygen. Okay. So starter and 15 meters. There is a tension movement.
So, more needed. Airway. So, immediate.
So I'll take a large bore needle, just quickly clean the area, second intercostal space, mid-clavicular line. I'll insert the 14 gauge needle. Do I hear a hiss sound?
Yes.
Okay. This patient will need a ICD, so we'll prepare for the ICD. Meanwhile, we can just quickly do a log roll. After the ICD will be better. So
I have prepared dressing, draping, this thing. I've given the local after locating the point on the anterior axillary line, the 5th intercostal space. I've given the local. After the local, I've measured the size of the tube, made the incision. After the incision, with the help of forceps, I've directed the skin, checked with my tip of my little finger. After that, I've placed the tube as it appears to be pneumothorax directed towards the apex. I've placed the tube. Along with that, I've kept my water still drain intact and secured the ICD. After that, we'll give log roll and check for reassess. Again, we'll go to airway again, check whether it's chest, all the vitals. After that, we'll do just other.
You reassessed. You are on the airway, no? Breathing airway. You have to reassess after that.
what's his name? Hi, can you tell me your name?
Samir.
Okay. I'll just auscultate. Is there air entry on the border sides? Is there?
Here?
It's there. It's there. CT has improved. We'll just give a pain management also, which we forgot. So we will start with the morphine 2 mg. And other than that, other injuries will be there. Abdomen just, is there anything else? So now we can go ahead with ICD kit. Sorry?
When you log in, you see a lot of blood on the right side.
On the right side. Okay, and there is a okay. So in that case, we'll have to 40.
5 minutes for A4 और A3
खत्म करना पड़ेगा
इसके लिए ना A4 भी बचा है अभी हाँ ठीक है फीडबैक
Chest, back and chest. Right back and chest. So feedback to her. She was the team leader.
Actually, we have to give a
आप इसी ग्रुप में हो अच्छा आ जाइए You know the case?
I'm a 45-year-old. I just joined.
No.
Normally, you get what you get from the ambulance. They picked up a guy. He's in bed. He's coming. He has breathing problems. That's probably what you get, right? That is what we want you to be prepared for. The feedback, and then we'll go on to the next one.
He doesn't know, I think, anything. A 45-year-old male prisoner is stabbed at the back in a fight and he's having a problem in breathing. He's complaining of pain on the chest, right side. So he was having pain on the right side and he was there was difficulty in speaking and the patient BP was 90/60, 120 pulse. So they were managing this patient, okay? So they were managing this patient, okay? So what do you suspect?
Pneumothorax.
Right-sided pneumothorax, so they have tension pneumothorax. So they have inserted the ICD. Okay. So feedback.
First thing was we didn't give the history to the team leader what the case was about. Actually, that's why she was not oriented. And after that, she took her. And about the wound.
Third चल रहा है सर. ठीक है.
Next. Who's going to be the next team leader? Yeah, someone next. One for the patient and one for the team leader.
हाँ, patient बन जाओ. आ जाओ. Team leader. Wait कर लो आप. आप पढ़ो.
So 25-year-old man, also a high-speed motorbike. Okay, arrives in the hospital, gurgling, noisy, shallow breathing, unconscious. Okay, left thigh is swollen. Okay, he is drowsy. Okay, he's talking irrelevantly. He has got chest movements equal. Palpitations okay, percussions okay. His BP is 110. His pulse, his pulse is 110. BP is 80 on 30. Okay. He is not good enough because he's not talking.
He's irrelevant. Basically, it's irrelevant.
Irrelevant talk.
Okay. There's a large swelling of the thigh. Okay. And the pulses on the femur is reduced.
So, how will you manage the patient? Just call the team leader.
25-year-old motorbike speed.
Are you okay? Are you okay? Are you okay?
Very nice.
She's unconscious. Doctor, please secure the.
नहीं बिल्कुल सही कर रही है.
She's a 25-year-old man. He's a 25-year-old man who had a RDA. Okay. She has a swelling on the left side. She's unconscious, obviously.
आवाज नहीं निकाल रही. She's very nice.
She's making noises like that, and she's unconscious since she came. The vitals are 80 by 30. 80 by
30, yeah.
Yeah. The pulse is 110.
BP is 80 by 30.
You just a lot.
Doctor, can you secure the spine further? And someone take the large ball IV with the expected of expected of all things in blood correction. Someone check the airway.
Excuse me, can I ask one thing? So in the history, we know about the there's a percussion law.
He needs to explore. He needs to explore. Yes.
Who is doing what?
What?
Who is AB, who is doing C, who is doing D?
Exactly. We can do
Instructions देने आप सबको.
Then someone take deformities also check.
So she's having.
There is swelling. So I immobilize it. I'll also check for distal pulse.
Distal pulse is reduced.
Distal pulse is reduced, and I'll immobilize it first.
So I've exposed the chest area, and I can see the infection is normal. Auscultation was also normal. Percussion was also normal.
आप भी इधर आ जाओ.
Breathing part is.
Then you start with large IV fluid. Large with IV fluid.
Okay, so I've connected the
Quick. She's having snoring sound. She's grunting.
Check airway. Someone suctioning the suction is done.
Asking to. So we can for that.
He has done that.
Secure the airway first with the.
Everything is okay. Auscultation, percussion, everything is done. No sensory and all. I've secured the airway.
Anyone wants to do anything?
You can suggest also team leader.
Go ahead, do the log roll. You want all three to do the log roll?
इन्होंने एयरवे का क्या किया है? देर नॉट अच्छा लॉग रोल कर बस हाँ लॉग रोल यू हैव डन ओके
So that will use the fat so like the trauma is there. Shock हो रहा है.
There is no external bleeding.
No external bleeding. Yes.
Okay, so there is nothing to stop.
Yes, sir.
The patients come with a BP of 80 on 30. What should you do? This is a circulation problem.
Yes, circulation problem, sir. So we'll it's like fluids, like we'll
Fluids
start the
दिया?
fluids. Yes, sir. We'll
कैसे
start
दिया?
it. So wide bore needle से देंगे sir. Like both the sides से.
हाँ, कितना 80 ml
कितना
per
दो
hour?
कितना दो how much of something called as bolus
Bolus.
how much of bolus
1 F. Okay, sir. Venous bolus देंगे sir. Start.
Do you think that will help? क्या चाहिए? मैडम पूछ रहे हैं और क्या चाहिए तुमको? What is he lost?
you also come you also tell now you comment
you can give the suggestion
Blood transfusion.
Next is shuttle.
so basically is go ABC airway you put Qdils you have sterilized it breathing was anyways
ये
fine.
second station है
Palpation everything was fine abdomen if it was shocked but there was deformity and the blood loss was there then you have to see whether
what happened to your airway nobody managed your airway
you give 1 meter bolus see whether the BP is coming up if it is coming up if it is staying or you stop the fluid it is going
हाँ
up.
बैठ जाओ
Responder fluid not responders in the meantime you ask for ABO
नहीं तुमने एयरवे का कुछ क्यों नहीं किया वो ग्रंटिंग साउंड भी निकाल रही थी why didn't you do something about airway कुछ भी नहीं किया एयरवे मिस्ड
टंग फॉल है नहीं है पता नहीं
Patient 5 and 6.
ठीक है लेटो
Scenario 5 and 6.
चलो
ये पेशेंट है
हाँ ये पेशेंट है
करना पड़ेगा अच्छा
ये हो गया will be the team leader
वहाँ पे कर भी लिया मैंने
one team leader
मम्मी
ओके ठीक है बड़ा है
We've got a 15-year-old who is climbing a mango tree, falls down, landing on the head. Okay. He was initially conscious. To the family, he is now complaining of neck pain. Over the next 30 minutes, he is becoming. Thank you.
10 मिनट 2 सेकंड चलो बंद वो तो वॉलंटियर
कलर में किस
ये आप लगा दो दे आर रिकॉर्डिंग team leader says again when came to the hospital there was a right-sided seizure. So basically we are looking at a left-sided
Head injury.
head injury or whatever, some sort of a thing which has led to a seizure. क्या हुआ?
पेशेंट उठ रहा है ये तो 5 लोग हैं सर मुझे लगा 4 हैं आप एक
तू ले जाएगा हाँ ये ले
नहीं आप लोग
नहीं आप you will do much more justice than what I would do.
तो इसमें क्या है कि टीम लीडर जो भी करेंगे इसमें क्लू होगा कि जब उसने प्यूपल देखा तो मैं बोलूँगा लेफ्ट प्यूपल इज डायलेटेड अगर उसने प्यूपल नहीं देखा तो डायलेटेशन बनाएगा सो दिस इज द अबाउट दिस सिनेरियो एंड लेट्स सी बाकी पूरे वन ओके कम इन तो 15-year-old boy climbing a mango tree fell to the ground landing head. According to the family, he was initially unconscious, then he became conscious, and now after 30 minutes he again became unconscious, and he had some abnormal movements on the right.
Hello? Hello? So there is no response right now. Okay.
समीर
उनके भी हमें काउंट कर रहे हैं क्या मिस कर रहे हैं आप लास्ट
Airway, jaundice and collect the samples, CBC, triple H, and blood glucose match. Amir, can you do a long bone assessment?
So when he did that on jaw thrust, he's breathing all right.
He's breathing all right.
On monitors, the heart rate is 100, BP is 130 by 90.
Okay. And saturation?
Saturation is 98%.
98. And okay, and quickly assessment of the chest.
Yes, everything is fine.
Everything is fine. Okay. Other than that, abdomen, can you see the abdomen is soft and
Abdomen is soft, no distension, no tenderness.
can you check the pupils?
Left pupil
बहुत
is
सारी
dilated.
मिस के बहुत मिस के
Dilated. Okay. We can just secure the C-spine right now with the collar.
पहले कॉलर ही कर दो
Okay. Other than that, so on the reassessment again, the BP is normal.
130/90.
130/90. Do I see any head injury?
No.
Okay. We'll quickly do a long roll for this patient and exposure before that to see many major injuries and then long roll. I'll stay at the head end. Dr. Amay, can you come to this side and just check the
injuries
spine and if there is any abnormality and also the rapid. On the count of 3. 1, 2, 3. Check the spine. ऐसा टच करके देखो किधर any deformity? No. Okay. 1, 2, 3. Okay. So in this patient, just by the primary assessment, looks like a head injury. Patient will have to get the CT done as soon as possible. Is there still an abnormal movement of the?
No, there is no such movement.
Okay. Initially there was a history, so we can give an anti-epileptic with the airway trolley in place. I mean, with the patient, we can get a CT scan done.
CT scan of
Brain.
only brain.
Brain and C-spine.
Anything she missed?
ये pupils तो किए थे उन्होंने.
Anything you would like to add?
First step, talk to the patient. Patient से बात नहीं किया. क्या?
और कुछ?
Instructions भी नहीं दिए. हाँ,
किया था एक्सपोज.
Injection.
चल. Overall
Good.
Next.
अभी कौन टीम लीडर?
Who's going to be the next team leader? आ जाओ. क्या scenario?
Number 6 scenario. बताओ.
This is a 55-year-old female who is involved in a head-on collision in a car accident. She was wearing a seat belt. She arrives in hospital with dyspnea, difficulty in talking, and complaining of right side chest pain. Okay. बाकी का बता दो.
हाँ, इनको तो बता सकते हैं.
She has an obstructed air. She's making gurgling sounds and snoring. Her respiratory rate is 30 per minute. 30 cycles per minute. Air entry is not there on the right side at all. Trachea is also shifted to left. There is wasting tension. And Baki pulse BP is fine. She's little tachycardic. Pulse is 110. BP is fine. Pupils are normal. Baki neurological deficit. कुछ नहीं. Rest fine. हाँ ठीक है बोला उन्होंने.
उन्होंने कहा बुलाओ, उन्होंने कहा बुला लो.
अरे इनको तो पता नहीं.
अच्छा, इनको बताओ.
अरे हाँ.
You have to tell him ना. You have to tell him the situation.
आपने उनको दिया, then वो देंगे.
Breathing difficulty, barely able to complete the sentence.
This patient was wearing a seat belt also.
Seat belt pennant.
And she's complaining of right chest pain.
प्राची
इसमें होना चाहिए आपने एक बार बता दिया देन वो बताएंगे अगर मिस करते हैं देन आपको बताना है
डॉक्टर संदीप
AB
kindly look for the vitals and secure the Amay look for the peripheral trauma if at all patient are present to the
5 मिनट है हमारे पास
check for the airway.
I'm starting on 15-liter oxygen. Is it okay? Sir?
बोल दिया
No, there is no grunting.
No grunting.
But the patient is snoring.
Sir, I will
Gurgling
just
sound.
the vitals.
And monitor पे vitals में heart rate is 110 beats per minute, BP is 110 by 70.
This one and
Sorry, BP?
110 by 70. But heart rate is 110.
Is this still snoring on the Jata's maneuver? Is there improvement? In
Yeah, there is improvement, but still there is gurgling sound.
Okay. Just do a little suction if there is
Okay,
any
it has
secretion.
improved. Yeah, a lot of secretions.
And is it improving now?
Yes, now saturation is 98. No, the saturation is 90. 90.
Okay. Put a OPA. Okay, done. Okay, put a OPA. Is there a gag while doing it? No. Okay, putting a gag नहीं है ना? Okay, putting OPA.
गैग होना चाहिए
अरे normally yeah.
कोई नहीं बताएगा आपको
है गैग है
Gag. Sorry.
Okay. We can put a NPA. I mean, depending on further assessment. Decision लगा के
You have assessed periphery. Again, the cervical collar. I'll place the patient on the cervical collar till that time. Okay.
Since struck
What?
that was breathing. I'll check the breathing.
Okay.
Inspection. What was the findings?
Expose, inspect.
Yeah,
There is any,
expose. Like I've inspected it. So there's a equal outside. So that percussed it. So that on the one side it was
on the right side.
Yeah, on the right side it was
hyper resonant noise.
Yes, on the right side. It's an auscultation also. Auscultation also.
Auscultation में the air entry is not at all there on the right side.
Not at all.
Not at all on the right side.
Not at all on the right side. So it appears to be tension pneumothorax. So I'll ask to with the help of bone needle. I'll immediately on the mid-clavicular line. I'll just give away for the needle. Put the needle, and then I'll ask Prachi to arrange for the ICD placement. Meanwhile, I'll also check the pupil of the patient.
Okay. Now patient can talk. Patient saturation is improved to 96%.
Everything. After this, I'll go for rolling of the patient to assess for any.
क्या मिस किया
Circulation तो
किया ही नहीं हाँ ब्लड सैंपल नहीं गया
क्रॉस मैच
succitation, BGCM, HB.
You have to give clear instructions.
It comes with practice. Don't
While advising for the circulation, I'll ask them to collect the samples and.
So instructions have to be clear. Place a large bowl IV, collect sample and send it for whatever you want, and blood for cross match and reservation and
rather than
cross match.
You could have done circulation. If she was doing
airway, he was doing
breathing.
अच्छा okay fine.
Yeah.
ठीक है एक बार और करते हैं रिपीट करते हैं है ना
ठीक है let's start from the beginning.
You have to give clear instructions.
Okay, fine. I'll first look for the responsiveness. I'll instruct Dr. Prachi to look at the airway. You can talk to the patient.
Talk. Ask his name.
नाम क्या आपका?
अब हम देखते हैं फटाफट क्या मिस हो रहा है
हेलो
पेन है आपके पास
रमेश
कट करते रहेंगे ना क्या हुआ है
कंप्लेन ऑफ राइट साइड चेस्ट पेन
ओह बहुत ही अच्छा पेन है पेशेंट से बात किया
बट
on percussion, I don't feel any entry on the right side. Auscultation also the finding good.
एक आप भी ले लो जो भी याद है फटाफट टिक करना है कि क्या नहीं किया इन्होंने इससे कर लो मैं एक और लेती हूँ मेरे पास भी था पेन तो कहीं
keep ICD drain read for placement of ICD tube. Yeah. Thank you. Tube is placed.
but you don't know the vitals of the patient's
कोई बात नहीं, ये होता है अभी क्योंकि फर्स्ट टाइम ये कोर्स हो रहा है तो इसलिए हो रहा है। सबके पास ये रहेंगे और इसके साथ हम लोग उस पर भी व्हाट्सएप पे ग्रुप में शायद डाल देंगे, आप लोग अभी हो उस ग्रुप में है ना, तो उसमें डाल देंगे। 25 पॉइंट्स हमें सिर्फ याद रखने हैं, क्योंकि एक बार आपको ये याद हो गया ना तो रात को 2 बजे भी फ़ोन आ रहा है ना किसी जूनियर का तो आप तुरंत बोलेंगे ये कर लो। तो ABC हमें सीक्वेंस में चलना है, सारे तरीके से ही हैं, सब करना है हमें, लेकिन हमें सीक्वेंस वाइज चलना है।
मैं आपको एक एग्जांपल देता हूँ। मेरे उसकी बात है, इंटर्नशिप की बात है। मैं तो और मेरी सीनियर इंटर्न थी, पेशेंट आए ER में कॉन्शियसनेस और ऐसा चेस्ट पेन और ये लेके, तो सीधा उसको हमने एक ट्रायल रूम होता था हमारे उधर ले लिया। पेशेंट डरा हुआ है, पेशेंट पड़ गया ऐसे करके, लेट गया ऐसे करके, तो हमने ECG लगा दिया उसको, तो ECG की लीड उतर गई। उस टाइम पे मॉनिटर्स इतने एडवांस नहीं होते थे, वो लीड उतर गई तो वो हो गया फ्लैट। तो मेरी सीनियर इंटर्न चढ़ गई उसके ऊपर और शी स्टार्टेड CPR एंड पेशेंट साइड की मैडम क्या कर रहे हो, ठीक है। सो दैट्स व्हाई टॉक टू पेशेंट,
कंप्लीट सजेस्ट
कंसेंट नहीं, टॉक टू पेशेंट।
फर्स्ट कभी नहीं बोलना है ABC।
डर के मारे चुप करके ऐसा पड़ा हुआ था, पेशेंट डर के मारे चुप करके पड़ा हुआ था, नॉट फॉर एनी अदर रीजन, डर के मारे था। तो उसको पूछोगे तो वो हाँ ना कुछ तो
बोलेगा, नहीं बोल रहा है तो हमें वैसे ही पता है कि पेशेंट अनकॉन्शियस है।
बट पूछना जरूरी है।
फर्स्ट स्टेप इज टॉक टू द पेशेंट एंड देन स्टार्ट लिसन, लुक, लिसन, फील एंड देन स्टार्ट ABC।
चलो रोटेट लास्ट रह गया ये ना, सबके पास एक कॉपी होना चाहिए।
मैं वही उनको बोल भी रही हूँ, सबके पास एक कॉपी,
जिसके पास नहीं है
जिसके पास नहीं है सबको,
चलो नेक्स्ट ग्रुप,
किनके पास नहीं प्लीज।
आप इधर
सर है ना यहाँ पे,
कोई बात
Okay, so the scenario here is a 19-year-old male, a man has been hit by bull in the abdomen. Okay, on arriving in hospital, he is clutching his abdomen and complaining of severe abdominal pain. So this is a scenario, and now we all will see how he is proceeding.
So is there injury is there?
Injury is there, blunt, yes. Hemothorax is there. Chalo, yes. So, some accident case.
So how do you approach patient? So how do you start?
See, you don't need to think here. You just follow the steps, what we taught you. And then we will give you findings if you are correct. Complaining of pain, he is talking nicely. दर्द है उसको, yes, he is telling. Pain abdomen.
He is talking. So as a team leader, you give instructions. Okay. You have to verbalize your thought process.
No, chest movement is reduced on the left side. You asked for chest, airway, so I told you, no, it is clear, okay. So once abdominal trauma, airway is clear, put on oxygen. That part sorted. So the chest examination, there is chest movement is reduced on the left. This is one finding, and there's crepitus on the left lower chest with tenderness. Percussion note is dull on the left, okay, and as on auscultation, reduced breath sound on the left side. You don't tell, he will tell now what to do.
Give instructions.
So, when it was sending sample.
Yeah.
Routine time. Triple X,
So once you given the instruction, just make sure that everybody is doing what they are assigned to do as well. So you've got third person who's doing nothing at the moment. So what would be your instruction to that?
Yeah, check for extremities for the injuries. So he's also assigned. Now what?
Could you check for the peripheral injuries as well?
No injuries. Okay. Now he's free.
Have I touched the monitors?
BP is okay. BP, sorry, 80/40. Yeah.
We'll start.
Heart rate is 120.
Start pushing fluid. Start pushing fluid.
Yeah, already started. You told him already. Although little late, you should have assigned all the tasks in the beginning. You assigned him late, but still okay.
Tramadol for the pain.
Okay, given tramadol. Still complaining of pain. He is still restless. Abdomen is okay. Soft. Tenderness is the right upper, right subcostal and right supracostal region.
Breathing में there is a respiratory. You have to intervene with that.
Yeah.
Percussion dull motor.
No. Why you are telling?
There might be a tension pneumothorax because there's the decreased air entry there.
Okay, fine. Then tension pneumothorax is there. Okay, fine. What you will do next? Do you will do or somebody else is doing? You assigned her. So okay, fine. Do okay. Now he guided you finally. Now you do what you want. Okay, I'll give you leads now. Yeah. You do. Yeah. Now you can do, no?
There was a dull motor. It's like a hemo could be there.
No. You don't tell diagnosis. You do what he's asking, no? You follow. You put a okay. Nothing is coming out. Nothing is coming out. No no air. BP now is still falling. 70/40. Previously it was 80. Now 60. Now 50. Now it is 40. कुछ करो भैया, पेशेंट है इमरजेंसी में. Do something.
We'll start pushing blood.
ओके, ब्लड इतनी जल्दी आ जाएगा? फटाक से लेके डाल दिया.
क्रॉस मैचिंग करने के बाद.
हाँ तो फिर कुछ और करोगे अभी? बीपी अगेन ठीक है. हीमोथोरेक्स का यू विल डू समथिंग. You will put a chest tube.
Yeah, chest tube.
It is a very important thing. You will put a chest tube and immediately he is feeling better. Now you ask IV fluid, he is maintaining, BP has picked up, arrange for the blood, emergency transfusion will be done. But here, all the findings in the beginning, I told her, chest movement is reduced. Then there is a crepitus on left with tenderness. This percussion note dull on the left side, and then auscultation reduced, press sound. So when all these things are there, immediately this needle thing and then ICD. And although you missed that blood arrangement, IV fluid and all those things, but that is also very important because in the beginning I told you BP is low. Okay, so you just need to follow the steps. That's all, nothing else. If it is chest injury, it is fall from tree. If it is car accident, if it is a stab injury, if it is assault, if it is fight, whatever, follow these steps. Come, hello, how are you? Not talking, difficult breathing, look, listen, feel. Come and check for airway, do something. You will put cannula and send blood for investigation and start IV fluid. You check for the extremities. Done. Your job is over. Now she is examining. She told chest this, everything is this. This is a finding. She will put no. Then you will ask arrange ICD. She will ask arrange ICD quickly. So once he is meanwhile free, he checked no external extremity injuries are there. Arrange for the blood. Okay, fine. He is inserting the cannula, large bore cannula, sending blood for investigation, pushing IV fluid and arranging for blood. Done. Okay, so it looks complicated, it might confuse you, but once you revise, this is the simplest way to handle an emergency. Okay? Chalo, good. Thank you. So we are done for the day, I think, sir? Great. Chalo, good job. Very nice.
Hello, 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 hello.
It looks like all the scenarios have settled. Can everybody settle down? Okay, so the next is on limb trauma. So my name is Dr. Tavri, I'm one of the orthopedic surgeons. So we're going to talk about limb trauma. It's okay, you can hear me. Acha, video. So what do we aim after this? So at the end of this, we should have a structured approach to any limb injury, and we should be able to treat the limb injury. So we go by a scenario. So we've got a 35-year-old man brought in the hospital who stood on a landmine. Okay, so what do you see? A limb that is destroyed pretty much. Okay, you've got muscles falling off, you've got bone exposed. So what are we thinking here? So what do we do first? You can talk in chorus or I'll talk. It can be either. So what have we learned so far? So it's come like this. What are we going to do first? Loud, loud, loud. In chorus. It's fine. Primary. So what is primary? A, B, C. Correct? Okay? And then you'll have an approach towards limb examination. Okay? So primary survey. A, cervical spine. We'll stabilize. We'll check breathing. It's a huge injury. So when you see something like this, you cannot say that is the only injury. You have to ascertain that that is the only injury. So you have to first go through everything else and make sure that that is an isolated injury, then put all your focus there. Okay? So breathing, circulation. In disability, you will probably see that. You'll probably do something for it at that time. And then you will see for other injuries on exposure. Okay, so in limb trauma, what do we get? We get peripheral hemorrhages. Some you see, some you don't. If the wound's open like this, you will see peripheral hemorrhages. Then the wound's open, so there is worry about infection. And if we don't treat them, there is a worry about disability, because everything that bleeds is going to die at some point. So assessment wise, we look for ABC, and then we look for the color of the limb, deformity, we look for any wounds, any swelling, any blood, which is a standard thing that we look for every time on any limb in any patient. Okay? Then we can, once you have done the ABC, you feel the limb, look for any tenderness, any swelling, any crepitus. And then actively, passively move. If you have problems with any of these, don't go on and actively, passively move, because you could just create another problem for yourself. So in management, what we need to do is, we need to control hemorrhage. That is the first thing, because it forms a part of C, if you see any external hemorrhage. You maintain perfusion, again C. So get access, give fluids based on what you see. Okay, invariably if the limb is involved, is a bolus. You give fluids. Okay, because there's going to be a bleed. You prevent necrosis. Now how do you do that? So you see which part of the skin's come off, how much of it has come off, has it got vascularity or not. However, that's a part of beyond D&E. It's a secondary survey thing. Because if you maintain perfusion, you reduce the risk of necrosis. So you have to first maintain C to make sure that you don't get a skin necrosis. And then prevent damage to the nerves. Okay? So nerves do form a part of the limb. Only having a fracture, only having a bleed does not mean you ignore the nerves. Okay? So how do we control the hemorrhage? So if you see it, something pouring out, what are you going to do? Put pressure. Okay? What is the next step? So if it's a limb is involved, you've got a femur fracture, it's bleeding, you don't see it. It's not externally bleeding. How do you stop the hemorrhage? Traction. What does traction do? Have you ever thought, why do we use traction to stop hemorrhage? So okay, so you maintain, so if the bones are skew, you bring them in line, and that stops the hemorrhage. So what does traction do? So it helps you align the bone, or at least attempt towards alignment of the bone. But the most important thing where the bleeding happens is around the bone, in the muscles, around the subcutaneous tissue. The traction will increase the pressure in those areas. It will reduce the volume in that area for the blood to bleed. So you get an internal compression for whatever is bleeding. Okay? So it's very important that you traction it. You will get help from the soft tissues. And then tourniquet. Now tourniquet, obviously if something's bleeding and you've tried to stop it, you've given traction, it's oozing out, then yes, tourniquet has a role. However, you also pay a price for using it, because it reduces the supply to the whole limb. So tourniquet cannot be used for a long period of time. It can be used momentarily to get control. If not, then in a very difficult scenario to get transport. Okay, so you can lose a limb to save the life if you put tourniquet. And that is a call you have to take when you are going for a tourniquet. So don't go tourniquet. Okay, it's your last resort. Management of any limb injury, you have to stop the pain. So you give analgesia, that's a management for any injury for that matter. Okay? Dressings, most of the wounds that are open, you want to make sure that in the secondary survey, or there should not be a future disability. So you control infection. Okay? Align fractures with traction and immobilize the limb, so you can then control every other thing till definitive management is done. Now all this, you have compartment syndrome in it. Now what is compartment syndrome? The orthopedics will probably know, but people who don't do orthopedics routinely, compartment syndrome is increase in a pressure of a compartment. It's very simple. Now everything in a limb is a closed compartment. You increase the pressure in that compartment, you lose the supply of blood to that compartment, you get death of muscle. Death of muscle is future disability. Okay? It causes compression of the vessels, that is, and peripheral nerves. Now, signs of compartment. How do you know? It's a secondary survey or maybe a little later than secondary survey. How do you know the patient is going into a compartment syndrome? Pain. When does that happen? last. So we're not interested in pulseless. We don't want it to become pulseless. Let's put it that way. So pain. What kind of pain is it? Pain on passive movement. That is one. What else? What comes late? First is pain, right? So swelling redness comes when everything is compressed. So pain that is not responding to analgesia. So you're giving painkillers. Patient says pain, you will give painkillers by reflex. You would not say, okay, compartment syndrome check karta hu. Yes, so you give painkillers, the patient still complaining of pain. You give IV, the patient still complaining of pain. You give him morphine, patient still complaining of pain. Then you know something's wrong. Yeah? So that is what happens. Because the longer you leave, the more necrosis you get, the more painful it becomes. Okay? So pain on passive, edema swelling is late, but it is not responding to analgesia. Okay? You can then get decreased sensation, weakness, and muscle death. So these are easy to remember, but the last ones. So management of compartment syndrome, open the compartment. This is called fasciotomy. It is effectively just opening every compartment. Compartment starts from the skin and ends in the muscle. So you have to take skin, you have to take the fascia, you have to take the muscle fascia. Okay? Open fractures. What do you consider? Okay, so what is an open fracture? Anything communicating with air and bone is an open fracture. They will externally bleed. You have to stop the bleeding. We know that from the previous slides. Now the important bit here is reduce the risk of infection, give them antibiotics. Those are the two things that we want because the definitive treatment has to be undertaken. Okay? Tetanus prophylaxis. It is advised that we give tetanus prophylaxis, however I have not seen tetanus as yet. But we still give tetanus prophylaxis. So knowing where the injuries happened, knowing on exposure, seeing around, you would know. But give a tetanus prophylaxis, it's safer. The next important that we commonly see is crush injuries. We see a lot of crush injuries. So crush injury is collapse, RTAs where something's gone over, okay, explosions, traumatic amputations. The problems with crush injuries is you get a lot of myoglobinuria. So that is the problem. It's not about that hand. We're not worried about the limb at this moment. We're worried about what that limb is causing to the rest of the body. Okay, so you get a tea-colored urine. Now, I don't know when you put in a catheter to get the tea-colored urine, but anticipate that you'll probably get a tea-colored urine. They will be in renal failure, they'll be in shock. Okay? So you need aggressive IV, bolus with fluids. If you can get a catheter in, fine. You can see the color of the urine, then you can alkalize the urine. Otherwise, I think alkalization comes a little late. So, limb trauma. What do we understand? You have to make sure that the ABCs are sorted before you attend to the limb. You look for any external hemorrhages. You look for any internal bleeding. You apply adequate traction and support to the limb. In cases of open injuries, we do sterile dressing, antibiotics, tetanus. In cases of crush syndrome, we are worried about the kidneys. So we give fluids. In all these cases, we anyways give fluid, but in one case. So any questions on this? Okay. So in summary, early treatment will prevent disability. Avoid tourniquets because they can also cause a disability. However, they can be life-saving. Okay? Beware of compartment syndrome, so keep an eye out for it. And give adequate pain relief.
Lunch.
Dr. Sanjay Das, sir, please.
How do we know who's giving the moment?
Zoom karo.
The person taking should usually be like this.
There, sir. नहीं वो आपको देंगे. Dr. Agnivesh Kapoor.
Thank you.
सर आपको नहीं रुकना, आपको बाकी देना. Now, Daresh sir will give it to Ravi. बाद में बताता हूँ थोड़ा. डॉक्टर मंजू शर्मा. सर आप वहीं रुको, वो तेरे को लेके जाना है. 13 मिनट का कुछ इशू है, मैं कर देता हूँ. डॉक्टर अभिषेक तिवारी प्लीज. थैंक यू. डॉक्टर विजय तिवारी. डॉक्टर गौरव पांडे. डॉक्टर अंबर खान. प्रसाद sir, can I request you on stage to give some? नहीं हो गया वो आप क्या. डॉक्टर दीपाली राजपाल प्लीज. गौतम काले. मैंने नहीं बनाया लिस्ट. आई नो व्हाट इज गोइंग ऑन देयर. कहता का नाम लास्ट रखा है तो बोल रही है. चरिता प्रधान. ये नहीं है ना. रवि के हमको सुनील का भी देंगे. सुनील का लगेगा. सुनील का उसका बनाना है. लास्ट में नाम चेंज कर नाम देखो. डॉक्टर रवि किरण प्लीज. प्लेन नहीं है. प्लेन नहीं है. इनका से वो नाम है.
लास्ट डॉक्टर नितिन जगह से. So we'll move on to the next session, head trauma.
Thank you, sir.
And call Dr. Ravi.
He's got the mic. Here and there.
While he's getting ready, special thanks to two volunteers. Special thanks to two volunteers, Gauri and Adib. Check. Right. Photo. आपके लिए सरप्राइज गिफ्ट टॉयज आपके पापा को दे दिया है, वो आपको दिल्ली जाके देंगे।
So, am I audible? Yeah. A very good afternoon, one and all here. Thank you for having me here for this small session. I do realize that we have already had a session on the know-how of doing things, especially for the emergency managements, and now we briefly touch on why we are going about doing the things the way we are doing it nowadays in the more scientific manner. Gone are the days where you can do things arbitrarily. So these are the goals of this session. Yeah. So just a scenario, just to start off with. A 25-year-old man comes with RTA or to the hospital. He's unconscious and his breathing is noisy. And this is the scenario that sets things into motion in the ER. And we see that most of us here from the emergency side of things. So what do you do first? What are our priorities? And what are we actually trying to prevent or treat in these kinds of patients? So when it comes to emergency, we always come back to these. That is the ABCs. In a case with a neurological background, you will always worry about airway with the cervical spinal control, because that affects the entire outcome in terms of the cervical spine, the breathing control of the patient. Secondly, the breathing from the lungs point of view, circulation, disability, exposure. Now, head trauma, as we all know, is devastating. It is one of the most common causes of mortality, and there is a high precedence of cervical spine injury. Hypoxia and hypotension, they increase the rate at which there is deficits which occur, and we want to avoid any further injury that has already happened to the brain. So when you talk of brain injury, one is primary brain injury, which happens at the time of impact, at the time of injury. And that, it can be very diffuse, it can be diffuse axonal injury, or it can be small contusions, or it can be penetrating injuries, or it can be a bleed, or it can be a depressed fractures. And what happens later as a sequelae of these injuries is what is secondary brain injury, and most of these, if identified at the right time, can be preventable. And these are the ones which will actually decide how long the patient stays in the hospital and with what kind of mortality or morbidity the patient will be sent home. So what are the reasons for these secondary head injuries? Secondary head injuries occur when, as a result of the primary injury and the sequences of that, what happens to the blood supply to the brain. For example, the patient has a large bleed and it causes a mass effect. The intracranial pressure rises, then the blood flow to the brain reduces, and the reduction in the blood supply can hamper even areas which are not previously injured. So reduced brain blood pressure, brain blood flow, reduced oxygenation to the brain. The circulation might be good, but if the lungs are injured and your oxygenation is low, then a secondary hypoxic injury to the brain might occur. Or sometimes the oxygenation is okay, but the requirement has risen up. For example, patient is seizing continuously. The demand for it increases. The oxygen demand increases. For example, the patient might have fevers because of infections. The oxygen demand increases. So the balance between the oxygenation requirement and the supply is deranged, and that's when you will see, or the patient may be hypoglycemic. And you might be wondering the patient is unconscious. A simple remedy is just check his sugars, which we always do first. So when it comes to cerebral blood flow, this is the Monroe-Kelly doctrine. Every neurosurgeon will swear by this, and this is what we explain to every patient. It is the amount of blood that can enter the brain as against the resistance in the brain, that is the closed cavity. So the mean arterial pressure, which is the forward pressure, and what is obstructing the blood from going inwards is the intracranial pressure. So you would be surprised to know that there have been cases where we have operated on lesions which cause sudden acute hydrocephalus. For example, in AVM we have operated in the pineal region, and we saw that the patient deteriorated the next day. So we took the patient up for angiography. We take the femoral puncture, we push the dye in, and you'd be surprised that the intracranial pressure has risen so high that the blood is not entering beyond the carotids. That is intracranial pressure. It can be because of a tumor, it can be because of a trauma, it can be because of secondary injuries that happen, and that is what we are trying to control during our resuscitative measures. So, if the cerebral perfusion pressure has to be controlled, either you can increase the mean arterial pressure or decrease the intracranial pressure. That's how you get the balance. How do you increase the mean arterial pressure? You make sure that the fluids are going on well, you start inotropic supports, or you reduce the intracranial pressure. How do you do that? Either you alleviate the problem that has occurred, for example a bleed, you take the patient right into the OT, remove the compression what is happening, or you give osmotic diuretics, you give mannitol, you give 3% NaCls, you give your Dexa which will reduce the steroid, the edema, and you try to reduce the intracranial pressure. So the balance is always between these two. So what causes raised ICP as such, raised intracranial pressure? Low oxygen, high carbon dioxide, any brain swelling or hematoma as such, or a head low position which may be inadvertently, which increases the venous return, that it reduces the venous return to the heart and increases the venous return congestion into the brain. So that is why in the ER and all, once we intubate the patient, we keep the patient in the rate, we keep it high so that the tidal volume is fast and it is replenished, and the CO2 washout keeps happening, because carbon dioxide immediately will increase the intracranial swelling and intracranial pressure and indirectly reduce the amount of blood which is entering into the brain. And what can reduce the mean arterial pressure is obviously low volume. So for example, the hemorrhage happening in the brain, it can happen in the lungs, it can happen externally in pelvic fractures. So now we know the scenario. We want a scenario where we do not want the O2 to be low. So how do you make sure of that? You oxygenate. Apart from oxygenate, you will make sure that the airway is correct. In the scenario of a head injury and cervical spine injury, make sure that the cervical spine is also attended to. How do you make sure there is no high CO2? Breathing has to be normal. If his patient is ventilated, keep the rate high, hyperventilate, and cause CO2 washout. Or low blood pressure, we make sure that the circulating volume is correct, transfuse blood or colloids as required. Now when it comes to assessing a head injury, we must have uniformity, because a patient is unconscious and we are not able to, if there cannot be an interpersonal variation in what you actually describe a patient's neurological status as. And this GCS is one of the most rudimentary but one of the most commonly followed rating systems where there is lack of ambiguity. There are some loopholes to this, there are some drawbacks to this, but as such, if you see, this is common parlance from what my ER colleagues will call me and inform. They will say the GCS is 8, we need to intubate this patient. It's too dangerous to keep him. His breathing is noisy, we need to secure his airway. That is the general call that these guys give me. Yeah. So when it comes to GCS, we must understand that each point is very important, and eliciting that particular point is important. Okay, so the score is out of 15. The trend of GCS over time is most useful. It describes the responses that need to be done. So when we describe GCS, even though this is one of the most repeated things, it is very important for us to understand what we mean by each of these. So when it comes to eye opening, if the patient is just looking around, that is spontaneous eye opening. If you have to call out to him, you call out to his name and then he opens his eyes, that is response to voice. If you have to give him a little pain to induce his eye opening. See, eye opening is the first sign of consciousness. You describe a patient as conscious if he has eye opening. Yeah, so eye opening is extremely important for us. So if you have to give him a little pain for him to start opening his eyes, then you give it a score of 2. And then if there is no eye opening, then it goes to 1. Okay. Similarly, verbal. If he's spontaneously speaking a normal talk, he gives his own history, then you know his score of 5. If he's confused, You ask him something, he gives you a little deviated answer to it. He's confused, but still talking. He makes some amount of sense. You ask him for his name, where he stays, and he'll tell you his native place's address. So that is still confused, but it's still a good sign, a score of 4. If he speaks inappropriate words, completely inappropriate words, then the score becomes even lower. And if he makes sounds, not words, he just blurts out some sounds, then that even is lower, that's a score of 2. Yeah, and if there is no, then the score is 1. So the least score is important, that is always 1. Yeah? And the best motor response is when you instruct him something and he is responding to us, that is a GCS of 6. That is the best score that you can get. Once you go down lower, that the patient has some kind of neurological deficits, then you induce some pain. If you induce pain, if you give him a sternal rub, and if he brings his hands right to your and tries to remove it, that is localizing pain. Okay? That is one step lower than this. Now we come to stages where he is even more unconscious. So, flexes limbs to pain. Yeah? But this is a good flexion response. Next would come that he's flexing, but he's just bringing, but he's not localizing. He's not removing it and taking it away. Yeah? This normal flexion is 1 grade lower. It is important because the control of this cerebral hemisphere onto the midbrain, when that is lost, that is when your flexure response is lost. So it is actually you are localizing. When you try to localize a problem in terms of neurology, you try to localize it ascending, descending, and you try to localize laterality also. Okay? So when you're trying to assess the problem from vertical downwards, the moment the patient stops giving flexion response, you know it is brainstem, that is midbrain and below. When it becomes extensor response, it is the midbrain control on the pons and medulla is also lost. So it has gone 1 level below that also. So now it becomes extensor response. So now you must know, no, the normal tone is extensor. That is, if there is no the supracortical control on the movements and on the basal tone, then everything is extensor. The moment you start going higher and higher, you get finer tuning into all these movements, and that's when you get flexor, and then beyond that localizing, and then at the cortical level, you will start getting actual decisive movements. Okay? So the lowest score, that is 1. Now remember, this GCS is the best response. If you do it twice and you see that there is a discrepancy, you still go for the higher one because you're giving the benefit of doubt. Now, in spite of this, I must put a disclaimer here that you have a patient who have a gangliocapsular bleed which will come, and you will describe it just in terms of GCS. You might say that patient is, say, 12 by 15 or something like that. Okay? But you know the fact, this is because the patient still has eye opening to pain. Yeah, he's 3 points deficit, correct? So you shave off 1 point. He's not spontaneously moving, he's not spontaneously talking, and he's not obeying commands, but he's localizing well. So he has a score of 12. But it doesn't give you more detailed evaluation about neurology, because you know the fact that you are saying that patient is conscious, but he still has a hemiplegia, correct? So GCS doesn't give you detailed neurological evaluation at any stretch of imagination. So for that you go into more detailed, but this GCS is important because when you say over a phone call to a consultant or to inform the next person in over, you say that this patient came with a GCS of 12, 13 or 14. I'm giving this patient in over, make sure that this patient doesn't deteriorate, and if deteriorates then we should know why. You immediately send for a scan, you immediately check his parameters. So we must know that GCS will give you a rating, but it doesn't give you a complete picture of the neurology of the patient. Okay? So a severe GCS is less than 8, 9 to 12 is moderate, yeah, and 13 to 15 is minor, it is still okay. Then we come to pupils. The first thing that anyone will ask you, how are the pupils of this patient? And why are we worried about the pupils? Because in an unconscious patient, there is nothing much to go by. We are worried about herniations, we are worried about raised ICP signs, and the first thing that will go, it's a false localizing sign, but your abducent nerve can disappear. and you can have eye movement, gaze paresis. But if you have uncal herniation, your third nerve will get compressed and your ipsilateral pupil will get dilated. So that is one way of us coming to know that there is some kind of raised intracranial pressure happening which can be impending a little more than that, and the patient can cone. So if you see unequal pupils, that is like in general surgery, gas under diaphragm. You see the gas under diaphragm, we were told in general surgery days, we accompany the patients, get an erect X-ray done, udhar se gas under diaphragm, ऐसे X-ray भाग के लेके आना बोलते थे. So unequal pupils is a neurological equivalence to a gas under diaphragm here. Yeah. So when you talk of pupils, you check for the size, you check for the reactivity, and you check for the equality. So unequal pupils, you are very worried. Yeah. But you are also worried about how well it is reacting. Now, in the past few months, you must have seen 1 or 2 cases where you have a head injury, nothing much in the brain, but a pupil is dilated. Now, why the hell is the pupil dilated? So now you start looking at other reasons. Is it an afferent problem? Is the optic nerve compressed in the canal somewhere because of a skull base fracture? Sometimes we tell you, please go and ask the radiologist if there is any fracture which is impinging on the optic nerve, because if that is the case, the pupil will be dilated and you want the patient to be immediately decompressed, otherwise the vision is lost. Or you want to know if the efferent back into the eye, into the pupil is lost because of a third nerve problem. So we want to check the reactivity. So this is where a scenario of a RAPD comes. You switch the light on one eye, the eye should constrict. The moment you switch it to the other eye, in spite of the light, it will start dilating. So this is a relative afferent pupillary defect. So when you switch it back here and you check the other eye, it will again, why? It will again constrict. And why will it constrict? Because the third nerve, the optic going here, is giving the oculomotor on the other side, and it will constrict. But when it's coming on the ipsilateral eye, the afferent is lost. So now it starts dilating in spite of the fact that you have a torch on the same eye. So the equality, the reactivity, how briskly they are reacting, whether it is sluggish, patient may have had a seizure, patient's pupils are dilated. We worry the patient has come as E1, M1. 15 days ago we had an E1, M1 patient. Today patient is conscious and is obeying commands. So the first assessment gives us the gravity of the situation, but we completely don't write off the patient based on that. So this is the worst case scenario, bilateral fixed, dilated, unresponsive. This is the worst. It need not be purely brain related. It can be because of hypoxia, it can be because of hypothermia, and like I said, it can be post-ictal also, where it might be dilated, you give it time and we reassess again. Yeah? If fixed dilated is very scary, but fixed dilated should correlate with other brainstem signs also before we write off a patient as, the worst case scenario, brain dead. Yeah, we check for the brainstem reflexes and things like that. Unilateral fixed, dilated, unresponsive, expanding lesion on the same side. Okay, that is the tentorial herniation that I explained. Then we look for lateralizing signs. Now, like I said, GCS will tell you, okay, patient is 12 by 15. Now we want to know further details. Now we start, like I said, a gangliocapsular bleed. Now we start noticing he's not moving his left side. Yeah, now we know if the left side is not moving, there's something on the right side of the brain. Okay. If the patient is having mild facial twitching on one side, if the is moving, then you know there is something irritating the facial nerve on this side, whether it's a bleed, whether it's a tumor, whether it's an epidermoid, whatever it is. Yeah. So we try to look for reasons why. Now, like I said, we went top down, we went cerebrum, we went midbrain, we went pons. Now we are trying to understand sideways. We want to see whether it is, on which side of the brain in the first case, and then depending on far more subtle things, we can actually go and localize into frontal, temporal, motor and occipital also. For example, if we go on the basis of the gaze, if the patient is moving to one side, it can either be an irritative lesion on one side or a compressing lesion on the opposite side of the brain. So the gaze paresis to one side. You always inform the patient has a gaze preference to one side. That gives us an indication, look, there might be a problem. It can still be either ways. You look for other reasons. If it's an infective etiology, then you're worried about irritative lesions, meningitis or a tuberculoma or something like that. Or if you're looking for something like a compressing lesion, it can be a bleed or a tumor. you have your gaze preferences. Yeah. So similarly, the motor is obvious. The patient will have weakness on one side. So we try to localize first on the side of the brain, which is the left side or the right side, and then later we try to check within the brain also. If you go into details, you can actually, these are called localizing signs, frontal lobe signs, temporal lobe signs, occipital, motor, yeah, and insular. We must remember there is one insular lobe hidden deep within all these. Yeah. Then we look for breathing. In this slide, if you see, we look for the breathing pattern. You must have, it's more theoretical. It's very difficult to describe this, whether it is Kind-Stokes respiration, whether it's Biot's respiration, it is pontine breathing. These are different types of respirations which might give you an indication like that this is a brainstem problem which is occurring, and it has to be treated on a very, very urgent basis, yeah, before we lose the patient completely. And the posture of the patient, which is basically whether the patient is posturing. Is it decorticating? Decorticating is flexor, and decerebrating is extensor. Decerebrating is the worst, like I said, lowermost. Pons, medulla. Decorticating, you still have your midbrain in control, and above that is obviously much better. So intracranial breathing is bleeding is very important. It's life-threatening. You will get it on your first CT scans. It will shift the patient directly to the OT. May require decompression. These are the classic pictures. This is an EDH. You will have the patient who will be okay when it comes to you, and in front of you the patient will deteriorate, and you will know that there is a lucid interval. And these patients do very well with surgery. There will be usually a fracture overlying it, and the middle meningeal artery may be usually the reasons why the patient bleeds extradural. Yeah? And this is subdural, much worse than an EDH, because the amount of injury required to cause a subdural is much higher. An extradural will just require a fracture, a dural tear, and a bleed from there. But if it goes much deep, the injury is much more grievous, then the bridging veins between this dura and this arachnoid, they shear off and they cause a bleed. And this is when you have a subdural, much more worse than a EDH. And then you have other injuries where small bruise, that is contusions. You have depressed skull fractures. Your base of skull fractures. We must remember when we are talking of injuries like the vault, you have the base of skull fractures. Like I said, you can have a third nerve paralysis, you can have an optic nerve injury, or worse still, in terms of meningitis, you are worried about cribriform plate fractures, frontal sinus fractures, because these will not give you problems right now, because the moment there is fracture, there will be edema there. But once the fracture lines open up after a few days, you will see CSF leak precipitating, and that's when you have to take the patient into OT. You give them time. You may not have to operate, but you are worried about skull base fractures in all these patients because you are worried about meningitis ascending into the brain. Yeah. So base of skull fractures are very, very important. They can cause injuries to the pituitary stalk. They can cause injuries to the infundibulum, and suddenly your patient's going into DI and diabetes insipidus. Your electrolytes go haywire. Yeah. And diffuse brain injuries, these are very important. It is more a diagnosis of exclusion. When you don't see anything happening on the CT scan, you assume that it is a diffuse axonal injury. You can do an MRI, but the patient has to be stable enough to go. Otherwise, a working diagnosis is that the patient has a diffuse axonal injury, and these injuries are just shear injuries. They will take their own sweet time to recover. You have to make sure that the patients don't have secondary injuries, like I described. Make sure that oxygenation, you might have to do tracheostomies, make sure that nursing care is okay, you make sure that the oxygen demand doesn't increase, the level of anticonvulsants is maintained, and make sure that every little bit of support goes into the recovery of the brain, because that is going to take its own time. Yeah? These do not usually require neurosurgery as such. So we come back to this, you make sure that the airway is okay, you make sure that the breathing is okay, make sure the circulation, and in terms of neurology, you make sure that the ICP is not raised, and this is entirely your efforts are made to, so if you have an EDH, SDH tumor, trauma, you will operate. But the ones you do not operate, you have to make sure that the efforts are all going to make sure that the secondary injuries don't happen, because these will prolong the patient's morbidity from days to weeks to months. Okay. So how do you make sure that these patients are attended to? You intubate, you have the slightest doubt, you intubate, you oxygenate, you maintain the CO2 levels, you treat the hypotension, you make sure that the patient is not fighting the tube, you make sure that there is no increased oxygen demand, make sure that the patient is not seizing. You give the mild head elevation, it's enough to make sure that the venous drainage is back into the body and from the brain. We are hesitant in taking a central line in most of our patients during surgery when we operate in the OR is because we are very worried that you are occluding one jugular vein when you put in a central line. And we always have a fight between the anesthetist saying we don't want it on the right side, we want it on the left side, because we are worried of the venous return. And you will believe me, when we operate on the brain, you need to keep the patient's head fixed. And the patient is supine, the head is tilted, you put a clamp on the head and you tilt the neck little more than you than is advisable. The neck goes from here to here and the venous return reduces. We operate in sitting positions. We operate patients posterior for suboccipital craniotomies, go into posterior fossas, acoustic schwannomas. We go from here. The head is like this and it is tilted to one side and it is tilted down like this. Can you imagine the venous return, how it can be occluded? And sometimes we put the first burr on the bone and the bone starts bleeding profusely. That is where we realize that, our position has been little different from what it has to be and the venous return is being occluded. So this head elevation mildly, there's a lot of ambiguity about what is actually required, but a mild head elevation should work. Yeah. We must use the time to do a secondary assessment and find out what else, because you will find deficits later. You have a diffuse axonal injury on day 1. You label diffuse axonal injury and you are waiting for the patient. And 1 week later, the patient is not moving. He's moving his fingers very well. He's moving his elbow very well, but he's not able to lift his arms above his head. This is what we see after you take the patient into the ICU for a week or so. And then you realize the patient is not weak just at his shoulder. Now, is it the spine or is it the brachial plexus? What has sheared off? So we have to look for reasons later, complete the secondary survey and find out what is actually the problem. Because as long as the patient is unconscious, you are not going to understand anything. So the secondary survey is in fact, one of my colleagues had a gold medal winning paper on missed secondary injuries, because you do the primary survey and he found that nearly 20-30% of the findings were what he found on a secondary scan. Yeah. So you have to keep repeating the GCS. You have to look for the external injuries, make sure that there are no bleeds, the bruises, make sure there are no ENT and oral bleeds which can cause infections outside to inside. Yeah, look for movement, power, sensations. Bladder is very important. You miss it on the primary survey, but later you realize that we have been focusing on brain and cervical spine. Patient might be having a dorsal spine fracture and his bladder is lost. You will the catheterized. You will not realize it on day 1. But as the patient gains consciousness, you will find these problems. Yeah, you always worried about deteriorating consciousness, penetrating injuries. We are worried because they can cause infections, abscesses later. Depressed skull fractures are operated for the sheer purpose that the patients will not have an abscess later, because they're compound injuries, external roadside environment, aerobic, anaerobic, polymicrobial involvement. Yeah, we look for neurological signs, unequal dilated pupils, seizures. We look for posturing. Yeah, so head injuries, very, very important. We go back to the basics, ABCs. Isolated head trauma will not cause hypotension. You are worried about other reasons also. You look for other injuries which may overall affect your outcome, and we most importantly prevent a secondary injury. And if the patient deteriorates, you have to keep reassessing again and again, multiple times in the day. That's where the ER and the ICU care comes up. Okay. Thank you.
Thank you, Ravi.
Thank you very much.
Last circuit, you have the energy? Yes? Okay, can we have the green team at station 1, CPR? Yellow team at station 2, which is suturing. Yellow team, station 2, Charita and Dr. Manju. Station 1 is Dipali and Dr. Khan. Yeah. और कौन सा टीम है? है पक्का? दिख नहीं रहे कोई? Red team can go to Ravi. Station 4, red team. And black team pick up a chair and come on the stage. कहानी में थोड़ा twist है. Black team chairs on the stage. You can get the chairs like this. You'll be seeing the PPT. Just move the chairs around. यहाँ पे 3 है.
3 and 4. आपको मैं सिखाते हैं. Sorry? आपको सिखाते हैं.
PTC website, right? It's not.
वेबसाइट खुले.
Okay, I don't know where is.
हाँ वेबसाइट पे है.
नहीं पूरा वो है.
ये सर का है ना आपके इसमें?
नहीं
This is video on trial where we will learn like how to try it in this and show you all the big video. So during the triage, there are 3 T's, right? Triage, treatment, and transportation. So what are the objectives? To understand the structured approach to multi-patient trauma. इसका वो pointer होगा क्या? And to identify serious injuries, right? So to sort out, it means to sort out. A process of sorting injured people into group based on their immediate medical treatment. So how to start simple triage and rapid transport. Triage assessment is based on 3 criteria, which is respiratory effort, pulse, perfusion, mental status, and the categories which we use are black, red, yellow, and green.
अगर ताकि कैमरा में रिकॉर्ड हो और आप उधर उनके पास भी खड़े होके बात करें.
एंड वो चेंज कैसे करूँगा स्लाइड? ये मैं रख लेता हूँ. हाउ डू आई चेंज द स्लाइड? पॉइंटर है यहाँ. RPM 30 can do, respiratory rate less than 30, perfusion 2 seconds, good. If you check, you blanch and check in 2 seconds, it is good. And then motor command, if he is obeying, that means he is fine. Okay. How to classify? Black is dead, red is immediate attention required, yellow can be delayed, and greens are minor. Okay. So this is I already explained. To you. Respiration 30 or less, pulse. If you can check the at the nail bed, if less than 2 seconds, refill, then nothing to be done. And mental status, if he can talk, he is fine. Working? इट्स ओके, देख लीजिए आप, कोई बात नहीं. अभी तो यहाँ से भी काम नहीं कर रहा. दिस इज वीडियो वर्किंग? नो, चलेगा क्या? See, this is video is not working. This video actually, like how you can use green, those who can walk, those who are okay. So this goes inside and immediately does triaging. So if a patient is injured but he is talking, he can talk, BP pulse, everything is okay because he is talking, he can walk, there's no external injury, then he put into green. Black is like you can do nothing. If he is dead or cut into 2 pieces, nothing can be done. So he will also come into black category. Red is immediate intervention, like tongue is fallen back. So if you do it immediately, from red it turns into green or yellow. So all those, or maybe some bleeding is there, or some patient you control the bleeding but needs immediate intervention, so you transfer. So those are red and yellow, which can be further delayed. Like there is a skin cut and bleeding, you compressed, put a bandage, now he is yellow, he can be delayed for some time. क्यों नहीं हो रहा? ओके. Okay. So if this is a group exercise for all of us, a patient states that he can move or he can't move or feel his legs. Respiration is 26, pulse is 110. He is awake and oriented. So what will be the triage category? Tell me. Can you tell me? Anything, it's just exercise. Yes, but why? Because respiration, pulse and oriented, everything is good. He cannot feel lower limbs, probably limb fracture, neuronal injury, so needed but not urgent. Patient is soaked with blood, no obvious arterial bleed. Okay. Respiration is 38, pulse is weak, no radial pulse, and he is awake. What triage category? Yes, immediate, because you see everything, respiration, pulse, and then soaked in blood. So now this patient walks over to you and has an obvious broken arm. Respiration is 22, pulse is 124. He is awake, alert and crying. What triage category? Tell me. Yes. Patient is face down in the field, not breathing, weak carotid pulse and unresponsive. What do you do first and what triage category? Face down in the field. Sorry?
Triage category.
Yeah.
category is red in and stand his position.
See, not breathing, no? First thing. She is not responsive to anything. Okay, this is try. Just immediately you need to decide and move. So, not breathing, not responsive. What else you can do? Weak carotid. You cannot do any miracle, right? So these things. That's why this is there in the last. So summary is identify red. Initial management remains same ABC and go back to. Then you go back to yellow and black. Okay. So our station is over and the message is very simple. Hope you understood. Try how to do it. Chalo, good. Thank you. Please send next one also from there, no? Hani. No problem. Maybe. हाँ आई नो बाकी स्टेशन कर देते हैं या मैं एक काम करूंगा सबका एक साथ कर दूंगा ना
अभी वही करते हैं ट्रियाज लास्ट में कर देंगे
कब को करके
वहाँ पे उनको घुमा के सब
हाँ वरना टाइम वेस्ट होगा क्या
मुझे नहीं करना ना हो गया मैडम
भैया मुझे लग रहा कि
मेरा भी
ये
What are we trying to achieve? Aligning the ball. Okay, we align the ball. What else?
What other
From the pain. That's correct. Because, yeah,
what other problems you get from a broken bone is what he's trying to ask.
Try to put it back into anatomy.
Well, okay, with splints you can only do so much. So, but then if the bone's broken, what happens? What leaks out of it?
These are the secondary injuries also.
What are those secondary injuries?
Will be muscular injuries also nearby structures.
Okay.
Neurovascular.
Yes.
What is most common in fracture femur?
Yes. What goes into the chest?
Yeah. Right. Okay. So because the long bone will release fat, and then you'll have fat embolism. Patient can die. Yes. Patient can die with bleeding. Patient can die with the fat embolism, isn't it? Patient may not necessarily die with the muscle penetration. Will die with these two things. So the whole concept is to minimize that with the splinting and allow the easy transportation. Yeah.
So, kinds of splints. What is this for?
Knee mobility.
Okay.
Long knee.
Okay. So immobilizes the knee. Injuries used commonly?
Meniscal injuries.
Okay.
Cruciate ligaments injuries.
Ligament injuries.
Patellar dislocations can happen.
Fine. So basically in a trauma situation, you'll get a multi-ligament injury. This can be used, not necessarily will be used. Okay. What's this one? Okay. Anybody has used it? You've used it? Okay. So just tell others how can we use it.
It is used mainly in the case of open book fracture or a hip fracture where there is a possibility of a lot of bleeding inside which cannot
Correct.
be seen from outside, and also there is a possibility of shock. So it is put at the level of greater trochanter, not above at the ASIS नहीं है. Greater trochanter, a lot of people put it a little up, and basically it will help clamp all the vessels as much as possible through external pressure. And
So it reduces the volume of the pelvis. So whatever clot you have acts as a compressive.
Okay. How long can you keep this on for? Rough idea. Can you keep it on forever till the patient heals? Yeah. So just be mindful of that.
What is this?
It is Thomas.
Yeah.
Yes. Tell us, how do you use the Thomas?
So it's a shaft of femur fracture.
Yes.
It's the main thing we usually use in the emergency department.
Okay.
And also pre-hospital, right?
Yes. So any shaft of femur, wherever you can find this. How do we use this? What are the parts? How do you? Right? Can you put this on me?
The ring should be in our.
So basically, what I'm trying to ask is there only one size for all? Is it a universal? No, there are sizes. So if anything has sizes, we need to know how to size them.
So we compare it to the limb that is
Correct. Yes.
and then a few centimeters broader.
Correct. And the ring should be a few inches out, so that it doesn't hurt.
Otherwise it will become tight here. So already there will be some swelling because of the fracture. The other leg is normal. Put on the same thing, it will be tight from this side. That's why the 2 inches should be lying in the 2 inches from the normal side.
Which is the outer side, which is the inner side of the Thomas vein? If it's lying in this, is it which side?
Which side split?
This is right.
Now, how do you know that?
This side is a little.
So you look at the angle here.
Angle.
The angle is out, always. We don't want angle in the groin.
And how do you apply splint? What are the preparations you do before you put this splint on?
So it comes with a kit. If you get a kit here. Correct?
That's a weight, yeah. What else do you need? Would it just be sliding it in the bone around the leg, and that will
Hold the leg in the place. So what do you need with this?
We will bandage that right
On the Thomas splint?
After this, we will be tying the leg on Thomas.
How? With a crepe bandage onto the Thomas splint? So you'll use something called a skin traction. So you'll first get traction on the leg, then you'll put the splint on, and you try the traction on the splint. And that is how you maintain length. Okay?
What are the risks with the splint? Can you just put the splint and just forget about the patient?
Yeah, 3 months. Femur will heal in 3 months. Okay.
Neurovascular damage, which nerve probably you are more worried about? You use any of the orthopedic guys? You guys, when you reduce the fracture on traction table,
Yes.
right? Which nerve you can damage? Suspension pudendal nerve, that can have its own consequences. Patient, especially male patient, will not thank you, right? For various reasons. Pressure sores, you can get pressure sores because of the inappropriately applied splint. So even though it helps you for fracture management, inappropriately applied splint can have its own consequences. Right? We want to minimize that as well. That's a well-padded, well-measured splint with an appropriately applied skin traction, and after splint care is important, managing patients. Okay. Any questions? Would you all be comfortable applying splint by yourself? Yeah, in a situation which is not a hospital sector, sometimes you will have no access to the splint. So you can use whatever is available. You can use the bamboo sticks, you can have the towel. If you don't have a pelvic binder, patient with an open hook injury, you can use a bed sheet, right? And that can be a lifesaver, isn't it? Yeah? Good. So use this knowledge, use this kind of understanding, and I'm sure you all know about it. It's best to apply the practical.
So you'll all
skills is relevant.
see when you do them in practical, you'll understand a lot more, and then you get better at it.
For neck of fever, we just put a skin fraction. No, this doesn't require.
Not required.
And sometimes we don't even apply for the leg of femur. After leg of femur, we just give some sort of gutter splint so that the leg doesn't flop.
Intracapsular fracture is already stabilized.
So body will try and bring the limb in the most comfortable position. However, what you have to understand is the most comfortable position the most appropriate position?
Okay. Yeah. Yes. Yeah, so feel free to ask questions. Even though it's not related to this, please kind of use this day for your own learning. So don't step out of this room leaving any doubts in
Any
your mind.
doubts? Yeah. Ask us. Probably is better that we tell you what you're thinking is right or wrong, or how can you apply it.
Good. You are emergency. Are you part of the training? Or you finish your second? How many years?
Second year.
3 years?
3 years.
Excellent. You are in orthopedics.
No, I'm an emergency.
Excellent.
You are in orthopedics. You are in emergency.
Emergency.
You think you are orthopedics here? No, Divai.
First month, first year. It's good. That's good. That's good. So we get who? We get these guys.
These were with you.
Achha, okay. So now this will shift where? These two will move there, they two will come here. Okay.
Now, so right between the middle and index finger.
How much do you prefer giving a fascia block?
Always. Always. Because IV will have, so okay. So what disadvantages of IV opioids?
Respiratory depression, drowsiness, and others.
So in a trauma patient, their airways came obtunded or obstructed, you survived them. Their lungs have had some issues that you have survived. The circulation has had some issues that you've survived. Now opioids can hammer all three, and you would not know what caused it. You would go through ABC again. Because opioid is a diagnosis of exclusion then for you. You would see, okay, airway वापस obstruct नहीं हो गया, lung में pneumothorax था, मेरा pipe तो बंद नहीं हो गया. You'll do all that, right? So why, when you have local ways of solving pain, why do you want to use systemic ways of solving pain?
When do we use it here?
Fascia ilaga, I presume every time, I guess. If you are qualified, Nitin, how often do you use fascia iliaca block here? Every femur?
अभी नहीं ना, we are in the process of making it more regular.
अच्छा.
एक और दो
में वगैरह कितना ही होगा?
What ER से ही आता है? होके आता
नहीं
है?
होगा.
ER से
होगा
आता
तो ER
है?
में होगा.
Because you need ultrasound guys, anesthetist or EMG guy, yeah, emergency guys to do it.
दो साइन डन. सो वहाँ पे जाके तुमको निकालना पड़ेगा उनको, क्योंकि वो हटेंगे नहीं नॉटिंग से. जाओ 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 जाओ, ये तो मिलेगा. We have only 20 minutes. You have to do knotting and suturing. हो गया. Swap. There are extra knotting machines. There are 6 in total. पकड़ लो एक.
अभी नहीं, दो और ना.
the knotting and suturing will be there. Finish your other stations, you can come back here. Because we have something at 3:30 which is a Zoom call. So we need to finish all this and then you can come back and practice. This will be still there.
So the second knot was the only one.
You will need to go there.
One may be considered.
Saima and कौन था तीसरा? Samir, आ जाओ उधर. Then you come and practice later. Suturing team, CPR team suturing. एक हाथी काफी है. Orthopaedic surgeon का. You will wake up. सलमान खान की पिक्चर है ऐसे वो आता रहता है और जग जाती है. कौन सी पिक्चर की बतानी बहुत पहले. आईसीयू में जैसे.
क्या कंफ्यूजन?
दूसरा टीम चला गया.
हो गया ना स्वैप. सुचरिंग.
You are taking care of that station?
नहीं मैं तो कुर्सी का.
Long white. Purple towards you, white away. The next step, you hold like this.
Even in dice they don't use this double head. Yeah. Where it is useful here, not space.
ऐसा कट नहीं करना है. Yeah, ठीक है. You guys are from ortho, which department? Emergency medicine. Okay. ठीक है. So first we'll do simple sutures. Okay. The simple intermittent sutures which we take on skin. अब ये निकाल दो.
Put your middle finger on top of it.
Take this suture. Take this one. नया चाहिए तो ये ले सकते हो. टेक दिस सीजर, निकाल दो इसको नॉट्स को पूरा.
आपको निकालना
डू इट फॉर यू.
ओपन करना, कट करना.
कट कर ले भाई.
कट तो वैसे ही
ऐसे कट कर, ऐसे कट कर. कट हो गया, ये कट हो गया. इसने सब क्यूटिकुलर लिया है. इसका दिस इज मैट्रेस ना. मैट्रेस को इधर से निकालना होता है ऐसा. डन. अब ये सब निकाल दो. ओके चलो विल स्टार्ट नाउ. ठीक है. तो फर्स्ट विल टेक सिंपल सूचर. सिंपल इंटरमिटेंट. Okay, you have to hold skin edge with this tooth forceps. This is a special type of tooth forceps. We call this Adson's forceps. Okay. Always take tooth forceps if you want to suture skin. If you're suturing bowel or something, you take plain forceps because it's a delicate organ. Tooth चाहिए? This is tooth forceps. Suture, yeah, have this one. सबके पास है ना suture? क्या हो गया? ऐसे मत निकालो ना. Take this needle holder. Just have to twist. Yes. Okay.
Over the purple, under the white. Turn like this.
चलो, shall we start?
Put middle finger on top of it.
तो
Put middle finger on
hold
top.
your skin.
Middle finger on top. On top. Yes. Leave
Go from epidermis, come from dermis. This yellow thing is dermis. Okay.
Leave everything
Yeah.
else.
Now.
And pull.
नहीं सिंपल है अभी. Then hold this other edge. Again go from dermis and come from the skin. ठीक है. What is important is this distance. This has to be equal. यहाँ पे मैंने थोड़ा ज़्यादा लिया. अभी जब आप निकाल रहे हो ऊपर the suture material, try to hold skin down from here. नहीं तो ऐसे ऊपर आता रहेगा. Okay. Just push it little bit down. And when you are taking the suture material out, try to do it like this so that you have more control over the thread. Okay. हो गया. अभी see what some people do is कि वो ऐसे इसको घुमाते हैं. Don't do this. What you can do is simple. इसको ऐसे घुमाना है. You move your needle holder. 1 2 उल्टा जा रहा है आप. सी दिस इज द V. हाँ, आपको अंदर से जाना है. 1 2 यस गुड. नाउ होल्ड दिस. किया होल्ड. नाउ यू हैव टू क्रॉस. जब क्रॉस कर रहे हो तो आपको यू हैव टू होल्ड दिस थ्रेड लाइक दिस. इसको नहीं ज़्यादा मूव करना है. ओके, कीप इट स्टडी. मूव योर लेफ्ट हैंड. किया. नाउ अगेन यू हैव टू कम फ्रॉम द V. छोड़ो इसको. यस, होल्ड दिस एंड टाई. हो गया, डन. एंड द थर्ड वन. सो you take 2 2 1, sorry 2 1 1, total 4 throws.
You take all in the same direction or some people?
You have to go from the V. So one, so you have
like this.
सारा alternate लेना होता है.
Second is like this.
Yes.
And third is again.
Yeah. ठीक है. और एक करना practice. You want to do mattress.
Tell me the difference between vertical and horizontal mattress.
Yeah.
So that is confusing.
If you are assisting somebody, I tell you to, you are standing there, I tell you to tie the knot, you say, sir, I can't tie this way, let me come this way.
पहले simple switches लेते हैं. Okay. So this is simple intermittent. Now if you want to take continuous में there are two types. एक continuous interlocking होता है and then there is just continuous. So what we do is एक सिंपल सूचर लेना है, जैसा अभी लिया था वैसे ले लो. ओके.
कितना ऊपर लेके हाथ में लेना है, कितना लेने के बाद हाथ में
आप ले लो ना, पूरा ले लो एंड देन ट्राई टू रोटेट.
इसमें
प्रैक्टिस.
अभी इस पे हो जाता है, ओटी में नहीं होता ना, सीधा नहीं स्टिक.
ओके, करो कि हाँ ले लो पूरा ऊपर. हाँ ले लो, थोड़ा सा और रोटेट करो. ओके, आप नहीं कर रहे हो. यस. नाउ ओके, इसके बाद वी आर टेकिंग कंटिन्यूअस सूचर्स. बाद में लॉक करना कैसे दिखाता हूँ मैं. लिया, कट नहीं करना है. कट किया आपने,
पहले वाला
ठीक है. टेक वन मोर सिमिलर, सिंपल जैसा ले लो. आपने भी ले लिया. अब ये एंड से जाओ और ये एंड से बाहर आ जाओ. कंटिन्यूस के लिए या अब आप
इसी डायरेक्शन जाके
या हाँ सिंपल ले लो, आप सिंपल ले लो. बाहर आया.
नहीं, बट इट्स नाइस यू आर डूइंग. यू आर रियली नाइस. बड़ा फटाफट किया आपने.
सी ऐसा नहीं मूवमेंट होना चाहिए इतना. शुडंट स्ट्रगल व्हेन यू आर टेकिंग द सूचर आउट. हाँ, यू शुड मूव योर रिस्ट में मूवमेंट होना चाहिए. ओके.
मुझे लगा ये कैसे हो गया.
या टेक इट आउट. यस, अभी लीव दिस एंड इट्स ओके. हमें कंटिन्यूस लेना है, तो अभी होल्ड दिस विद योर नीडल होल्डर और इसे बाहर निकालना है बस.
But I have already tied it.
यस. तो अभी ये एंड से जाओ, बाहर निकालो. नहीं, इधर से जाओ, बाहर निकालो.
बट अभी इसमें क्या करना पड़ेगा.
हो गया आपका.
ऊपर जाना पड़ेगा.
आपका प्रॉब्लम ये हुआ है, यू हैव टू नो, यू हैव टू गो लाइक दिस. गो लाइक दिस. इसके ऊपर से आया तो भी चलेगा. इट्स ओके, नो इश्यूज. ऐसा मान चलो वहाँ पे कुछ भी नहीं है.
अभी नेक्स्ट जो है,
ठीक है. तो बेसिकली यू हैव टू कम लाइक दिस नाउ. See, continuous is easy and it's quick also. आया? निकालो, पूरा बाहर निकालो. अब फिर से यहाँ से लो, यहाँ से बाहर निकालो. Quick. That is why it is continuous. When you don't have time for suturing, for closure, you take continuous sutures. हो रहा है, समझा? Just have to take it out. आपका हो रहा है नाउ. हम यही कंटिन्यूस में विल डू इंटरलॉकिंग. ओके, अभी सी लॉक करना है तो यहाँ से बाहर आए आप, बाहर आए ऐसा. देन देयर इज दिस लूप. या आप पहले से लूप से ही बाहर आ रहे हो. नहीं, बराबर है, बराबर है. सो ये लूप से बाहर आना है, राइट. ऐसे सी यहाँ पे लॉक हो गया. सो दिस इज डिफरेंट, दिस इज डिफरेंट, दिस इज इंटरलॉकिंग. ओके, हो गया. नाउ अभी ये लूप बन गया. अब आप ये लूप से बाहर आ जाओ. यस,
आपको सिखाओ.
तो फ्रॉम ऑर्थो ना, क्या सिखाना है?
नहीं रे, इमरजेंसी है.
अच्छा ठीक है, चलो. या ओके, डन.
खोलो.
दिस इज, हाँ खोलो ना. यू कैन टेक दैट. इसको नहीं, कुछ नहीं करना. लूप आपको इंटरलॉक करना है ना, तो ये लूप से निकालना है आपको. लूप से निकालो बस. फिर इसको खींचो, ये लॉक हो गया. लॉक हो गया. अभी क्या? अभी कुछ नहीं. कंटिन्यूस इंटरलॉकिंग में क्या करना होता है? सी आई जस्ट शो यू. मेरा ये वाला लॉक हो गया. आई कांट. ओके, हाँ सर. यस.
Because you all will get time after we finish.
Yes, yes.
The kit will be here only. You all can keep practicing afterwards.
So this is the loop.
Seat low, then you can practice.
लूप में से बाहर निकालना है. ये लॉक हो गया. सो इंटरलॉकिंग भी ले सकते हैं. व्हेन यू क्लोज aponeurosis, external oblique aponeurosis and all. For that you take interlocking sutures. Just
these are more hard.
Yeah. देखो, सो देयर इज अ डिफरेंस. क्लोज कैसे करना है? आई विल शो यू क्लोज कैसे करना है.
मतलब ये वाला कंटिन्यूस था.
ये वाला कंटिन्यूस था बट नॉट इंटरलॉकिंग. दिस इज आल्सो कंटिन्यूस बट दिस इज कंटिन्यूस इंटरलॉकिंग. ओके, तो द थिंग इज कि वन ऑफ योर असिस्टेंट हैज टू पुल दिस, नहीं तो ऐसा लूज हो जाता है. सो यू नीड एन असिस्टेंट टू पुल दिस. ओके, अभी इफ यू वांट टू क्लोज इट,
दोनों टेल एक साइड नहीं पकड़ सकते. अगर आपको ये अंदर करना है तो ये आप अंदर कैसे कर सकते हैं? लाइक दिस. अरे बहुत अच्छा कर रहे थे, इतना अच्छा कर रहे थे. कुछ नहीं है इसमें. ये लो, देखो आपको कंफ्यूजन बस यहाँ पर है और कुछ कंफ्यूजन नहीं है. बाकी सब बहुत अच्छा है आपका. ऐसे कर रहे हो, यहाँ भी लेके आ रहे हो, सब कुछ अच्छा है. उसके बाद हमने क्या किया, ये जो फिंगर है ना, इससे मैंने छोटे टेल को पकड़ा. व्हाइट वाले टेल को मैंने
immediate medical treatment and transport. This is a dynamic process. Now, based on triage, we are going to classify all our patients into black, red, yellow and green. So these 4 colors you have to remember, which we have got it here in front of us. Which is RPM. So first thing we have to remember are the 4 colors: black, red, yellow, green. And second thing we have to remember is respiratory, pulse and mental status, which is the RPM. So RPM 32 can do. Now what does that mean? What I am writing there? Respiratory rate of 30. So if somebody's respiratory rate is more than 30, then this person is serious. Less than 30, it is not serious. Perfusion, if after pressing my nail, which is pink, it becomes white. And when I release it, again it becomes pink. If it is taking more than 2 seconds, then that is serious. And lastly, mental status. So if I'm talking to somebody, they can talk to me. Mental status is okay. So that's what is the can do. That lift up your hand, and if the person can lift up their hand to your order, that means he can do what you are ordering. So again, this is all that is required in triage. The 4 color codes: black, red, yellow, green. The RPM, respiration, pulse, mental. R30, pulse 2, and mental status is can do. So please remember, And based on this, we classify people into black, immediate, delayed, and minor. Significance of this is minor. If there is a group of injured people, we can tell the minor to move away. So green, we move them away. Dead, we are not going to do anything about it. So it just leaves us red and yellow. So basically we have to classify between red and yellow, because if you have to shift somebody from here to the hospital, you will first shift the red, then the ambulance comes back, then it takes the yellow. So this is what requires priority, that is the immediate. Respiration 30, pulse absent, perfusion present. If the pulse is present, then you don't have to worry, because then things are okay. Mental status can do. So if any of these three things, R, P and M, are abnormal, then the person goes into red category. So in other words, if the victim is there and you can see that his respiration is more than 30, you don't need to check the pulse and mental status. You have already decided that this patient is red. If respiration is all right, then you go to pulse. Respiration, pulse, both are all right, then you go to mental status. So सांस ले रहे हैं, नब्ज देखो और बात करो. अभिषेक, ये वीडियो चलता है? नहीं, उसमें पिछली बार चला था. Okay, that's fine, not a problem. So we have a patient here. Now I think we can start from the back. इधर से ज़्यादा अच्छे से दिख रहा है. Okay, from the back corner most view. Patient says he cannot move or feel his legs. Respiration 26, pulse 110, awake and oriented. What category will you give him? Red. Why red? Any problem with the R?
Respiration is 26. This is more than.
It's not more than 30. It's less than 30.
Yeah, sure.
So respiration is all right. Pulse is felt.
Yeah.
So pulse is fine. He is awake and oriented. Yeah. That is also fine.
Yeah.
Then why do you want to give him red? Abhishek, वो वीडियो चल रही थी बस वाली.
Yellow.
Okay.
So we can give a yellow color.
You will give a
yellow color.
Yellow color. Why not green?
So because it's
okay.
Tachycardia.
So green are the people who can walk. So when I go to a trauma scenario, I say anyone please get up and walk. So anybody who can get up and walk is green. So this is, you are right, yellow. Next.
Red, RPM 30, more than 30.
Yeah, so respiration is more than 30, so immediately red. We don't have to worry about the rest. So that's red. Next, we come this side. Yeah, you last seat. Yeah.
So respiration.
Respiration 22, pulse 24, he is awake and crying. What criteria?
Yellow, green. Green.
Why not yellow?
Yellow. He's awake, alert
and he can walk.
Walk, yes sir.
Correct. Next, hand over. और आगे आप बोलोगे next.
Let me make a wild guess.
Patient is face down, not breathing, weak carotid, unresponsive. What would you do first? So
this
question for you is, what will you do?
First will be to turn the patient.
Yeah.
And then we follow the ABCD of the.
Sure. So first thing would be to turn the patient by log roll. Next, Mike. So what triage is this?
Red.
Red.
Black.
But carotid pulse.
Carotid pulse है ना?
अब क्या करोगे? तो बहुत मुश्किल हो गया ना?
एयरवे सर, एयरवे प्रोटेक्शन तो करूंगा।
वो ब्रीद ही नहीं कर रहा। आप यहाँ पे ट्रायज करने आए हो, आप यहाँ पे पीटीसी करने नहीं आए हो।
सर सीपीआर चालू कर देंगे सर।
और बाकी लोगों को कौन देखेगा फिर? सीपीआर अगला टीम आके करेगा, आप आए हो यहाँ पे ट्रियाजिंग करने के लिए। नाउ दिस इज वेयर इट इज अ वेरी डिफिकल्ट मॉरल सिचुएशन फॉर द पर्सन हु इज डूइंग द ट्रियाजिंग, कि जो ऑलमोस्ट मर गया है उसको बचाना है कि जो अभी नहीं मरा है उसको बचाना है। सो गोइंग बाय द ट्रियाजिंग क्राइटेरिया, दिस कम्स इन ब्लैक। सो यू अटेंड टू रेड, अटेंड टू येलो, देन if you have time, then you come back and see अगर अब भी कुछ हो रहा है तो CPR करोगे। Because अगर आप CPR में अटक गए तो अटक गए ना, फिर तो बाकी का तो कोई ट्रायज ही नहीं कर सकता। So in summary, triaging is identifying the red, initial management is ABC, then go back to yellow and black after that. So I think, do we have Nigel online? So can you project? And which mic would be connected to him? It's going through your laptop, so the laptop mic will be connected, no?
Yeah, I'm just starting.
Yeah, so Dr. Nigel is the chief of the PTC Foundation. He is otherwise an orthopedic surgeon, and he is based in UK, and he's done a lot for PTC, its growth and promoting this, and we have the honor to have him here online with us, and he's going to say a few words about the PTC Foundation.
Ravish?
Hi, Nigel, can you hear me? Unmute.
Hey, Nigel.
Hi, can you hear me? This mic is working.
Yeah.
Hi, can you hear me? Okay.
Ravish?
So we're just projecting you onto the screen. And we probably would be having more courses with the help of Nitin at Mumbai. Duplicate screen. Yeah. Duplicate screen. इसका ऑडियो ऑन है, then I'll put the mic here. Let's see if this works. How do we make him go? Are you on mute by any chance, Nigel? Yeah, we're just raising the volume. Can you speak now?
Yes, we can.
Yeah, we can hear you. We're trying to get the audio up.
Navi, you put you're on speaker. Listen. Thank you. No, we could hear him. Do you want me to keep speaking so you can test it?
Nigel, just wait. I think this is just trying to sort out the technical glitch here.
No worries, no problem.
Yeah, okay, fine. You carry on, Nigel.
All right. Okay. Just give me a thumbs up. Can you hear me okay? Okay, cool. All right. Well, welcome everyone. I see that you're about halfway through your course, and I'm delighted that you're all able to attend this. And thank you for giving me the opportunity to welcome you. You're sitting in a lovely warm part of the world, and it's pretty cold, wet and windy over here. So enjoy where you are. So I have the dubious honour of being the medical director of the Primary Trauma Care Foundation, and I was the chair until very recently. And so I'm going to tell you a little bit of why you're doing what you're doing today. So trauma is what I call the forgotten pandemic. And the reason for this is there are 5 to 6 million people who die from trauma-related deaths every year. And that's more than all the people who die from all contagious disease every year. See, if you add HIV, TB, malaria, and COVID-19 together, the number of people who die from those do not come close to the people who die as a result of injury. And this is largely forgotten. And we concentrate on the deaths, but as many of you are aware, there are many more people who are injured and disabled. And there are 40 million people who get permanently disabled and 150 million who get temporarily disabled every year. And that has a massive impact on global GDP. In my country, that may go up to about 2% of GDP. But in many countries around the world, particularly low-income countries, it could be 10 times that, up to 30% of GDP. And that's a big problem. Now, the issue is that when you start to talk about those numbers, people tend to what we call zone out. Because the numbers are so great, people do not really take them in. So let's put it into perspective. We're talking about the death of the entire population of Ireland every year, year on year. And we're talking about the entire population of Central and Northern South America becoming disabled every year, year on year. And the issue is that trauma is the leading cause of death in the 5 to 30 age group globally. And the vast majority of the globe lives in a country where the population is under the age of 35. So you're affecting the working population of the country. And as we've said, we concentrate on the deaths, but for every death, there are 97 people who are not working. Now, there was a beautiful study done by the Vancouver group in Uganda with the University of Macquarie, looking at the results of a simple closed tibial fracture. So a fracture of the tibia that does not come through the skin. In my country, if you have a simple closed tibial fracture, you would expect to be back at work within 6 to 8 weeks. In Uganda, you have a simple closed tibial fracture, a working age man will take up to 18 months to get back to work. Within 6 months, their children are out of school because they're having to earn money to keep the family alive. And within 12 months, that family is destitute. That's a problem. The other problem is that before COVID, injury, there were twice as many people who died from injuries than from contagious disease. Contagious disease got 36% of global healthcare spending, and injury only got 1%. Since COVID, contagious disease is getting over 60% of global healthcare funding, and injury, trauma, is getting proportionately less. Now, as you know from where you live, most of that trauma happens where most people live. And if you look at these bubbles, you can see where the population of the world is presently. And you are well aware where you are that you live in an area with an incredibly dense population that is growing. And it will continue to grow probably for the next 20 years or so. But over the next 20 or 30 years, those red bubbles are actually going to reduce in size. And it's the blue bubbles in Africa that are going to dramatically increase, while the yellow and green bubbles also decrease. And we need to think about how we train people to meet this growing population. And that's another topic that I can talk about and bore you at another time. Now, we know that what you're doing at the moment is incredibly cost effective. What you're doing right now is 135 times more cost effective in terms of life years gained for those people who are affected by injury than giving antiretrovirals for HIV. That's not to say that giving antiretrovirals is a bad thing, but what you're doing is considerably more cost effective. We also know that if we train you properly, we can prevent half of all deaths and a third of all disabilities by getting that training correct. And that's why what you're doing is so important. Now, in high-income countries, and you may well have heard of Advanced Trauma Life Support, ATLS. ATLS was instituted in 1976 in the United States and is now the standard of care in all high-income countries. The ABCDE that you're learning came from ATLS and is now fully accepted as the way of doing things. The problem with ATLS is it's expensive. It costs about $1,000 to attend a course, and it's quite didactic. You are expected for the patient to go into a CT scanner, and many countries around the world don't have CT scanners. They don't have blood warmers. They don't even have blood. So that's where what you're doing comes in. Primary trauma care and the PTC course is effectively ATLS, the ABCDE, for low resource settings. And what you're learning is recognized by all of these organizations, including the World Health Organization, Médecins Sans Frontières, and all those other organizations you can see on the screen. And what's so special about it? Well, it's considerably cheaper, if not free, compared to ATLS. We don't depend on equipment. We use what is available, and we work within your skill levels using local faculty, local instructors, as you have had, training people so that you can immediately cascade that course. Everything you're doing is freely available on our website. So you can go onto the website, primarytraumacare.org, and download everything that you want to learn that you have been doing in the last day and will do tomorrow. So as you have started to do, this is the traditional way of doing things, what we call a 2-on-2 or 5-day sandwich. So you attend a 2-day course where 20 to 24 people come in and are trained in PTC. During that course, 10 or 12 people are selected or pre-selected to become instructors, and on day 3 learn how to teach the course. On day 4 and day 5, those new instructors now become the people running the course, with another 20 to 24 people coming in. So by the end of that time, we've got about 40 people, 40 to 48 new trained people in PTC, with 10 to 12 new instructors. And you can cascade that course out, which is what Aaron and the team have done so successfully in India. Now, we know for many of you that attending a 2, 3, or 5-day training course is extremely difficult. And that is true in every country in the world. And so you can go online and you can do this in a modular fashion. There are 10 modules, each of the modules taking 1 to 2 hours, so that you could run this training at the same time every week over 10 weeks and do 1 module every week, and at the end of that time, be fully trained. We've also spent the last 18 months digitizing the course. So everything that you have just learned, if you go onto Appropedia and Google PTC Appropedia, all the course content is there and freely downloadable for you to search and look at. And we've been doing that with an organization called the Intuitive Foundation with our help from friends from Amadisc. And all these training programs are now being uploaded to this new app called Surge Hub from the United Nations, where all training courses that are digitally available will go. And that is a really useful resource. We've been going since 1996. We've just run courses in our 87th country, and we've trained possibly up to 1 million healthcare workers, and that's quite an achievement. And because we're so widespread, although I'm the medical director, we have people who coordinate all of PTC training around the globe and report to me, and I report to our patron, Sir Terence English. Now, there are presently 8 billion people in the world, and 5 billion of them don't have access to surgery, obstetric, trauma, or anaesthetic care. And at last year's World Health Assembly in 2022, there wasn't a single surgical, obstetric, trauma, or anaesthetic topic on the agenda. And that's criminal, that's outrageous. And a lot of us got rather upset about that, and I even wrote an article about it. Now, I sit on the World Health Organization Trauma Committee, which has a crazy name. It's known as GACI, the Global Alliance for Care of the Injured. And they've actually done a lot of good work. And at this year's World Health Assembly, we had 4 items on the agenda that put injury right back at the top of the agenda, which is a great achievement. So things are beginning to get prioritized again properly. But I'm afraid to say that trauma remains the single largest unaddressed global healthcare issue. And what you're doing right now is hopefully helping to make this a subject that we will care for much better, get people, save people's lives, make them productive, and make them contributors to society again. So welcome to the course. At the end of this, you will join the Primary Trauma Care Foundation family when you're joining a very large family from around the world. And as Aaron will tell you and Ravi will attest, now once you become part of that family, you can become an instructor and cascade that course locally, but also do it internationally. So I welcome you to the course. I really hope you're enjoying it. I hope you get a really good outcome from it and have a great time. So I'll end there, and I hope you're having a great time there. And I'm very happy to take any questions, but I'm sure that Arun and Ravi and the team will be able to answer most of the questions far better than I can.
Thanks, Nigel. Thank you very much. As a part of the PTC team, I think me and Arun are really privileged to be associated with it, and I think there are plenty of now the potential instructors coming along our way. I would like to thank Apollo Hospital, and we've got Dr. Nitin here. He's been spearheading the program here, and he's got a extraordinary team who has helped us to get this program run successfully. We've squeezed a lot of material, and they've provided us the phenomenal infrastructure to get this done. So I'm thankful to them. And I also like to acknowledge the Bombay Orthopaedic Society to provide us this platform so that we can grow from here and support the local trauma team. Nitin, you want to say?
No, that's it. Thank you.
Arun?
Thank you all as ever. Thank you, Apollo, as ever. Ravi, Arun, and the Bombay Orthopaedic Society. That's really wonderful that it's working out so well.
Belated Merry Christmas.
Thank you.
Belated Merry Christmas and
Happy New Year from all of us. Thank you very much.
Bye, Nigel. See you
We're
later.
about to give birth to a turkey.
Right. Bye. Bye.
Take care.
just 2 certificates for our lovely volunteers. आप आइए ना. We have Adil Tiwari. Gauravi Tiwari.
Very nice.
Thank you. So yeah, I mean, we've come to the end of the course. We still got practice for suture and knotting. So your MFT certificates are ready outside. So if you want to leave, you can just pick that up and leave. Unless you have anything to say. Tag, sorry. We need the tags back because we recycle it every course. So you can just drop your one, if one of us will just come down and collect the tags. Those who want to practice, you can go and practice. Make sure you take your certificates before you go. Thank you.
सर आप थोड़ा साइड हो जाइए.
और प्लीज वो चेयर पीछे वाली थोड़ी दोनों चेयर्स को अपने पीछे कर दीजिए. Only 1 minute. Yes, ready? Yes, smile all of you. Thank you.
Thank you. Thank you. Thank you very much.